Everybody. Thank you very much for the opportunity to deliver this keynote presentation. My name is Professor Sue Gordon. I'm the Research Director and Founder of ARIA, Aged Care Research and Industry Innovation Australia. I had the pleasure of meeting in my presentation today.
And the group's ambit into global horizons. Together, the team of trustees seek unique achievements. Karma Yogi, Dr. Mattikere Sampanga.
Esteemed guests, participants, as well as the organizing committee of this Asia Pacific Aged Care Hub, under the bannership of the Australian ARIA activity, we are very much honored that we in the Philippines would be given this opportunity to discuss and share our
Let's start. We are live. Good morning, everyone. Welcome to the second day of Asia Pacific Aged Care Hub International Policy Forum. Hope you had a very resourceful day yesterday. And continuing the journey of learning, we will start initially with a message from Mr. Reuben Jacob, who is the Chief Executive Officer and Company Secretary of the Aged Care Research and Industrial Innovation Australia, ARIA. Reuben is a seasoned leader with a unique blend of technical acumen and commercial insight. His diverse experience across private, public, and non-profit sectors has honed strong analytical and problem-solving skills. He has an excellent background in leadership, management, negotiation, relationship building, and networking. So we'll have a small message from Reuben, following which we'll have the initial keynote by Sue Gordon.
Good morning and Vanakkam everyone. My name is Reuben Jacob and I am the Chief Executive Officer of ARIA. It gives me immense pleasure in welcoming you all to the APACH International Policy Forum at Ramaya Medical College in Bengaluru. ARIA is a not-for-profit organization wholly owned by Flinders University and is funded by the Commonwealth Government's Department for Health and Aged Care. We work very closely with the aged care sector, and our mission is to improve aged care workforce capability through evidence, innovation, and technology, and thereby improving care quality. We do that through 4 programs. Our Knowledge and Implementation Hub is a free resource that resides on our website that provides evidence-based information in lay language for everyone. Our Innovator training program trains aged care and more broadly the healthcare workforce. Our Incubator is the aged care partnering program that turns ideas and innovations into good projects and minimum viable products. And we also have a grant program. We are grateful to the Department for Foreign Affairs and Trade for funding this APAC program. It's been an absolute pleasure working with Madan, Angie, Jyoti, and Sue in hosting this program. Late last year, we hosted 15 leaders from India, Indonesia, Malaysia, Philippines, Bangladesh, and Nepal in sharing our learnings from Australia, but equally learning from these leaders in the Asia-Pacific region. While I cannot be there physically with you all for this program, I really look forward to the next couple of days and the inspiring debates and deliberations that go on. And I really look forward to building collaboration and partnerships with you all, both now and into the future. Thank you.
Good morning, everyone. Welcome to the second day of the Asia Pacific Aged Care Hub First International Policy Forum. I would now like to introduce our first keynote speaker for the day, Professor Sue Gordon, who is the Research Director of the Aged Care Research of the Aged Care Research and Industry Innovation Australia, or ARIA. As the Research Director of ARIA, Sue works with aged care providers and the community to optimize aging, aged care, and the effective use of technology to research translation. Professor Sue Gordon brings over 20 years of physiotherapy experience and more than 15 years of academic experience to the role. Her research has involved collaboration with the local government, aged care, and health service providers, and colleagues from other universities. As the research director of ARIA, Professor Sue Gordon has been leading much of the research initiatives, collaborating with the Australian government of the Department of Health and Aged Care and across the aged care industry in Australia. It's my pleasure and privilege to welcome Professor Sue Gordon to deliver a keynote. Sue has recorded her keynote for today, and she's also will be available online if you have any questions later on.
Good morning, everybody. Thank you very much for the opportunity to deliver this keynote presentation. My name is Professor Sue Gordon. I'm the Research Director and Founder of ARIA, Aged Care Research and Industry Innovation Australia. I had the pleasure of meeting many of the APAC members when they were here in Australia last year. I'm sorry not to be able to be there with you, but I hope that this presentation will provide some interesting information about the Australian context. I'd like to begin my presentation today by acknowledging that I come to you from the lands of the Kaurna people and pay my respects to their elders past, present and emerging, and acknowledge the great deal of care that they take of their elders. In this presentation, I'd like to talk about aged care services in Australia today, to give particularly those of you who weren't able to join us last year a context of what the Australian aged care system looks like. I'd like to talk about some of the things that are changing and that we're having to respond to in the Australian context, and I'm aware that the things that we're having to respond to are things that other countries globally are having to respond to. I'd like to talk about links between aged care and industry and the great need for us to be innovating and using technology. And I'd like to talk about some of the opportunities and challenges across these three items. And I think we'll find there are many commonalities as we go through the present. This is a diagram that describes the aged care ecosystem in Australia. And it has really developed over the last 30 years, and there have been national reviews of the aged care system annually during that time. Aged care in Australia is federally funded, and it is a very consistent and regulated governance and compliance system that we have. It follows mostly a traditional medical model for clinical care, but that is changing. The understanding of the importance of biopsychosocial models of care, and that clinical care is the foundation, but it is not actually what makes somebody's life a good life. And so we do have changing emphasis in the way that aged care is being delivered. So if you take a look at this diagram, you'll see to the left, living at home. And increasingly, Australians are making it very, very clear that they want to live at home as they age. They want to stay in their own homes. And the federal government has committed to providing greater funding so that people can stay at home. So things like home help, cleaning, gardening, shopping, nursing care, allied health services can all be provided into the home. And where needed, where people are no longer able to drive, transport can be provided, and respite care for particular family carers actually need a break sometimes, particularly when there is a high level of dependency. So again, this is the federal government assesses somebody, works out what they need, and then funds them accordingly. These services are means tested, so for those who have the means to access services independently, then financial means, then that is certainly the way that it goes. But for those who can't afford services, the government will actually provide services. As people age in Australia, and perhaps they're finding that the house is too large, the garden's too big, they often choose to buy into retirement living villages. And there are different models of villages, but it's basically a place where a whole lot of people who are elderly live together. They're often gated communities. Sometimes they're individual dwellings, sometimes they are multi-storey buildings, but there are extra services that are provided to help build a community in these retirement living villages or spaces. And they might be meeting spaces. They'll often have a hairdresser on site, food outlets, recreation facilities that people use and can build a new community in these retirement living spaces. And of course, sometimes, unfortunately, people do go down that slippery slope of functional decline and then need greater care. And this is where service departments and low-level care come in. And so, again, this might be the type of facility where there is still independence in most activities, but perhaps meals might be provided. In retirement living, people tend to still cook their own meals. So you're getting, in those low-level care, you're getting more services provided, more personal care provided. As functional decline increases, people then go into high-level care. And we're seeing this particularly for three groups of people. Two are listed: dementia care, palliative care, but also for disability, particularly where people have an existing disability that they've had throughout their life, and as they age, it becomes more incapacitating for them. And so this is the sort of journey that people may have as they age. And of course, we still have a lot of people that stay at home until they pass, and some who pass at retirement living. But these are the stages that are available and supported by the federal government. What Australia is wanting to achieve with its aged care sector and is striving for is quality services and care for older Australians, just as every country in the world wants, and capable and flexible workforce, which is not as easy as it sounds. We desperately need to have the right workforce, and I think with the increasing number of older people, increasing need for services, this is one of the things that is difficult globally to respond to. We need efficiency in the delivery of those aged care services because we do have such a thin workforce. It has to be efficient, it has to be effective. And we need growth and new models of business that respond to these increasing needs. And increasingly, we're looking towards technology to support better provision of care. There are changes happening. And one of the things that we are seeing a lot is this increasing complexity of client presentation. And think back to the slide I had of the aged care ecosystem in Australia. We're getting increasing complexity in the community, but we're also getting increasing complexity in residential aged care. Some of the figures show us that in residential aged care, that people who have established dementia, more than 50% of them also have a mental health issue, which exacerbates the presentation of their dementia. And so we're seeing, because people are living longer, more comorbidities, and so greater severity in their presentations. Polypharmacy is a problem, and there are lots of projects, and in fact ARIA has funded some, that are looking at how you manage polypharmacy better. How can we make sure that this is not contributing to people's behaviours and lack of function? And frailty, of course, is an issue. And responding to diversity, which here in Australia is really important. And if I talk perhaps to end-of-life and palliative care as an example, that there's increasing demand for person-centred and culturally appropriate end-of-life care. So in Australia, we have over 127 different nationalities residing, and so it's a very mixed culture and very, very diverse needs around care at any time, but particularly around end-of-life and palliative care. So what we're trying to do here at ARIA is to promote best practice and high quality care and services, and taking very much the perspective of improving the capability of the aged care workforce. So why do we have all these major challenges with workforce? The Committee for Economic Development of Australia, called CEDA, has reported that the number of direct care workers is now 30,000 to 35,000 a year short of what we need. Australia's total aged care workforce is about 360,000, but about 65,000 workers are leaving the sector each year. And you have to say, well, why is that happening? It's happening for many reasons. Some of it is burnout. It's a tough job providing care. And one of the other things has been that particularly during COVID, where Australia didn't have any immigration, countries didn't have that mobility, and our workforce in aged care is very much reliant on our immigrant workforce. And so that's actually made quite a difference. So that 35% of the workforce is actually from cultural and linguistic diversity. English is a second language. So we have lost, that workforce. The other thing is that the workforce has not been well paid. And in the last 6 months, the Fair Work Commission in Australia has granted 25% increase in pay for aged care workforce, which is just great, because previously it's been the aged care workforce or the aged care sector has been competing with disability and acute care, and so they've been paying more. So there's been a bleed of aged care workforce into other areas of the care economy, what we call the care economy in Australia. There's a lot of challenges around workforce reform and regulations. We have new aged care quality standards. We have new requirements around nursing hours and minutes. And this increase in compliance has actually changed the type of work that people do who are working in aged care. There's increased reporting. And so there's a lack of skills and confidence to actually support these changes on an ongoing basis. I've provided on the slide some of the figures that were published a few years ago now, but it gives you an idea of how many people have said that they intend to quit aged care. And so there needs to be some changes around the culture of aged care, about how we value and respect people working in aged care in order for better retention rates in the sector. We, as I said, have enormous system changes going on at the moment. We had a Royal Commission which that resulted in $17.7 billion of federal government money being put into the aged care sector for these 5 pillars over 5 years to really start to address the things that were a problem in terms of workforce is one of them, but governance. The residential aged care quality and safety, which are the standards by which people are assessed, aged care provider organisations are assessed, residential aged care services and sustainability, and home care. So you can see there's a massive change agenda happening to help us meet those 4 criteria that we really want for aged care. Now, where does ARIA fit in all of this? So ARIA did a 6-month consultancy nationally and said to the aged care sector, what do you need to be able to put evidence into practice within your organisation? but also to start adopting and incorporating technology so you can be smarter. What does your workforce need and how do we help you to do this? And they said resoundingly that they needed access to the evidence and they needed to understand the evidence, because it's one thing to have the evidence and pass somebody an academic paper. They don't necessarily understand the p-values or the contextualisation of that information. And we have responded to that by providing a knowledge and implementation hub, which takes grey literature and academic literature and delivers that in Year 10 language. It's available from our website for everybody. They said they also needed increased capability and capacity to actually implement change. And so we've developed an innovative training program that does that very thing. And they also said, we'd really like to be involved in the co-design of technology. We have a lot of people coming to us with technology that's not actually fit for purpose for what we need. So we'd like to co-design it. And we'd actually like to be able to trial it when it's actually developed. And this is where the Aged Care Partnering Program comes in. Wrapped around this, we meet with government on a regular basis to help inform policy and to advocate for change, other change. And we also fund grants. So this is where we sit as a very unique role within the aged care sector. This is just a few slides to show you what our knowledge and implementation hub resources look like. It's freely available to everybody. So please hop on, take a look, and hopefully some of the resources there will be helpful for you in understanding what the research and grey literature is actually telling us about what best practice is. And you'll find that the topics that are covered there are the topics that the aged care sector said were most important to them here in Australia. Our innovative training program it's one thing to know what you should be doing. It's one thing to know what the research actually says. It's another thing to be able to implement it. And what we've found is those skills in understanding what the best evidence is, how to contextualise it for your setting, for your population, then to understand change management and how to implement that change are really actually not common skills. We tend to teach people about clinical skills. We don't teach them how to implement change terribly effectively. And so our innovative training program is all about that, having a local solution that you've developed and you've got an implementation plan for it. And so this is what we do. We travel around the country doing this with organisations but also with individuals, upskilling individuals and upskilling organisations. Been pretty good outcomes. We have an aged care partnering program, and the green arrows are what the aged care sector has told us they want to be involved in. They want to be involved in the ideation of technology. They want it to be co-designed so it's fit for purpose. They're not really that interested in the development and the implementation, but when it comes to actually trialling it and commercialisation, that's where they actually want to be involved. And so we help put together industry technology with aged care providers so we are getting the development of fit for purpose resources. So alongside the things that we do, the other thing that's happening is the increasing and changing expectations of clients. We've got an emerging market. The demography of older people, the family care units are changing. I know it's the same in your countries. Changing needs and wants. And they don't necessarily want to buy something from aged care services. They want to actually have greater choice. And for many of them in Australia, because we brought in superannuation back in the 80s, and many people now are retiring with enough money to pay for their own services. So they want flexibility in where their services are purchased. And this group of people are increasingly tech savvy. They are the digital natives who actually were the ones who had Space Invaders, for those of you who remember Space Invaders. They are actually into gamification, so actually using gamification And as Arnold Schwarzenegger says, I'm addicted to exercising. So gamification is one of the things that people are exploring around how you make people more active and keep them healthier. And this is the group of independent thinkers, the Vietnam protesters. They are more into self-management of their health, and they actually want a user experience, not just a service. So the great challenge for us is how do we get the right services to the right people at the right time, in the right place, when we have a diminishing workforce and increasing needs and wants of the older person. And so leveraging technology is really important, and we do have a more technology-savvy older Australian coming through, but we also need a technology-literate workforce. We need to have organisational infrastructure, and we have great opportunity to change the way that we do things. We only have to think about drones delivering food, delivering drugs. We only have to think about virtual care, robotics, and so AI. So there is so much that is happening, and we've adopted some things, but I think we've been a little bit slower than perhaps we needed to be. And what we often see is that there is a conventional one technology framework, and what we need to do is move to a holistic approach where we combine the various technologies to provide services. And so there is opportunity for us to do that better. And I guess this is, I think, a good example is re-ablement in the home. So tele-rehabilitation is an established telehealth approach. It relies on stable technology, clinician-patient video conferencing, online and pre-recorded instructions. But I think that if we think about how we can use this and how we might bring therapeutic robotics into this, how we might use AI to change somebody's program as they need it, that we have massive opportunity to deliver services in a different way. I'll leave you with that, and thank you very much for your time.
Thank you, Sue, for that wonderful lecture. Dr. Sue, if you're online, could you please unmute so that we can hear you comment and add to what you have already said?
Good morning, Dr. Nanda. I'm very happy to be with you today. Thank you.
Good morning, Sue. It's a pleasure having you here at the APAC, and we would love to hear from you in person online. Please go on.
I guess my presentation tried to set the scene about what is going on in Australia, and I know there are lots of commonalities around that. We know we've all got increasing older people with greater complexity and severity of presentation, and I think we're all grappling with the issue of workforce as well. So I'd be happy to take any questions if anybody has some.
Okay, if there are any questions, either from the offline audience or from online, we can take a quick question for Sue. Any questions? We have Dr. Shalini Pradeep, who's the Associate Dean of International Medical School. She has a question.
Dr. Sue, thank you for your presentation. It is quite vast and extensive, but I don't know how much of it in the Indian context can be applicable. We have the families in their homes, with the senior citizens. Is it possible for us to train the family members as caregivers? Is there a scope for such training?
I believe there is. And I'd be interested, I think our Malaysian colleagues can probably talk to, now I think I have this right, that some governments are looking towards actually paying people to stay at home to look after their family members. And I think if you're going to be paying people to stay home and look after family members, you have to support them with education and training about what best care looks like at home. I think that's really important. Here in Australia, we have Dementia Training Australia and Dementia Services Australia that provide great support for family carers. You know, we're lucky to have those resources. It is not easy to care for somebody at home who has advanced dementia. And we find that when people do go into residential aged care, there are two things. It's usually the advanced dementia, or the other thing is incontinence. That is the final deal breaker about whether you can look after your loved one at home. But I agree with you. I do think we need to be looking at really good supports and respite services for people that are looking after their family members at home. The unpaid workforce is essential to aged care in Australia as well.
Thanks, Sue. That was very informative. And in fact, from yesterday, when we are seeing different models of care, I mean, across the spectrum in different contexts, we might have to sort of like take the best of all and try to come up with a locally appropriate and suitable model. So thanks for that wonderful discourse. We will move on to the next keynote address. So I would request Madan to introduce the speaker.
Our second keynote speaker of the day is Meredith Wyse from the Asian Development Bank. Meredith Wyse specializes in aging and care. She has extensive experience working in the Asia-Pacific region on issues related to adaptations to population aging and older persons, with specific focus on long-term care systems. Prior to joining the Asian Development Bank, Meredith worked for HelpAge International in a range of senior management roles, where she worked on initiatives related to social protection, community development, health care, and humanitarian responses. Meredith is joining us from our Philippines node, and welcome, Meredith. Over to you.
Thank you so much. Can you hear me?
Yes, we can.
Yes. Okay. Well, firstly, thank you so much for the invitation. I'm actually currently sitting in Thailand, but I really would like to extend my thanks to the Philippine invitation to join this session. I'm going to spend about 15 minutes or so talking about some of Asian Development Bank's experience in developing long-term care across the region, with a real focus on the home and community-based services. Yes, I was listening to with a lot of interest to yesterday's discussion, and I think this key point has been reiterated again and again, that the real challenge in the region is the gap between policies and implementation. I'll reiterate that. Asian Development Bank has been working in this area for about the last sort of decade or so, and our experience really started in China. Well, obviously there's a huge demand for this given the population demographics and the huge rural and urban migration. And again, the request from the government in China was that the policies were there, and very clear policies and policy direction, but the implementation at local level from provincial to municipalities was missing. And so over the last sort of decade or so, we've been working with a number of provinces and municipalities, really in taking the policies through to implementation. Some of the key sort of questions we were asked by the national government was really to help define what's the role of government, the role of private sector, civil societies, and the families. And in the policies from the national level, they had indicated a major role for the private sector in the development of the long-term care system in China. But much of the work has been done around the incentives and the regulations and the regulatory mechanisms to require a sort of effective development of the private sector, and really looking at how we can get services to low and middle income persons. So I've been with ADB for about the last 5 or 6 years, and I really joined with this regional TA, which was taking some of our experience from China, but then looking based on demand from our clients, which tend to be the governments, as to how to develop and strengthen long-term care in a range of countries. And our first sort of regional technical assistance was based at the national level, and this was really a sort of a diagnostic process, of which all the diagnostics are online if you were interested, and then a series of sort of capacity building at the national level for a range of stakeholders. And when we took this approach, we really sort of emphasized in building the systems, and there needs to be a building block approach. And, you know, we could look at human resources and services, but we also really needed to look at the regulatory mechanisms, the governance, the financing systems, and the information systems, and that these building blocks needed to be coordinated and aligned to really develop a long-term care system. Resulting from that, a number of countries developed sort of guidelines or strategic plans. Tonga and Mongolia both had strategic plans to sort of outline the development of long-term care for the next 5 years. And in Indonesia, the input was used for guidelines into the National Strategy on Aging. One of the key benefits of this process was really to develop a consensus around the vision and the principles for care in each country. And that was a really, really important process to help define how care would be developed. Following that project, the request we then got from the governments in various countries was, okay, we have our vision and principles, but how do we really implement this at the community level? Most of these countries have really emphasized home and community care service development, with residential care for the most needy. And so our focus over the last 3 or 4 years has really been on what is a sort of an integrated community care model that could work in hugely diverse countries and hugely diverse contexts. And so the request has been to develop affordable, effective, sustainable models to provide quality-based care. A number of these pilots have been running for about 2 or 3 years now, and we're just coming to the stage of evaluation, and we're at a number of regional learning events between these countries. I'm just going to illustrate from a couple of these pilots. The first one is in Indonesia, again, a very large, very diverse country, and the real request was, you know, what is a model that we can use that it has enough flexibility to be implemented in the huge diversity within the country, that builds on the current assets and systems and capabilities that we have, but also links up and coordinates and provides good quality care. So really at that, we did an assessment, and the real challenge that was identified was really a lack of coordination down at the community level of services. And while there were a number of services sort of on paper, again, when we got down to the community level, they were either sporadic or they weren't coordinated, and older people and their families really had a challenge to navigate these services. So this pilot in Indonesia, we're working in 2 provinces, in Bali and Yogyakarta provinces. These are the provinces with the highest numbers of older people, which is why they're identified, but they're also very, very different from each other. And so there at the community level, we've developed what is called a community care hub. This is really a virtual hub. It's not a physical location, which is staffed by paid staff. And their job is really to coordinate the services for all older people within that community. That's been sort of facilitated by a sort of risk screening process of all older adults, and then a case management and referral system for adults with long-term care needs. That is then supported by care and support services for those people, information referral services for all older persons, and a series of activities on active aging for the population. The other key enabler we have here is the digital management information system. At the moment, that's called Solani. At the moment, that is collecting a lot of data on older persons to really help local and national planning. And we're working with the government at the moment to develop and integrate a digital case management system into that. So this is just an example and some photos of some of the work. Just to really reiterate, integration between the sort of health and social side is key. In these pilot sites, we have a senior case manager from the local primary healthcare, and they really take the referrals from the community care hub as to who is identified as being high risk and follow up with that comprehensive needs assessment. One of the other countries that we're working in, which is very, very different from the Indonesian example, is Mongolia. Mongolia, again, the situation was they did have a number of service providers, but again, it was the same question as like, how can we support NGOs and private sector to really expand their services, and what really are the services that older people and their families need. And so we developed collectively this concept of an active aging hub with 6 sort of core services that would be provided. As a pilot, one of the key areas that we're really looking at is, how can government work effectively with different types of service providers? And so our pilot works with NGOs in the capital city, works with the state-owned Elderly Development Centre at the provincial centre. And of course, Mongolia is hugely diverse, and usually, the population is very sparsely lives throughout the country. And in the real remote areas, we are developing these active aging hubs with a general hospital as the main sort of service provider there. Again, a real focus on health and social integration. And one of the key sort of elements or key principles behind this pilot, again, it's about a mixed source of funding. So how do we mobilize public and private and CSO funding to really expand these services? So like I said, we're about 2 to 3 years into these pilots, and there has been quite a lot of progress. Some of the key sort of achievements has been the development of capacity building material of these new models of integrated care. There is active screening and case screening across these communities and case finding, and the case management processes are quite well established, and all the sort of the focus on the care foci and associated protocols have been developed. Including one key element or activity that we did in both countries, which was really, really useful, was actually a mapping of all the community resources, formal and informal. So service providers, these hubs could actually know who is out there and who can help in providing these services. And that's really helped in the coordination. And a big focus has been on the development of personal care programs. There's still a lot of work in progress on the systems. We've got quite a lot of evidence and experience around the sort of the eligibility and gatekeeping systems, which needs to be formalized. But there's still work to do on quality management and really taking the evidence around the costings and options for financing for moving forward. Just to highlight, one of the key challenges is really on the institutional mechanisms for coordination at local and national level, and really who is responsible for what and how that can be regulated. This is our last sort of big outstanding piece of work going forward. Some of the gaps and challenges, like I said, these are quite sort of small scale pilots. Obviously, as we've developed these services and we've really got to know the communities and the needs of the older people and the family, we really see sort of shortages in some services that are required for effective home and community care. Key shortages are really access to assistive technology, transport services. And again, while we're developing the care and support services for older peoples in their homes or in the centres, whether that's adequate or not is questionable. Both of these pilots, they really do they are aimed at providing that emotional and practical support to the family caregivers, but as just been highlighted in the previous presentation, I do think there's still much more work we can do. The health and social integration is key, but at the moment, the mechanisms for really incentivizing the health providers to continue to engage in this is very much done on goodwill, and we need to sort of include the incentivization. And one key area which I've been sort of is really a key lesson for myself is, as has been highlighted, you know, family care is so important in these countries, but where we see the collapse of family care, it's often because of very complex family situations, and the need to really improve the sort of social work support to help navigate and support those families and strengthen those family links to be able to provide the support to older persons. Again, like I've highlighted, you know, there's still a lot of work to do on the coordination ownership of as these pilots develop into a system, the sustainable financing and the quality management. And just one sort of area that we need to keep an eye on as we go forward is really as these pilots look to scale up based on the evaluations, is really how closely the pilots which are scaled up adhere to some of the core principles that they're based on. For example, both of the pilots I've highlighted do rely on paid care. That was quite a key principle, that caregivers and people working in the system should get paid, supplemented by, of course, families and family care and volunteers. But whether that is going to be adhered to as we go forward is something to be closely monitored. Just a sort of that's an example of a couple of the pilots that we've been doing. This is a recently approved project on integrated care in Tonga. This was approved at the end of last year. Again, this was built on a sort of diagnostic work and then working with the government to support them to develop a clear aged care strategy and action plan. And this project, which we implemented over the next 4 or 5 years, is really focusing on the establishment of community care centres across the archipelago, with one key national hub, which will be able to provide that capacity and support to the sub-hubs across. And that will really develop and support a range of aged care services and programmes, both at the centre and obviously home care and respite care as well. But I just wanted to highlight this really to respond to, I think, Professor Gordon's comment in the last one. One of the key outputs of this project is really on that support to families and as family and family caregivers. So this project is going to pilot a caregiver allowance for family caregivers. And that access to that caregiver allowance will be based on the family caregivers having received some training. This will also look at some of those key elements which perhaps missing out of the pilot, and really look at home modification assistance, assistive technology, ancillary supplies, especially for incontinence, which again has been highlighted, those counselling services, and again, an interesting programme on gender equity and the importance of care for all. Just some of the other work that we've been doing on community-based care, which I think might be interesting, and we're really looking forward to working with, we're always looking for partners and experts to work with. We've been running a number of events. This one was held last December. We invited 9 countries to come to Chiang Mai, really to learn from the excellent work that's been happening in Thailand, but also to look at the pilots that we've been developing and really work out how we can actually scale up on them. Financing is absolutely key. So we've also been working on hosting masterclasses on long-term care financing. I think one of the key elements was here of successful was actually getting the Ministries of Finance to join these regional masterclass and really taking them through the whole long-term care financing cycle, again with action plans to be followed up in each country. The other key element, obviously, we do have knowledge, and the production of knowledge is absolutely key, especially for this very sort of fast emerging area. Please do have a look at our website. We have all the diagnostics, the country diagnostics that I've referred to. We do have a number of case studies, including Singapore and Thailand, for people who'd like to learn a little bit more about the systems there, and some technical briefs on areas such as long-term care financing or the governance of financing. I understand my colleague, Aiko, will be joining you later today, so I won't discuss too much, but she's been doing a lot of work really about the data collection and developing the evidence base. We had a major report published just a week or two ago called Aging Well in Asia. And ADB has also been supporting a number of the health and retirement surveys, including in Malaysia, which was published last year as well, but she can talk about that later. So what's next for us? Obviously, there's a lot of work still to be done on building systems in Mongolia. We'll be continuing the work, really looking at the finance, governance and quality management system. We do need to evaluate these pilots, and there's been interest in how to take them up to national programs. So we're working with the government of Indonesia and Mongolia on those plans. And there's increasing interest from a number of new countries in the region to help us to request AD support in this area. Obviously, we can really see that long-term care doesn't sit in a vacuum, and there's huge opportunity to integrate these elements into other sectors, especially affordable housing, urban development, education, of course, and digital finance and health work. Health and care workforce, again, has been highlighted repeatedly, again, with the challenges and the huge opportunities that provides. And we'll continue to work on regional learning and capacity building. So look forward to contacting and working with many of you on that. So if you would like any further information or contact, please do reach out on LinkedIn, or that is my email address. Thank you.
Thanks, Meredith, for that excellent overview of what Asia Development Bank is doing in the region. If there are any quick questions we can have, because we have another 5 minutes in this session, either online you can put in your chat, or offline if there are anyone who needs to ask a question, we can do it for Meredith. Any questions? Okay, I'll ask a question, Meredith. In terms of the Indian context, are there any activities from the ADB which, because we have a huge set of researchers, both offline and online, who are working in the aged care sector, are there any opportunities to join any program that is ongoing, or do you want to initiate? What are the priority areas for India as a country?
Okay, so that's a bit of an echo. That's okay. So actually, I've just come back from India yesterday morning. Very, very quick visit, both to Kerala and then discussing with a number of national stakeholders some of the opportunities and their interest in collaborating with ADB on that. So some interesting feedback. Obviously, the aged care workforce was the key priority that we heard from many of the key ministries. But we were also emphasizing that there is a need to really look at the coordination and the system as well. So whilst there's no program at the moment, we will be looking to develop a program hopefully over the next few months. In terms of, especially on sort of data, my colleague Aiko does have a network of aging researchers, which maybe some of the participants are already engaged with, especially on the LASI and the comparative analysis across countries with some of these health and retirement surveys.
Thank you, Meredith, for that. And with that, we conclude the keynote sessions for today. And in the next few minutes, we will move on to the first panel discussion of the day, clinical geriatrics. I would request the team to set up the place for the discussions. And I have Dr. Suhail and Kejal from Malaysia, who will be the conveners for this. And I would hand over to Suhail to continue the proceedings. Thank you.
Hi everyone, good morning and good afternoon. Can I just check the camera?
Oh, can I start it? I'll wait. I'm just introducing. I just introduced online participation. Online participation. $74. That was 5.
All right. Okay. Hi, good morning and good afternoon, everyone. Can I just check if you can hear us clearly from the Malaysian hub?
Yeah, we can hear you clearly.
I hear you here. Sorry, guys, we don't see the Dr. Nanda, sorry, just to check if you can hear us clearly.
Good morning, everyone. I, Dr. Suhail K, Assistant Professor, Department of General Medicine from Ramai Medical College and Hospital, as convener, along with my co-convener, Dr. Kejal McRae, Senior Geriatrician from University of Malay Medical Center in Kuala Lumpur, Malaysia, take this opportunity to welcome you all and to extend a further word of welcome to everyone here this morning for panel discussion session 3 on clinical geriatrics, global challenges and local solutions at APACH International Policy Forum 2024. So it gives me a great pleasure to introduce our chairperson, Dr. Meredith Wyse, ma'am. She is Senior Professor, Practicing Clinician and Geriatrician, Dean Academics, ROAS. Please open the desk, ma'am. Our co-chairperson, Dr. Shalini Pradeep, ma'am, former Professor, Department of Community Medicine, Associate Dean, current Associate Dean of Ramai International Medical School. Welcome, ma'am. It also gives me immense pleasure to call upon our panelists for today. We have got Dr. Prabha Adhikari, ma'am. She is Professor and HOD, Geriatric Medicine, NAPA Medical College. She has extensive experience and expertise in geriatric medicine, and she has made significant contribution to improving the quality of life in elderly people. Welcome, ma'am. We have got Dr. Pritesh Kiran, Associate Professor, Department of Community Medicine at St. John's Medical College and Research Center in Bangalore. He is recognized for his expertise in medical education and clinical practice. His role likely involves training medical students and healthcare professionals to provide comprehensive care to older adults. Welcome, sir. We have got international panelists too. We have Dr. Bindu Pandey. She is an consultant emergency medicine, serves as an assistant professor and head of the emergency department at Norfolk International Hospital and Medical College. Welcome, ma'am. We have got Dr. Elizabeth Chong, Senior Consultant Geriatrician at Kuala Lumpur Hospital, Ministry of Health. She is an experienced clinician with passion for teaching and currently holds the position of National Lead for Falls Prevention and Orthogeriatrics with the We have last panelist, Reiko Gikawa. She's a senior economist in the ADB Asian Development Bank Economic Research and Development Impact Department. She is the lead author of the Asian Development Policy Report 2024, that is Aging Well in Asia, and the Asian Economic Integration Report 2019-2022, that is Demographic Changes, Productivity, and the Role of Technology. We welcome you, ma'am. Now, I'd like to hand over the session proceeding to our Metha, ma'am, the chairperson. Thank you, ma'am.
Very good morning to all of you, both our delegates offline and the delegates online. At the outset, it's my pleasure, first and foremost, to express my gratitude to all the panelists. Dr. Prabha Adhikari, whom I've been known from the time she's a student. Dr. Pritesh, for a while he decided to be my student. Dr. Shalini, my co-chair, my colleague and friend. Dr. Kejal, we're happy to have you online. Dr. Bindu, Dr. Elizabeth, and Ikaev, most welcome. Let me express my gratitude to you. And my gratitude is specifically because the panelists have taken their time, spent time with this whole idea, a noble idea of disseminating their experience. Knowledge of geriatrics is available everywhere on the net, books, so many seminars happen. But their unique experience is what they will be sharing with all of you today. And that is very valuable. Today, the scenario in the geriatric is that before we go on to the seminar or the discussions as such, there are some key statements which are reminders. Point number one is demographic is galloping. There is no need to panic. The biggest risk factor in dealing with the aged society is the risk factor which is inevitable aging of all living beings on this planet. As of now, we have not succeeded in stopping it nor slowing it down. So the primary objective of looking and viewing at geriatric care is to ensure or try and work towards escalating the quality of life. While we have worked and to increase the number of that's activity, more efforts to go in line of improving the quality of life. If you ask me a question, when do we begin? For the people who have assembled and working for this, begin right away. They're already working. But refine your policies. But for the youngsters, whatever age you are, start working towards that quality right away. For the adults who are taking care of the children, start working right away to get your children to grow healthy. So it means it starts right very early in the life, and I don't want to redefine an arbitrary age. My favorite phrase is catch them young as possible. The geriatric care is spread. It has a big bandwidth. It's an outpatient care, inpatient care, emergency care, preventive care, curative care, and rehabilitative care.
What's more important is the added element of domiciliary care as and when possible. One of the most difficult aspects in caring for the elder is the domiciliary care. How's the landscape today? The scientific landscape. The landscape is such that we have newer assessment tools. We have diagnostic tools to confirm the diseases. We have diagnostic tools to monitor the progress of interventions. There's technology which is again advancing very rapidly. However, the word of caution is, especially in the geriatric segment, we need to use the technology very, very judiciously. We have newer modalities of care interventions. Acute care, chronic care, preventive care, rehabilitative care. Newer modalities, but many times equipment-based modalities. Newer drugs. Some have been tried, of course, before the FDA approval, there's a lot of clinical trial. Yet, the exact effects on the elders is not most comfortably announced, which is why we have to exercise enough caution when we use newer drug modalities. Bottom line is alert observation as to how the older population responds to all these modalities is a must for all healthcare professionals. However, let's remember all these developments across the planet are all cost intensive. And more often than not, we keep arguing, discussing about affordability and access, which cannot be forgotten. Good news in geriatric section, the awareness about geriatrics regarding health aspects or availabilities or access to health or trying to prevent and take care of themselves in spite of the changing socio-economic cultural scenario is good. The awareness is much better than what it was a decade ago. The second thing in the good news which I sense myself is the awareness on part of the decision makers, politicians, governors, NGOs. Lot of decision makers are now aware that yes, they have acknowledged the need to spell out the policies which are going to have a larger benefit and serve larger proportion of the population. That said, we have selected a few topics. Clinical geriatrics is huge, east to west, and therefore we are going to select a few things. We start with how do we assess the geriatrics. The age-old tool of comprehensive geriatric assessment, beautiful. That's the basic every healthcare professional must know and must practice. Over to Dr. Prabha Adhikari, because she will share her experience on how effective, what are the challenges, and how she has overcome these challenges.
Hello, yeah. Regarding comprehensive geriatric assessment and how we can take it to the community. Actually, I have been highly motivated by Dr. Medha Rao, who has been training innumerable doctors in geriatric care, and I also took the training under her, and it was my passion to develop geriatrics in my part of the Karnataka. And we started doing comprehensive geriatric assessment in a geriatric clinic where I was working, that is in Kasturba Medical College. And it was taking at least 30 minutes of our time. And where do we have that much of time? Like if I'm sitting as a physician, I just get about 15 minutes of my time. And if I dedicate 30 minutes for one patient, it would eat away the time for other patients. So dedicated clinic helped us in doing comprehensive geriatric assessment, and the outcome was fantastic because it was only in the first instance we spent 30 minutes or 45 minutes or even 1 hour. But further follow-ups will be just 5 minutes because the patient has told all that the clinician has to know, and we would have got the complete information about the patient. As I moved to start the Department of Geriatrics and MD program, we had the challenge of doing comprehensive geriatric assessment because it's a big volume. So what I did was I trained everybody in the department, including the physiotherapist, social worker, even my attender is able to do comprehensive geriatric assessment, the mini part of it, which just takes 10 minutes. So we start with a mini comprehensive geriatric assessment, which has around 10 components, including social history. And after they do it, then only the patient comes in and the consultant looks at it and then gets into the details of it. And that's why we are able to do it now for every single patient who walks into the OPD, every single patient who's discharged at discharge. Because this has been very, everybody knows what is CGA in my department now. So PGs don't have to worry so much about it, but they look at the parameter and then go into the depth of it. So everybody need not go through the 69 tools that we have for comprehensive geriatric assessment. Whenever it is required, it will be used. Physiotherapist will use higher tools, nutritionist will use higher tools, and our PGs will use higher tools. Our social worker will use higher tools if required only. So that's how we have been able to take CGA to every patient. Even in community camps, we are now able to do it. Because even if my attender can do it, definitely anybody else can also do it. So it's just a set of simple questions which and simple tests. Something like a 1 minute tuck test can be done by anybody and the time can be recorded. Only we need to observe the patient for the gait and other things. But the test can be performed by anybody. So that's how I have managed to do CGA at various settings.
Thank you, Prabha. Just one line. Your inputs are exciting and we'll consolidate it. Dr. Pritesh, can you help us with role of comprehensive geriatric assessment right in the middle of the community, the rural setting?
So I'd like to, at the outset, thank the organizers of this summit for inviting us to share our views as far as what we are doing in geriatrics is concerned. We've been working at St. John's in the field of geriatrics and in the field of community geriatrics. So we've been working actually in both rural and urban communities on the home health side, where we actually provide care, for people, in their own homes who are not able to come across, as well as in old age homes. And in all of these settings, we have been able to use a comprehensive geriatric assessment through a number of ways. One, we've been able to actually train what we call community health workers. So we have people, from the community who have been identified to be part of the program that we're actually running. These are people who are 10 standard or 12 standard pass. And through training them, we have been able to actually do some of the assessments, in various of these settings. The most specialized ones, being undertaken by the postgraduates or, the medical faculty involved in the care of, patients. We have also tried ensuring that this aspect of geriatrics percolates down to the government setup. So we've been part of multiple attempts to be able to train medical officers of primary health centers and to be able to try and initiate what we call the National Program for the Healthcare of the Elderly. This national program was initially proposed in 2010. Unfortunately, it has not gathered much steam and it's not percolated to the primary care level where it's actually truly required. So it's more at the district level. But we have made certain attempts in various states to be able to develop modules for training of medical officers ANMs and ASHA workers who are there at a primary care level, and to be able to try and see if they could also initiate geriatric clinics in their own settings. One of the components they are trained in is to be able to do a CGA, to be able to maintain a health record of the patient, so that the next time around when the patient comes back, they are able to immediately identify in case the patient requires a follow-up in a particular domain, or when is the next time actually that they would possibly require to do a CGA. The last bit is we have come up with what is called the St. John's Geriatrics Center. So this center would be up and running by the end of this year. It's a 150-bedded center on the campus of St. John's. And there are 4 components to it. One of the components is training that we are looking at. And we are looking at a cadre of people that we can train actually through this particular center, including geriatric care assistants. So even caregivers can be trained to perform certain assessments on the home front. It's not that to be able to do certain assessments, patients have to come to the hospital setup. Caregivers also can be trained to be able to look at certain components and pick up warning signs, wherein they are able to actually immediately bring in the patient to the hospital. So in a comprehensive fashion, in case they are taught some of these aspects, whether it be related to nutrition, whether it be related to bowel bladder function, activities of daily living, the orientation of the patient itself. So all of these components, in case caregivers are actually trained to be able to pick up certain components, that is also an equally important aspect of comprehensive geriatric assessment, which is required on the part of the patient and their family. So in a nutshell, I think this is how we have been able to reach out to communities. The biggest challenge being educational levels as well as understanding of the elderly. So what we have tried doing is adapting certain things in the local context. For example, if you actually take the mini mental status examination, many of the components our rural elderly are not able to understand. They may score actually low on the cognitive front in terms of assessment. In fact, that's one of the challenges that the LASI study has actually experienced in terms of trying to pick up cognitive decline. But what we have tried doing in our communities is adapting simple local things. For example, to be able to draw, they may not have ever held a pencil or a pen, but we give them rangoli powder, right, chalk powder, and make them actually just draw a certain shape using rangoli powder to be able to see that they're able to perform something. Or we try and relate to something that is local to them and not necessarily exactly what is there in the necessary assessments. So in this fashion, we have also tried looking at adapting some of the CGA tools for the local context.
Thank you, Dr. Pritesh. It was so very good and informative. He has highlighted the component of training and educating. Very heartening to know that he has drawn in caregivers and even young physician assistants. Are they school dropouts, some 10th and 12th?
Many of them actually. So many of them actually are women, from the local villages who possibly have studied up to 10th or 12th. They've not dropped out, but they didn't pursue education further than that.
So all that is being highlighted by Dr. Pritesh is there is a local solution available depending on the cultural and social conditions at your given place. Delegation of the responsibility is excellently done by both of them. They have expanded the care team, not the established defined care teams, one nutritionist, one physician. They have been locally able to expand. Very good. We note that point. Now we'll come to a little tougher situation and the responsibilities. Dr. Bindu has taken the responsibility of dealing with this difficult situation of CGA in an emergency setting. All this while it was a cool chronic setting. Dr. Bindu, are you here?
Yes, ma'am. Yeah, I'm here. I don't know.
Something about
audible or not? Yeah, I'm here.
Yeah. Can you tell us something about CGA in an emergency setting? Comprehensive geriatric assessment in your experience in an emergency setting.
Yes. It's Dr. Bindu here. I'm from Nepal. So thank you so much. And it's my pleasure to be a part of this program and a panel speaker for providing me an opportunity. So in this changing global demography around the globe, no doubt, it's resulting in older population presenting to emergency department in greater numbers than ever before. So they present with greater urgency and with more care, expecting more care and likely to be admitted to the hospital or re-attend and utilize the greater resources. So in emergency department, older people assessment and management is very complex, and no doubt it's challenging as well because they take more time. It takes more time to evaluate them. CGA itself, it takes minimum of 15 to 30 minutes, like by rule, and it requires specialist skills. So specific challenges such as like chronic illnesses and their functional decline or care strain, which need to be screened for and managed appropriately. So identifying those type of specific frailty syndromes, it can be even more challenging, and it's very complex and critical too. So delivering CGA in emergency department, this time it's it's an evolving era of practice. Now we have to say that it is must. We should follow the comprehensive geriatric assessment in geriatric elderly people in emergency department by making certain tools. It has to be done that way, but unfortunately, or let's say unluckily, we have not been able to produce some kind of short tools till now, and it is and multiple domains like why it is challenging. Let me tell you, the main important thing is that when I was doing MBBS, and like all of us, when we were doing MBBS, we were not taught the way we used to get details history taking of pediatrics and then adult and then gynae ops. We were not taught, or we were not produced that way. We should move on to, or we should learn something from the history taking basis on elderly populations. So I just heard about the CGA when I was doing postgraduate. When I was doing postgraduate, so it is very difficult to produce tool. Even my juniors, medical officers who are working in emergency department with me, when I ask them or when I talk to them about the CGA program, they didn't even, they become surprised. They just wonder, is that is there such a tool of those things? So what I have been thinking and what I have been planning and what I have been already started is, at least I'm giving some orientation to my juniors about comprehensive geriatric assessment in view to not to miss the most important things, most important illnesses, or most important part of the disease that has to be addressed on time, so not to miss the elderly population in emergency department at least. So because of criticality of the patient presenting in emergency department, regardless of age, and we don't have some setup of a pediatric emergency or adult emergency or geriatric emergency. We have not differentiated. We have to treat, we have to see, we have to attend each and every patient in one hall or in one emergency room in my hospital or in the hospital, every hospitals of in my country. So first of all, it would be good if we segregate the place, and if we start doing triage in elderly population as well, like the way we used to triage other age group of the patient who visit in emergency department. So what I have been trying is that I have divided some beds for elderly population, but I just wonder for the 24 hours, I used to get elder population more in number than I used to face like younger population or younger patients in a day. So it is very challenging and it is like very difficult also. But what I want to say, if we train our juniors, at least if we train our juniors, or if we include this comprehensive geriatric assessment tool or history taking in undergraduate or in MBBS level, then it would be a bit difficult to assess those elderly patients in emergency department by our medical officers, even by our interns, so that we could, we will be able to reduce the number of mortality or any kind of, we would not miss the major illnesses. So these are the things, these are the solutions also, and these are the some few things we have been facing here. So it's again policy makers who has to lead, and we are there to support the policy makers by doing practically. Thank you so much.
Thank you so much, Dr. Bindu, for highlighting the specifics of CGA in an emergency setting. The advantage that Dr. Bindu has is emergencies do not follow cultural discrepancies, do not follow social discrepancies across the globe. Emergencies are emergencies everywhere and they are similar. So she has highlighted one point which I can make out is that we can possibly develop a section of CGA called relevant CGA in emergency setting. If everybody agrees, at the end of it, we'll say we'll develop a small training module called relevant CGA in an emergency setting, taking into consideration cardiac respiratory trauma and other and neurological emergencies. Therefore, can I now request Dr. Elizabeth? Elizabeth, are you there? Yeah, thank you. I'm here. Happy to have you, Dr. Elizabeth. Can you please tell me whether it's going to be useful in your opinion to have this kind of module as a training module right from the students who are getting trained?
Thank you so much for inviting the Malaysian team to share a little bit about our experience. So I work as a geriatrician in Malaysia, and CGA is indeed a very beautiful tool, very comprehensive. It just teaches a houseman on how to manage a patient holistically, being physically, psychologically, in terms of mental health. And we also introduce them to how to communicate with families, because there's like a spectrum of things to talk about, and to teach them a little bit about what multidisciplinary care is at a very early stage. So we have actually run a couple of pilot projects in our hospitals, especially in our geriatric ward. So for housemen, we have introduced them to doing a smaller part of CGA, not the one which is comprehensive over 30 minutes, a shorter version like what Dr. Pavita mentioned earlier. Even the attendant can do it, so we thought a houseman would be able to do it. But as we could see, when we introduced it to a houseman at a very early age, let's say in an acute ward, it's a little bit overwhelming for them. They were like learning how to treat diseases, and then they come on with this extra thing that I have to do. I barely learned how to do the initial thing, and there's an extra thing to do. It has come upon to us for acute wards that a houseman found that it is a bit hard for them to manage both. But they will still perform it, and sometimes not so complete in performing them. But I believe that it is actually a very, very good tool for them to learn at a very young age. Because we could tell that when they start managing patients or presenting to us during rounds, they have understanding of the elderly in a more comprehensive way. And they have more thoughts about the patient instead of just looking at the acute problem. But it is really a work in progress because they are more excited about learning about acute management of patients, diseases that can kill the patient immediately, than to talk about a comprehensive geriatric assessment, which to them is a soft skill that takes a longer period of time. So when you talk about a step down ward, things are a little bit easier because the patients are allowed to stay a bit longer. So the household have more time to do this job, so they feel a bit more at ease, and it is done in a bit better manner. And when they can see the improvement of the patients through what they have done in the assessment and how they have helped the patients, they are more willing to participate. But towards the end, we realized we could probably introduce it to the allied health, just like what the team has mentioned earlier. So we introduced it to our nurses, who actually spend more time with the patients, with the multidisciplinary team who come in and off, and the family members as well. We found it actually very useful because they are there more often. They could communicate better. They could get the answers to the assessment easier because they've got longer time spent in work with the patients. So that was a better sort of like thing that we have introduced on top of what a doctor's assessment would be. Saying to introduce it to all general medical wards, it is quite hard because we're always pressurized for beds. So as we know, housemen run on shift levels. They will be running in and out, taking bloods, running around to get investigations. That will never be prioritized. But we do encourage our colleagues to ensure if the patient is very complex and if the geriatric team could not come by to see the patient, they should run a CGA assessment. So quite a few of our colleagues have taken up the idea and have done that before we can get more information on how to manage the patient. But unfortunately, we have also opened a can of worms. So once they do the CGA, they're very excited and fill it all out, then they're stuck. They say, what next? So that is the downside of the whole issue of CGA. They could do the assessment, but the management after that would be something that what they struggle with. So towards the end, I think it is good to introduce at an early level in medical school as suggested, so that they have the idea of what the whole CGA is about and how they go about management. Actually, a lot of it already learned in general medicine is just putting the bits together, which is what they're struggling with. We think that it's good to be exposed at an early stage.
Thank you so much, Dr. Elizabeth. It's very nice to know that all these solutions which are already being practiced very soon will yield the result. I also understand from what we have heard till now that there is a need to expand the geriatric care team. It's not just the professionals. So with reference to the emergency setup, it's now going to be the training module for the geriatrics, which also begins with the training on CGA, will include the team in accident and emergency division of all the hospitals. We're all aware that for the last few decades, this has been an emerging specialty in healthcare system. And now we feel the need so that the golden hour of the benefit for the emergency patients is not missed out. And the accident emergency team, right from the admin till the interns, and will now be included as important stakeholders in the training module, which is going to be disseminated if all the panelists agree to my suggestion. We want to conclude this, but not without the experience of Dr. Aiko Kikawa. Are you here? Yes. Aiko Kikawa, are you here? Yes. Not audible? Yes. Unmute, Aiko. Can you please unmute your system? You're not audible. You're not audible. Chat, you can just read. She's speaking. Are we audible to you? Yes. Yeah. You are not audible to us.
Now I can. Now I can. Can you hear me?
Yes, yes, yes.
Yeah, okay. So,
thank you. Thank you.
You're welcome. You're welcome. And thank you very much for inviting ADB to this panel and to discuss. So I'm probably wearing a different hat. I'm an economist by training, and that our job is to help, health professional argue for how cost effective some of these measures are, and that those are best buy for the policymakers to invest. But sometimes you would want to have some numbers or evidence so that they'll be more convinced and more so. So, for example, we really believe in having a comprehensive assessment as the best buy and also the most cost-efficient ways to support older person aged better. And that the why, because it's a preventative, and that our estimate shows that many of the preventative work that can be done through promoting healthy aging or through some of the initial checkup can really save the health system from not only the health service delivery, but also the out-of-pocket expenses, and moreover, the productivity of the people who care for the elderly. So we've done a number of assessments of that. Actually, this productivity gain from older person as well as the caregivers are large. And that those points really are perhaps more helpful for the medical professionals really to argue for this importance of the comprehensiveness. And I hope I have a chance to introduce to you our recent report that we published, that the Meredith, my colleague Meredith, have just shared. It's just a comprehensiveness of looking at the different aspect of our old person's health, not just perhaps health, but then also on the economic and the living arrangement matters a lot. So we have recently looked at the determinants of some of the well-being, being at the life satisfaction, depression, and many others. And those are highly complex mixture of things that some easy things such as feeling lonely are highly affected by the health or the economic stress. So it's very important to have these comprehensive assessment of well-being, be it health, economics, their work, and also financial preparedness and the family and the social setting being all mapped out so that any of those do not fall out and affect others. And that our research shows that up to about 60% of the people in our region, older person in our ADB's member states, do not go through any of the medical checkup in the last 12 months, 60%, while at least 60% are claiming they have at least one NCD, which we think is more, So it's very important that this importance of having screening or even some initial assessment can really be helpful and also help them also be aware of the current situations. Thank you.
Thank you so much. Thank you so much for your inputs. And I also happened to read those important chapters from your book. And it was very similar to a lot of problems we are facing in India as well. And we understand it's miserable to know that 60% have not had. So what are their challenges? And I think very soon Dr. Pritesh will be able to probably give us some solutions to that. I'll just pass on to Dr. Shalini for the next question.
Taking back from your previous statement regarding the 60% don't get any screening done. So as a primary level of prevention, healthy aging, self-care should be started very early in age, that is from 45 to 50. So let us discuss about the self-care. Dr. Prabha, can you share the self-care points you would like to discuss with the elderly who has a non-communicable disease?
Yeah. 20 years back, I think that would have been a dream because even at community centers, NCDs were not managed effectively. But today, I think it has become a reality. Even our sub-centers are able to manage NCDs, and there's education built in it, and accessibility is there, and our ASHA workers and health workers are able to even take it to bedridden elderly as well. So I feel we have really progressed. Our country has progressed from a time 20 years back. These medications were not available at the diabetes and hypertension, cholesterol and heart medications were not available in primary health centers, and they had to come to the district hospital to access care. But today it is not so. And even if they can't go to the sub-centers, we have generic drugs available all over, and it has really worked very well. Because 20 years back, what I would do is I would have an education module for the elderly on their self-care, and I would certify them if they attended all the classes and answered a few questions, and I would hire them as educators in their own community, and I would pay them 50 rupees for one session of education, and that would really incentivize them, and many would come and take the course, and they would train them in self-glucose monitoring. They would train them in insulin injections. They would give education on diet and exercise, and they would even demonstrate exercises for them in the community. So I think the government is moving towards that, because the sub-centers are really equipped with information, and they have healthy aging component built into it. And I'm very, very happy that we have made that progress.
Dr. Pritesh, your comments on this. Under the MPCVS program, we have the grassroots level workers working on this, but it is not sufficient. So we as a healthcare workforce should join together in helping this. What do you say?
Certainly, I think, what we need to realize, it's just not the health department or the health force that has a role as far as self-care is concerned. Self-care in terms of individuals needs to start early. That I think all of us agree on. And towards this, it needs to be a multi-pronged approach. So very often, we tend to overstrain the already, strained health system. Right, so we speak of the ASHA workers, we speak of the medical officers, but all of them are overburdened as already, in terms of delivering, care and looking at administrative responsibilities. So it's very important to be able to look at other line departments like the education department, departments like Panchayati Raj, rural development, Department of Social Justice. So there are multiple other departments which are able to also participate in this effort of self-care. Just to give you an example of what we have been doing in St. John's, is that we have initiated something called Grama Hiriyara Kendras, right? So Grama Hiriyara Kendras are like Anganwadis, for the elderly, right? So they're like, daycare centers, for children. On a similar note, we have centers, for the elderly, and these are not centers, where elderly come for medical care. So they come in the morning, they say a prayer, they have a glass of milk, they do some exercises. Thereafter, they sit down and just do some meaningful work. They may make paper bags or do some knitting. They just chat with each other, sit down, talk to each other. The component of psychosocial support comes out very strongly here. So what happened was, we started this in 2016 in 3 states of India. It's yet to gather steam as far as Karnataka is concerned. But as far as Karnataka is concerned, our recent effort has been to engage with the Rural Development and Panchayati Raj Ministry. And through the RDPR, there are libraries, being set up in different villages. So we are trying to look at, some sort of a policy where these library spaces can be used by the elderly also to be able to come and spend maybe around 1 to 2 hours of, getting together, sharing and caring for each other, as well as improvement as far as their psychosocial status is concerned. The last bit is from St. John's. We are currently running a 10,000 strong cohort study, which has been started. It's going to be looking at, healthy aging. So we intend to actually recruit around 10,000 people over a period of time and follow them up. All these 10,000 being 40 years and above, and try and identify what we call healthy aging matrices. So it's a study that's going to be prospective and trying to identify various components of healthy aging, including aspects of certain important biomarkers and predictors of healthy aging. And that's what we hope would be very useful in terms of encouraging the youngsters or people in their 40s, starting early in terms of self-care and ensuring that the trajectory as far as aging is changed. Also involving the community themselves. So all our elderly, in our rural areas, before we start our clinics, we have certain training sessions, we have certain, educational sessions for them. And Currently, as such, it has grown to such an extent that people have now started walking groups in the village, right? So our elderly, when they're going for a walk, if they see another elderly person, they say, "Why don't you join us from tomorrow?" And slowly, those kind of numbers are increasing. People seem to be becoming more aware and conscious of preserving health, and this is certainly a move in the right direction.
Thank you, Dr. Pritesh. I think even in the government, there's one daycare center. But as far as I know, there's no screening done there. They just come there, spend their time for a half a day and go back. That is actually socializing, which also improves their mental health. Right? Now, Dr. Bindu, emergencies. Once a person comes to the emergency and he's ready to go back home, do you utilize the opportunity to provide tips on self-care and improve the health outcome? Is it possible? And what are the tips you give them?
Yes, ma'am. Thank you, ma'am. So in emergency department, as we have been talking about the elderly patients or elderly populations, about self-care in emergencies. As per your concern, first of all, self-care means it's about social, it's about spiritual, it's about some chronic illnesses. It comes on some socioeconomic aspect as well, and including the chronic medical problems as well. So what we in our practices, what we have been doing in our emergencies is that the most important thing, what I wanted to highlight is that in recent years, whenever anyone, whenever any of the fellow or any of the patient had some epigastric pain or abdominal pain, they used to think that it is just gastric or something, gastritis or something like that. But now, whenever they have pain, they used to think this may not only the gastritis or gastritis, this may be something else than this kind of heart attack or any other thing like pancreatitis, which may be life-threatening. So they used to come to emergency once they feel like they have some discomfort in their chest or in their abdomen or elsewhere in the bodies or in their head, unusual kind of things. When they feel, they used to come. What I'm emphasizing is that this is the things we used to counsel the patient when they come in emergency department, when we discharge or when we admit the patient. So from the emergency department, what we used to do is we used to counsel and we used to talk to the elderly patient that now you are going home. So these are the life-threatening conditions which could come across you based on their chronic problems or based on their regular medications. For example, whoever is diabetic, we used to explain about the symptoms of hypoglycemia. If they are on some blood thinner medications, we used to explain them about the bleedings. If they encounter or if they see any kind of bleeding, or if patient is on multiple kind of medications, they may land up in hyponatremia or hypokalemia or even hyperkalemia. So we used to address in the base of the medications and in and according to their chronic problems, we used to explain them. We have also developed some kind of tools related to stroke, not everything, related to stroke, related to side effect of those medications they have been taking. We used to give those tools or papers to the patient, if patient could understand, and if patient is very older, and they have some kind of dementia or Alzheimer or anything like that, we would explain and we would give some education to the caretaker as well. So till date or till now, we have been trying to do this kind of things in emergency to make them aware of the caretaker also, and to the patients also, those who can take care of themselves, not only in elderly, to the younger population as well, so that Today's younger population will definitely be the elderly in coming days. So to minimize those things and to minimize mortality before presenting to the hospital, we have been doing these certain things in our setup.
Okay. Thank you, Dr. Bindu. You are talking about the warning symptoms to the people and what about the side effects of medications so that we don't prevent their coming back to the hospital with recurrence of symptoms. Thank you, Doctor. Now, Dr. Elizabeth, what are the challenges you face with housemen who are there, because self-care, unless it is taught to the students during their curriculum, it is difficult, and sometimes some myths and misconceptions also are there, which has to be cleared by the students. So, can you talk about this?
Self-care is not a word that we understand in Malaysia, especially for the elderly. When you retire, culturally, you sit at home and you do nothing. You don't do self-care, and you expect your family. So we got big families, 8 children, so the first son, third daughter, or fifth daughter-in-law will take care of you. There's no reason why you need to learn self-care or do self-care. In addition, they'll tell you everything is digitalized now. If I get out of the house, I can't even pay for my food. I need someone to care for me. So with all this, and talking about our nation, those above 70 are probably not literate. So there are a lot of things that they can't do by themselves. They can't even access the clinic by themselves. They won't understand how to read, how to do things. That is our culture. But over the last 20 years, the tide has changed, obviously, because our aging nation is growing bigger and bigger, and our life expectancy is getting longer. And they realize that they can't really sit around and do nothing. And the children are working longer and longer hours. The families are getting smaller and smaller. There's no one to take care of them. So a lot of things have to be put into place. The first thing is the mindset of the elderly, which is extremely difficult. Those days, the answer would be, ask my children, they'll do all the decision-making. So now we're doing a lot of effort putting into, starting from a school level, you have to have autonomy of your own self, on your own care, on your own health. And including, we have also increased a lot of literacy among our primary care teams. Sitting with us is Dr. Nagamai, one of the family specialists. We've got more than 1,000 primary care clinics in Malaysia, and hundreds of them run not just a clinic to look at health, but also a lot of activities for the elderly where they come by. They have a fun session together, but education as well, to steer each other on among the peers on how to take care of themselves well. The best way is actually prevention, not wait until they're all sickly, having lots of comorbidities and not knowing how to take care of themselves and deal with this. That's what we've been dealing with in the last 20 years. And we do not want to put in that manner. So we're advocating them at an early level before things get serious. On top of that, still with us is also Madam Lily Fu, one of the ladies who's working in NGOs, and NGOs are one of the people that we also engage with who start to educate our elderly who probably did not have a chance to have literacy in their time. And they even run a university for the elderly, which is really great. There are a lot of elderly out there who are actually interested to have more education to help themselves and help those around them. So this is actually a very good platform. We might not be able to do it in our government setting because it costs a lot, but we can engage our NGO colleagues, those who are passionate to be out there to help themselves and help those around them. So I think this is the way forward. We cannot put everything towards the government to get funds and get policies to come by, but they can help each other among themselves. Thank you.
Thank you, Dr. Elizabeth. And Professor Kikawa, in the interest of the time, can you just give us one challenge, how you would think you can disseminate the need for self-care in the public?
Sure, mine can be very short because most of the things are being said, but our report shows that about 40% of older men smokes, and alcohol is also taxing on some of the older person's health. Malnutrition remains quite prevalent among older women, and many people do not even report any of the self-care activities like exercise, sleep, nutrition. So in the policy space, one thing that we are encouraging, especially on preventing risk behavior, is the sin taxes on some of the items that has already been done to a certain extent, but not necessarily on some more progressive one like sugary beverages or others. So those are some of the things that was not highlighted yet during the panel, among the panelists, and can be up for consideration for the governments.
Thank you so much. Thank you so much for honoring the time limit. One, we had two more questions to be answered. One with respect to multidisciplinary and cross-reference in comprehensive geriatric care plan, and also the needs for assisting devices which they need. Quickly, in the interest of time, can you combine the two, Dr. Prabha, and just say whatever is.
Yeah. Hello. Yeah. Generally, the general public thinks a multidisciplinary team is a team of super specialists. They think they have to go to nephrologists, neurologists, cardiologists, like that. But actual multidisciplinary team will be there within the Department of Geriatrics or General Medicine, whatever, because what you require is a physiotherapist, occupational therapist, nutritionist, social worker. This is the multidisciplinary team that we are talking about. We do give referrals for probably acute care or continuum of care, like somebody who needs dialysis will have to go to the nephrologist. Somebody who requires advanced lung support will have to go to the probably a respiratory physiologist, respiratory medicine, like that. So I think a trained physician can deliver entire care to geriatric population with this support team of whatever I was talking about, physiotherapy, nutritionists and other things. And about use of assistive devices, the simplest of devices, walking aids, the spectacles, hearing aids are supposed to be given free of cost to the deserving elderly, but it doesn't happen because it's a very complex process for them. They need to approach the department, give their application, and then they have to come and verify, and they have to get certificates from multiple doctors, and that has really made it very difficult. Now they are getting it through NGOs, the generous donations from Rotary and other clubs and things like that. But still, I announced one camp for assistive devices, and I saw elderly coming with the ordinary branches of a tree as an assistive device, asking for an assistive device, and the government says, okay, we'll take your number, name, we'll supply it. And it happens after maybe 6 months. So we immediately bought some things and gave it to them. They walked miles together to get assistive devices. I feel they should reach the homes of these elderly people whenever it is needed on the recommendation of a doctor or a physiotherapist.
Dr. Preetesh, it is a rapid fire round.
Yeah, so I think, what's very important, like ma'am said, is ensuring that in community settings, the community physicians are trained to be able to identify when to refer. That's one component. They should not refer anything and everything. So the challenge, as far as elderly is concerned, is accessibility, affordability, and availability of healthcare facilities. So one of the bits that we have tried is to ensure the awareness regarding the Ayushman Bharat scheme, the insurance scheme, especially for BPL families, wherein at least healthcare can be accessed up to 5 lakhs by the elderly, and in many centers. The second is also trying to involve multiple departments. So the Panchayat Raj department, in order to be able to give senior cards, to be able to enroll people on the Ayushman Bharat scheme, and also trying to ensure that the policymakers realize that things need to be simplified. So we have been engaging, with the health department for the NPHC program itself to be able to provide some of these assistive devices at a sub-center and a primary health center level. Unfortunately, not yet happened. And also trying to ensure that medical colleges are able to start multidisciplinary services in their rural centers. So in our center at St. John's, we have multiple specialists, coming on different days, wherein a cross-referral is possible in that center itself without the elderly having to go very far. In fact, we have even established a OT facility for cataract surgeries, wherein surgeries are actually happening at the rural center itself, and they are not actually, having to go across to the city or an urban center, which is, very inconveniencing. So
just to respond to Dr. Pritesh, if I may add, when you have this multi-sector specialist coming in to your medical center, this is where you can use technology and use telemedicine. We've done that in Ramaya Medical College. From the rural center to the central hub, we use telemedicine to take care of the patient. But one other point is the super specialists need to be connected better by the primary physician or the geriatrician. Otherwise, they all respect to the depth of knowledge, but the modifications and what is required as geo-specific management, I think the connection between the geriatrician should be highlighted. Quickly moving to Dr. Elizabeth. Dr. Elizabeth?
Yeah, talking about multidisciplinary team in Malaysia.
Very briefly, can you touch on the assistive devices, please? The need for assistive devices and taking care of the patient.
Okay, talking about assistive devices and multidisciplinary care, in Malaysia there is an increased uptake, of course, of students taking up adult health training, like being a multidisciplinary team member. So in many ways, we're still very short being a developing nation. Even though in some areas where we already have the multidisciplinary team, the assistive device could not be obtained as well, which is quite difficult. We have the same issues like you, to refer, walk long miles to get the forms to be submitted, and yet you wait for 6 months. So we are also getting NGOs to help us with all these assistive devices as well. But one of the things that we had problems with our team is, we realized that even though they are trained, let's say as a physiotherapists and occupational therapists, when it comes to meeting an elderly person, they might not be well versed in managing them. For example, we have got an elderly that comes in, referred for physiotherapy due to osteoarthritis, and they're hard of hearing. But if the physiotherapist is not trained that this is an elderly patient that needs more care, they will just give it instructions and the elderly would not understand because they are hard of hearing, and they will just give up on the patient. So that is one of the challenges that we arrive at as well. So we need to start writing some new standard protocols for managing as a multidisciplinary team for the elderly population. On top of that, culturally, the patients like to doctors, when they meet a multidisciplinary team member, they wonder, who are you? Do I follow your instructions? And very much when they come for therapy session, they thought, oh, that is the only sessions they're coming from. They do not go home and follow instructions because it's not something they understand as part of the medical health team. So these are some of the things that we have been encountering in terms of issues.
Yes, thank you. Dr. Bindu, multidisciplinary approach in emergencies, just to multidisciplinary approach with reference.
Sorry, ma'am. Can you please repeat the question?
Multidisciplinary reference. Can you just wind up in 2 sentences?
Multidisciplinary approach in emergency department. Yes, ma'am. It's a very important thing, and it has to be done. It has to be done by all the physicians. They should understand. What I want to say is everyone should understand that multidisciplinary in medical science, multidisciplinary approach is very much important. But it's very sad to say that multidisciplinary approach has not been that actively done in my settings. We have to fight. Yeah, we have to fight for that. This is the thing I have been facing being an emergency physician. Because they want the thing is that the physician, they don't want to lose their patient.
I think
this is the ground reality, man. This is the ground reality.
This is a problem which all of us face, I think, so there are challenges, and we have to learn how to navigate through these challenges.
Yeah, one simple possibility in this context is that minus the intervention prerogatives of all the super specialists, like say the CAT or the dialysis or surgical interventions. Minus that, the indication for the super specialty reference, the medical part of it, I think it's time the geriatrician is well versed with that. So it's the internal physician who's going to have that higher caliber, know the indications, manage till to push the patient to an intervention. So till then the geriatrician can take care. So the expansion of knowledge and confidence in the geriatrician himself or herself has to now go to the higher level, in my personal opinion, so that you bring the dependence down. So now we have, pardon us for rushing through the last two topics, but technology in this would have helped. We can just wind up by saying we can use the technology judiciously in different arms of gero care. Let me start with training. The training part, we have already decided, training of all the stakeholders. The panelists have expanded the list of stakeholders. We have now included the multidisciplinary team, which Dr. Prabha clearly said is not just your colleagues in super specialty departments, but also your helpful team of physiotherapy, nutrition. Pritesh added the physician assistants, which is a new breed in the team. Am I right? And then we also decided that we are going to rope in, especially the accident emergency staff, to be trained in gero care, the basic gero care and the comprehensive assessment. It's really going to be very useful in the emergency setup. Number two, do we now, with everybody's concurrence, decide that there is a dire need to revisit the training modules? We revisit the training modules at different stakeholder levels, and one particular thing is a special small module for super specialists, a special small module for accident emergency physician care. This will be the task at the governance level, and the policy decision makers can decide to develop a task force, in my opinion, if everybody agrees. And the task force will have the responsibility of having subcommittees to develop these different modules. Let it be a centralized one for the country, because that's where you're going to take into consideration the local, cultural, economic, demographic, and social conditions to specify the training module. Let this be edited, and if it becomes time-framed, multidisciplinary, with all the participating countries involved in this seminar, we will have modules coming from every country. Probably a compendium for the Southeast Asia can emerge. This may be sounding like an aspirational goal, but I am convinced it is doable. We can share it with the rest of the world. With a time frame specified, it shouldn't be too late. Let's have the pleasure of seeing the module before I disappear from the face of this planet. I am in the midst of gero age group. That's the goal. That's about the training. Number two, care models. Different guidelines need to be developed. Care models are there for every disease. I agree there are guidelines. Gero guidelines for care models, acute care and follow-up care in NCD. This is to assist not just geriatricians, it's all the family physicians. So care models are also there. Number three, for the technology and assisting devices. Assisting devices, I think there's a very responsible role of the policy decision makers as to how they are going to allocate funds for service. Point number one. In India, we have a scheme called Corporate Social Responsibility, which is well schemed, well implemented for the corporate sector of the country. And there are aspects under that which include popularly the education, agriculture, and things like that. May I suggest to the policy makers, please include under CSR zero assistance. So that's going to help the government to supply these assisting devices, which Prabha had one very clear experience about tree branches and all that. That's pathetic. So that is possible and doable, and I want to strongly suggest it for the policymakers. That's about the assisting devices. Technology will be judiciously used. Rope in the technical experts to help us, especially in the training, social media for training. Another thing which I would suggest to the policymakers at national level is, we've been doing surveys of incidence and prevalence of NCDs. We've done surveys of malnutrition in the country. We've done surveys of economic situation in the elderly, or healthcare accessibility. All that is done. It's now there's a time when we are seeing the progress. It's a happy situation that there is progress at many levels, at the governance level and the public level. Now that we see progress, it's time for the government and the policy makers to start with a new survey model of trying to see the outcome of the interventions, outcome of the training, outcome of the care models, outcome of assessment, outcome of screening, outcome of Ayushman Bharat in India, and so be it in the other countries. What are these surveys and outcomes showing? That will boost the policymakers and the healthcare givers to raise the benchmark in comprehensive geriatric care. With no time left for questions, can I say thank you? Good luck to all of you.
I would apologize to the organizers. We are late by, I think, almost 10 minutes.
No, they gave us 15 minutes.
No, madam. Thanks for the time.
Suhail came and told me to take 15 minutes.
I thank the online participants, panelists as well, and also the participants. And the questions that have been put in the chat box, or if you can communicate, we will reach it to the chair and the other panelists subsequently, and that would be responded to. Thanks a lot for it. And Madan wants to add something.
It's just Dr. Aiko Kigawa from Asian Development Bank has shared a report with us. So we will display the report during the break, and the link is available for all of you to look into. Thanks, Akiko, for sharing that.
Please tell her that we will get back to her about her report.
Yeah. Thank you for that. And Dr. Kikawa will get back to you on the report, and we will share it with the participants as well. So thanks for that, ma'am, and we look forward for the next session. And in the interest of time, we will actually segue into the next panel discussion. So the tea break, those of you who want to have a bio break and a tea break, you can just go out and come back. But we would not delay the next session. So we will start in the next couple of minutes. I'll request the team to arrange the next panel, please.
Are you taking the people identifications related to school?
Recording stopped.
Very honored. And to Sudhir, you take yeah, I think the start of his badge is there. What you So I have a lot of manufacturing complicated lines. Yes, this is surgeon. Last material.
And with 6 countries, 300 plus participants. In just we should 2 minutes of which is going on for all the chairmen. How impromptu this what did they say about patient? Devices. ಅದು ಮುಂದೆ ಹೇಳಿ ಸರ್
Hello everyone, we are going to start the next session because we have online participants who are waiting. So to conduct the panel discussion, I would require Dr. Meghasham Bhatt to come and take over the proceedings. Professor Meghasham.
Thank you very much, Professor Nandakumar, for inviting me as a panel convener for this session. And good morning, distinguished participants. As we reconvene today, let's direct our focus towards the challenges posed by aging population in developing nations. So we understand that in the Asia Pacific region, we'll have 1 in every 4 individuals who will be over 60 by 2050. So there will be significant changes and complexities that may result in these elderly populations. These could include social and cultural shifts, technological integrations, and bridging intergenerational gaps which may be necessary, and also looking at financial considerations and the need to fortify healthcare systems for our vulnerable populations. So to navigate through these intricate challenges, we are honored to have a panel of esteemed experts in this area. Everyone among our panelists wears a different hat, and I'm sure it would be an enriching experience for all of us. And to lead this session, we have our chair, Professor Dr. Shalini Nui, who is the esteemed Dean of RMC. Allow me to briefly introduce our esteemed chair, and this will be followed by the introduction of the panelists. So, Dr. Shalini Nui is the principal and the dean of the Ramaiah Medical College. Dr. Nui has played a pivotal role in shaping the college's academic curriculum and fostering a culture of excellence. Her visionary leadership has led to innovative teaching methods, and Dr. Nui is committed to medical education and also the integrity of research. And as a person who actively promotes community health research and outreach programs to address healthcare challenges, and I feel that she would be the person who would take over and provide us with a very enriching experience which could be shared with our panelists today. So let me introduce our panelists. We have Dr. Vishwanath K, who is a professor of general medicine, Ramaiah Medical College. His comprehensive understanding of internal medicine would result in addressing the healthcare needs of our vulnerable populations. We also have Dr. Ramaiah, who has a strong background in healthcare management, and he is the dean in charge of the Apollo Institute of Health Management, and he has led several strategic collaborative initiatives which focus on holistic development. Then we have Dr. Suman, who is a professor in community medicine, and she has several years of experience in community medicine and also in working with geriatric populations. She has over three funded projects, and she has worked in the area of tuberculosis. And we also have Mrs. Pavitra Reddy, who is the Chief Operating Officer of Vayovikas, and she demonstrates exemplary leadership in the realm of aged care and fragile population support. With a background in healthcare management, Ms. Reddy plays a pivotal role in overseeing operations and strategic initiatives aimed at enhancing the well-being of vulnerable populations. And lastly, we have Professor Raj Singh Shekhawat, who is the Dean of Research, Education, Psychology and Social Work. He is a global citizen at heart, and he is also an internationally renowned TEDx speaker, mentor, an academic, and a scientist. He has a PhD in clinical audiology from the University of Auckland, and he uses brain stimulations and sound therapies for tinnitus management. So he has worked in this area well, and I'm sure that he would share his knowledge also in an impeccable way. Thank you, and I invite all the panelists on the dais, please. Thank you.
Okay, thank you. Thank you, Dr. Meghasham Bhatt, for introducing me and the panelists. And I'm sure we'll have a really interesting and insightful discussion today. As you said, all of them were different hats, and each one's perceptions and each one's expertise would be very valuable to us for providing insight into the issues of elderly in the developing world. So first of all, I would like to ask Dr. Vishwanath, what do you think of how can we integrate geriatric medicine into the medical curriculum? As you know, many of our students are really not sensitized towards the importance of the elderly. Most of them talk about pediatrics or the general adult population. And therefore, although our college, our institution has a geriatric clinic, we do take our students to old age homes. We do encourage them to look after the elderly when we go into the community. It is still not an integral part of the curriculum. So could you throw light on that?
Thank you, madam. At the outset, I thank the organizers for this innovative session. As you rightly said, initially, the geriatric component of medical education was more like, they're just probably senior adults, young adults. That's what, while you probably say, for example, I want to prescribe a drug. Now I used to calculate whatever is needed, creatinine clearance, all those technical parts. But incorporating this specifically medical education, geriatric education into medical education is trying to see that certain curricular components of it are incorporated early at the MBBS levels. So I think the previous talk, madam said, she has an aspiration of creating a module for super specialists. So probably similarly, coming at this end, probably it's MBBS students who start their career to have a good exposure to this component. Probably for the last couple of years, there has been a good shift and probably a positive way I can look into it. It all started when our very own Davidson textbook, it started telling, a disease, then a small bracket, a small box telling what happens in elderly. So that was the beginning. Initially, when we saw in the new edition of Davidson, we were, okay, something is there. So probably they started putting that, explain a disease, then put a small box saying how different is it in elderly. So that was the beginning. Then gradually, I think now with our NMC taking up this competency-based medical education, they have compulsorily included geriatrics as one of the important part where we have to train students. They have specified how many number of hours we have to take, and they have specified the components. Say, for example, there are certain components of geriatrics which has to be taught, certain components of geriatrics which has to be experienced, certain has to be group discussion. So they have, that's I think at a great beginning. Now we are taking classes. The third part is probably clinical rotation, as you mentioned. Now with the more and more probably exposure to students, there is one component called electives. I think you know that. So in electives, it would be surprising that these electives are taken by undergraduate students. Even we were surprised when almost 10 students took geriatrics as electives. So we were happy. We were running that geriatric electives. So I was wondering how many will come. But, the last 2 years, almost 10 students came, and it was a very, at the level of, they are all still in third term or third year, but that means probably, yes, it is happening. This curricular imparting of curriculum or based on probably exposure to geriatrics is definitely going to happen. So I think this has to go on. This has to go on. And postgraduate level, yes, there has been a significant shift where geriatrics is being a lot of importance. So undergraduate level, the postgraduate level, and probably super specialist connect is something that we are looking into further, how it can be taken. So that's, I think, all the three stages we should be looking at.
Thank you. And I think this is really very positive when you mentioned that 10 people took up electives.
Last 2 years, almost 10 students came for geriatric electives. Cardiology elective, of course, had a lot of fresh, 30, 40. Probably the next was geriatric, which means things are percolating at the student level, which is most important, because they are the one who are going to be in the healthcare industry for the next 25, 30 years.
Yes, thank you. So at the same time, Dr. Suman, what are the social determinants which influence older adults' well-being, and also how can they be addressed, these social determinants?
Social determinants. I think for the past, yesterday and today, if we look at the discussions, and also our experience in the field says the first thing I would rate it as economic stability. And then the second one, I would look at it as the family support. How much is the family, whether they are living with their family or away from the family, matters a lot. And then comes their education level. How educated are they in terms of health, and also accessibility to healthcare. Our neighborhoods or our cities, are they geriatric friendly? Right. This will make a lot of difference in terms of their well-being. Just being with the family and supported well helps them a lot. I would still rate the economic stability to be the first one. And to address it, as in the previous panel, I would say it should start very early. Maybe as they put it as active aging, even the economics which they need to plan for it should also start very early, and not when they reach the older age as they group it across.
Yeah, but how can we take this information to the people in low resource settings? I mean, I don't think they have this bandwidth to prepare early for old age.
Yes, and maybe that is where probably our social insurance or our social assistance from the government might play a role in those areas when it comes to a low socioeconomic status. But as far as possible, I think we need to inculcate these habits right from the beginning is what is my opinion.
And I think now that the students are also becoming aware of the elderly and the geriatric care, probably this awareness can be created first among students who will then take it to the community.
Exactly.
Isn't it? Right. Thank you. There's one more important issue among elderly. We have seen that many of them, as you said, the environment in the house is what matters. And many of them are neglected. Many of them either just neglected or actually abused. So how can we talk about, I think Dr. Vishwanath may be able to explain, how can we address these psychological disorders among the elderly? They have a lot of mental health issues.
So I think if I continue with the previous session where they spoke about multidisciplinary approach, as previous discussers said, it is not about involving super specialists or anything. When we say multidisciplinary, this is one important component, that is social support. The nursing staff or the doctors or the social support. That is something, we as physicians, probably as clinicians, we may not look into always every time, because My focus is patient is admitted, probably, yes, I mean, say I'm not wrong, but no, just make sure
the physical aspects.
Illness. But these are something, many times we have seen, they don't get discharged. I think we have seen a couple of patients. Then when we really, look into those aspects, they will say, as soon as I go home, they make me work. Sometimes
so they prefer to stay in the hospital. They prefer to stay in the hospital.
Every day they come up with new complaints. Especially they say, I have giddiness, I can't go. Now, the moment when we try to understand what exactly is happening, then I get the reason. Probably many times my residents get the actual reason. They may not tell me. They will tell, sir, I think evening she told me that as soon as she goes home, she's made to do a lot of work. So then we realized. Probably the next day rounds, I had to tell the attendants, not directly but indirectly, that you need to support her and not, she should take rest. Probably then she got discharged. So these are certain things, it's not very easy, but social support system, I think we have to do it.
Okay.
That is very important.
Thank you. So I think, going forward with this social support system, I request Dr. Ramaya to please let us know about your insight on integrating these practical experiences in aged care management, whether it is physical or mental.
Actually, when we, first of all, thanks the organizers for inviting me here, and kudos to the founder, Dr. Ramaya. I'm here today, and of course, dignitaries on the dais and off the dais, and my Professor Geriatrics-Gobal and all the audience. It's my pleasure to be here. When we talk about, elderly care, and as a management guy, we always talks about the holistic approach. It doesn't matter what, whether it's a physical or mental, but we would like to ensure the physical health as well as the social and emotional and spiritual well-being even, to make the quality of life better for the elderly population. So holistic approach definitely will benefit in providing a quality care to the elderly population. Thank you.
So as you know, WHO has included spirituality, spiritual well-being in their definition of health. So what you said, I think, makes it easier for the elderly to go through life if they have some kind of spiritual belief, some faith. Thank you. And another thing is, can you also tell us how we can use information technology in elderly care in our country, countries like ours, developing countries?
Yeah, right. See, now we are living in an era of IT, internet, and now we are talking about artificial intelligence. Just to add to my previous discussion, in AI generation, we need a double A and double I strategy to deal with elderly care. When I say double A and double I, A is aligning the health systems to the needs of elderly care, and also adopt the technology, and followed by integrate the health systems with the people. And finally, we would like to, when we say IT, first I would like to give a brief information about the IT connectivity in the world. See, we have two worlds where there are some countries like Netherlands, Switzerland, even Norway, with 99% of internet penetration. And also we have the country, I just want to name, not for any other reason, North Korea, 99.9% of the population is not accessible to the internet. Of course, when we talk about the developing countries like India, according to Internet and Mobile Association of India, 52% of the Indian population have the access to internet. And of course, when we take the other developing countries like Afghanistan, let's say South Sudan, and maybe countries like African Republic, and including some of the countries where 80% of the populations are not accessible to the internet. So this is a scenario. So when I talk about the using IT for the providing healthcare, especially to the elderly care, and one of the best example what we have seen after the outbreak of COVID-19, use of telemedicine. So elderly people, by using telemedicine technology, they can go for a virtual consultations and they need not travel. That's number one. And number two, the wearable devices like, heart rate monitoring, and also, of course, trackers, health trackers, and they will give the real-time data to the providers where they can detect the symptoms at the early levels. Definitely, when we detect the symptoms at the early level, it makes us easy to start the treatment as possible as early. So ultimately, it's going to improve the
I think what you say is true for countries, like you said, the countries that have, internet in all areas, whether it's urban or rural, and the population is educated to use it. Whereas in countries like India, where we have, people in rural areas, why not? And even in urban slums, many of the elderly do not have access to, social media, access to telemedicine also. In our experience, we have a telemedicine unit in a rural area where we are, our clinicians are supporting, this telemedicine consultation. And still we have, a smaller number of people who actually want to come to the telemedicine unit because they're still not so comfortable with telemedicine. It's a good start, but it may take some time for countries, developing countries, to really penetrate into the remote areas. Thank you for
Just want to add a quick point here. See, as per the World Health Organization's universal health coverage, by 2021, 4.5 billion people are not covered under essential healthcare. 4.5 billion, out of which about 2 billion people are suffering or facing the financial hardships. And 1 billion people are, they are into, catastrophic out-of-pocket expenditure issues.
Mm-hmm.
That's one. As you said, like Apollo, having 20 years of experience in telehealth, and we have 800 plus telemedicine centers where we provide teleconsultation, teleradiology, telecardiology, etc. And we touched almost, 16.5 million consultations. So this is how we can utilize, and of course some of the latest technologies are definitely useful, but whether the elderly population is able to handle the technology or do they have the knowledge of using such technology is the issue. Thank you.
Thank you. So just taking a cue from that, Dr. Suman, what do you think are the barriers of aged care in countries like ours? This could be one of the barriers.
This is one of the barriers, the education with regard to use of technology. We have extremes here. At one end, you have the higher socioeconomic status people who have access to technology, who are educated, but still find it difficult to adapt to the evolving technologies you have. And at the other end, you have people who do not have access to technology, one, and who are not literate enough to also use it. So this spectrum is too broad for us to really bridge it. At the lower end, you might need assistance for them to even access it. First, assistance to convince them that they require care. That is one of the barriers that we see. The second thing here is accessing it. Mm-hmm. And one more thing I would really stress upon is in our project area, wherever we have gone, whenever we asked our elderly as to why did they not continue to come for the care, I said, I needed support. I needed somebody to take me to that particular place. I cannot travel alone. I am not confident of walking alone. I'm not confident of operating certain things. So simple things like if they want to buy something, they needed money. Now everybody uses ATM. Probably an elderly is not accustomed to go to an ATM and draw money. They are more used to going to a bank, writing something and getting it. So you have a spectrum from this end to the other end where you can do a mobile banking and internet banking, those who are able to do it. Even with them also, they find it difficult when the technology keeps changing and it keeps evolving. So to keep it abreast, I feel these are some of the barriers. Another barrier, what I feel, is the social environment that is there. In some places, there could be certain apathy towards them.
Yes.
Their own interest to take care of themselves.
Yeah, as you said, the family also should support them, isn't it?
So that is one thing which can be a barrier. Another thing is physical accessibility. Simple example, we have high-rise buildings. God forbid, if there's no electricity and there's no lift that is operating, getting a sick elderly from the top floor to the ground floor is a ordeal in itself. So such kind of assistive devices where it is easier for us to bring them down, or even a 2-storied building. You need not have a 10-storied one, or the 3rd floor or the 2nd floor. Bringing them down is an issue. And within the households, I'm sure even in our own households, it won't be geriatric friendly either. There are lots of changes that can be done in the construction of the house where it is more geriatric friendly and where they stay in their own known environment, where, as we call it, as aging in the same place or inside to open. So these are, I feel, are some of the barriers which are there for access for healthcare.
Thank you. Now we have Professor Raj Shekhawat, who is actually quite a specialized field. So can I ask you how we can, what is the role of innovative auditory interventions to enhance the quality of life of these elderly?
Thank you for the wonderful question. Before I come to the question, how many of people sitting here can speak minimum 2 languages? Raise your hands. God, a lot of you, right? Okay. How many of you can speak 3 languages? Raise your hand. Still a lot of, okay. How many of you can speak 5 languages? Raise your hand. Gosh. How many of you can speak 6 languages?
That's the speciality of this country.
Fantastic, right? So I would really encourage all of you to think the fact that you can speak between 3 to 5, 6 languages, it's actually because of your hearing. When a child is born, the child doesn't start speaking straight away. They hear, they listen. And after a year, year and a half, then they start gradually speaking. So our language acquisition, our speech acquisition, it's all hearing dependent. We all are social creatures. Social isolation is extremely, extremely detrimental for everybody's mental health and well-being. And to stay connected with our environment, with our surroundings, with our loved ones, it's once again hearing dependent. And there are a lot of statistics which shows that as we age, as the age advances, we tend to start losing our hearing. Once we are in the 5th decade of our life, the hearing starts to deteriorate. So a lot of people who are elderly actually are disconnected from their environment because of hearing loss. And it's extremely, extremely important to ensure that we are helping them stay in touch with their environment, with their surroundings, with their loved ones. Right? You all are sitting in the audience. You've got delegates in Malaysia and Philippines there. They all can hear these conversations. You can enjoy these conversations, be part of these robust discussions. Imagine if all of a sudden you start sort of missing out lots of things we are saying. It'll be so difficult. It'll be so challenging. It's going to add so much of cognitive stress and communication stress that it's very difficult then for you to process things. Similarly, for our elderly, to start with, it will be really, really nice to create that awareness that people do tend to lose hearing as their age progress. It's extremely important to identify it, to quantify it, how much of a degree of hearing loss somebody has. And once we have identified those things, to put some intervention in place, whether that requires hearing aids, whether that requires some special listening devices. If we put those things in place, it really improves their quality of life. Otherwise, they just get isolated and isolated and isolated, and it's not good for anybody.
Yeah, but I mean, just out of experience, I have spoken to several people who use hearing aids. They feel, they have lots of issues in getting adjusted towards it, to it. So they have, echoing, hearing things loudly. Yes. And so I think we have to also be careful while advising hearing
Absolutely.
aids.
So let me just address this very quickly. Some of us are wearing glasses, right? So I wear these glasses. If I take my glasses off, I literally can't see. Like I can see this person sitting next to me because my near vision is okay. But all I can see is there are some people sitting in the audience. I can see some colors, but I can't see your faces, right? The moment I put it back, I can see crystal clear. But hearing aids don't work in the same way. It's very important for people to understand. Hearing aids are not like glasses. They can't get, the vision can be corrected 6 by 6, but that does not happen with hearing aids. So what hearing aids do is they amplify the sounds, and they need to be programmed really, really well based on the unique hearing status of somebody. So they need to be programmed really well. They need to be fitted really well. And then clear instructions needs to be given how somebody needs to use it in terms of battery changing and in terms of it being fitted properly and stuff. If all of those things are not done in place, of course, hearing aid will squeal, will create those sounds, and then they will not really help them. So expectation management as well as proper fitting and proper instructions and counseling about how to use them can make a huge difference.
Thank you for that. Now I have another interesting question for you. How can we leverage insights from education, psychology, and social work for holistic healthcare approaches for the elderly?
Absolutely. I think this is the multidisciplinary, the transdisciplinary approach, which we have been talking from yesterday and today as well. It's extremely, extremely important. So when we are looking at an individual, we need to look at that individual holistically. So if you're talking about aged care, we are not only talking about a place of living for those people, their diets, their mobility, we are talking about everything. We are talking about sensory management. We are talking about their physical health, mental health, spiritual health. That was a beautiful topic you brought in. Cultural sensitivity. Also, all of these things need to be addressed really, really well. And that can only happen when we bring people from different disciplines working really closely with each other and understanding each other's perspective as well. So if somebody is struggling with, let's say, hearing, and you have a clinical audiologist who comes and helps with respect to fitting the hearing aid, then you have got care workers. So it's really important for the care workers. They don't need to be an audiologist, but they need to understand that the hearing aid is on or not. They need to be able to have they need to be taught and trained in such a way that they understand that, okay, the battery needs to be changed. Or if nothing, I need to come in front of a person and speak normally. Sometimes we think if somebody has a hearing loss, we start exaggerating, That's not how we talk, right? We say, can you hear me? No, we don't. That's not how we talk, right? So it's important for us to understand, you come in front of them, get their attention, and speak normally if they're lip reading it, so that the lip reading is a normal thing. If we exaggerate it too much, then it's hard for us to interpret it as well. So I think it's extremely important for whether it's general physician to it's the physios or audiologist, speech, general well-being, all of those professionals to work really closely together to look at a holistic approach and almost having a personalized, person-centered approach as well.
Thank you, Dr. Raj Shekhawat. Now to Dr. Pavitra Reddy. What are we are keen to know about the distinctive programs and services of Vaya Vikas for the elderly and the vulnerable population. And could you cite your innovative approaches towards this?
Thank you for inviting me to be here. And with the panel, that's all doctors. I feel like I'm completely out of this. I come from an NGO, not-for-profit organization, and I'm here to talk about the different aspect other than health.
Right.
So though health is one of the things that we do talk about in our organization, we are in Karnataka currently, and we support about 60,000 senior citizens in this space. Our main focus has been on three things, which is legal, social engagement, advocacy, and research. So a board which compromises of a lot of senior people in the industry, including Dr. Devi Shetty, Mr. Chris Gopalakrishnan, and others. The main idea of Vaya Vikas was to be to advocate for senior citizens at the government level, at the NGO level, at the CSR level, at all levels, by having senior citizens themselves be part of it. That's what we are working towards. Having said that, when you talk about innovative approaches of what we are doing, we have just heard about what are the barriers that people face with having to use technology or with having to come out and talk to people and all of that. One of the things we do right now is teach digital literacy to a lot of senior citizens. We have programs across, we have programs online, we have programs in person. We work with companies like NASCOM Foundation, we work with companies like Infosys Foundation, Centum Foundation, who have these programs, and they're not for senior citizens, but we're trying to bring them around to be able to teach senior citizens. The way we do it currently is in English, but that's not enough in India. And one of the things we do need to, and we understand we have to work on, is bringing in language-specific training in this space. And like Dr. Suman was talking about, there is a barrier when the technology is changing very fast. And there's a new scam every day coming out. How do you bring them up to date? So that's another program that we have where we're talking about what to do with all those things. How do you identify these things? So that's been one of the most important thing and a lot of interest that's been seen. The second thing that we do, and this brings in 2-3 aspects into play, is legal services. We have a free legal service where we have in-house lawyers, where we have students from various colleges like National Law College, Gujarat Law College, and others who work with senior citizens to talk about what are the issues. 90% of the cases are related to abuse, are related to family issues. Very few are actual legal issues that the senior citizen has. So with these, again, coming back to what you've already been saying, it's more of mediation than actually working with a lawyer and trying to fix issues. And this brings in the aspect of intergenerational things, because you have young graduate students from different law colleges who are hearing the problems that seniors are facing for the first time. That makes them think of their own grandparents, makes them think of their aging parents, to understand how
that is a way of creating awareness.
Exactly. Yeah. And I think one of the other things we are working with is re-employment for senior citizens who are looking for it. Again, here class matters in terms of underprivileged looking for jobs because they cannot retire and what kind of jobs they need. The middle level looking for jobs for actually bringing up their families or whatever. And then you have the upper middle class who are not looking for jobs, but who are looking to be engaged because social isolation is an important issue that we all face. So again, looking at employment for the sake of whichever categories they're looking at, that's something else we work on bringing together.
So you said you have more than 60,000 people you're engaging with. So do they come voluntarily to you, or do you go actively looking for people to be part of Vaya Vikas?
So it's both. Mm-hmm. We have a lot of programs that we do online, offline, where we get people to come and be participating in it, which brings people who are educated, mobile, to be part of this. We also work with the various associations across Karnataka. We work with retired associations, we work with old age homes, we work with government, we work with the other NGOs to bring together senior citizens who are not able to physically come or who are not knowledgeable enough to become part of the membership. So we do try to get all senior citizens as part of it.
Okay, thank you. But how do you, integrate with various stakeholders which you would need? Like you said, lawyers, people from the other stakeholders would be?
So what at Vaya Vikas we believe, or at the non-profit we believe, is to not reinvent the wheel. So we have partnered with hospitals like yours and others, wherein we send our senior citizens for healthcare. We do not want to start a clinic or something else. We are also partnering with various, not hospital settings, but various clinics who are who are for physical therapy, who are working on rehabilitation, etc.
So you have sort of agreements with them, is it?
Yes. Okay. So that's in part of health. we also work with various companies who are looking at jobs to see if we can get partners who will work with senior citizens for the same. It's not for finding jobs for them. We say, can you take senior citizens in your company? They already come with experience. They are retired. Why don't you use them for other things? Maybe for accounting, maybe for mentoring, maybe for other things. So they are also our stakeholders. We work with other NGOs who are working like HelpAge, Nightingales, who are working with the underprivileged to see how we can help them out with other programs that will bring together help or aid that they can't get directly.
Okay.
Right. So we have different stakeholders in all areas that we're looking at. Like I said, legal, we have the law colleges. We do also have retired lawyers who are coming and doing free help for us. Similarly, in other areas too.
Yeah. You could also think of something for senior citizens who really don't require the funds, but they want to pass their time effectively and, to help the society. Like what our institution is doing. We have a group of elderly who come to the hospital just to help the patients, just to say, come here, you can go here, you can go there, these kind of. So, and they feel very fulfilled at the end of the day. So you can even think of, placing people in such positions, the elderly. That is our experience. And we also have one experience of supporting the disabled elderly. So we give them some small, employment, like a lift operator, things like that. So these are just some thoughts and suggestions.
Yeah, so that's a very good suggestion, because that's something else we are trying to work towards, where the abled senior citizens can help the underprivileged senior citizens. So one of the things when we talk about digital literacy, what we're doing is train the trainer program, where we're trying to teach the senior citizens to be able to talk or teach the others in their community, in their area, because it's not scalable otherwise. We cannot be everywhere. It's just not possible. So having a train the trainer, where we pick some senior citizens who are able to learn, who are able to earn with it, and go around in their community and teach. We had an underprivileged program where we raised funds. One was we work with the government. So we were looking at awareness programs on maintenance law and other things. We were looking at a health camp, and we were looking at getting them groceries and stuff like that. And you won't believe it, it was the abled senior citizens who had money who donated for this cause. So we didn't have to go and raise it anywhere. It was just that, look, this is what we're doing. Would you like to help? And they all came forward to help. So we're not looking at senior citizens as old and they can't do anything. We're looking at senior citizens as they have life. And it's actually extended to another 40 plus years. So you can do a lot more. And that brings them out to be part of the community and continue to learn and do things.
Thank you. Thank you so much. And I think in the interest of time, we would have to probably wind up the discussion here. Can we have one or two questions? I think one or two questions, we can stop with that. Anybody? Okay. If there are no questions, Dr. Megh Shambat, would you like to say anything?
Madam, thank you very much. It was a very interesting session. We had all panelists who asked, who answered questions which were very diverse in nature. And I have just one question, Madam, as regarding the stakeholders and who could probably benefit. So you said about the legal people who could provide. So in what way actually the legal insight could be provided to people who are elderly?
So when we're talking about stakeholders and legal, we also are working with the central government, where we're talking about the schemes that they have, the governance that the government gives. There's also a helpline that the government has set up. We try to advertise that. And we also work with legal students, lawyers, professors, and retired lawyers. Our service is completely free. We don't charge for it. And what we do is, if a senior citizen has any question, they either can come down to our office, call in, or there are like 4 or 5 ways that they can reach out to us and put in the question. And this is directly passed on to the legal students who look at it. And if they can advise it then and there, they do. Otherwise, it goes to the professor level, who comes back and says, look, this is the issue. This is how you can proceed. How do you want to go about it? What are the next steps? If it comes to a point where they say, okay, even after all this, I still want to go fight a case, we give them a few lawyers who are trusted. And we try to set a little pricing so that they know whom to go to. Trust is a very important thing, and they have very limited funds they cannot play around with and can't wait for 5 to 10 years to settle a case. So they can then take that and decide if they do want to go forward and speak to lawyers who are willing to fight the case for them. So that's how the legal cell is set up for us.
Okay.
Yes.
Thank you very much. And any questions in the audience?
We were talking about elder abuse. Could you get some information from them,
So one of the things you can get on topic of elder abuse is, again, the government has this cell, which is 14567 number, where there is a lot of calls coming in. One of the biggest issue that in cases of elder abuse that we find is abandoned elderly. People are taken on trips, people are taken out for one reason or the other and just left on street corners, left in areas that they're not familiar with, and the family comes back. So that's one of the biggest things. Second part of it is financial independence. If the senior citizen is not financially independent and dependent on the children, there are various cases where it happens that either they're not fed properly, they're thrown out of the house, they have issues with what they can do, can't do, etc. One of the other things is, we think it's very nice, but taking care of their grandchildren. But again, they're treated as nannies for the whole day. It's not like you take care of them for some time, but it becomes their complete responsibility, and they are abused if something happens to the child.
I think what she was asking is, do they give you that information? Do they come out with the information?
Yes,
they do.
Yes. But if it comes to filing a case or fighting for it, they don't want to, because it's still their children. That's a different thing. They come out, they talk to you and all that, or they call you at times when their children are not at home. They don't do it when the children are at home. They call, they say, this is the issue, what can you do to help and all that. When we say, okay, we need to have an intervention where we talk to the children and you together to solve it, they don't want to take a step forward. Or we say, okay, we'll send the police home. They don't want to do that. So half the time the issue stops with just having that, okay, there is an issue with them, but us not being able to do anything about it.
So it becomes a net and there's no solution there.
We do try to talk back, at least in the helpline that I have seen, they try to call back and see if this senior is doing all right. 10% of the time they do come back saying, okay, I can't live here, can you do something? Most times they say, okay, I'll adjust, how long am I going to leave? I might not stay longer, so it's okay with me, and those kind of things. So,
regarding the maintenance of parents, it is the responsibility of the children to look after the parents. How many of these people are really aware of it? And if at all they are aware, how many come forward and tell us that they need help?
Again, very, very less population of senior citizens are aware of this. Even if they're aware, like we just did recently in one of the slum areas where we had women who were abandoned by their children in the slums. We were talking about the maintenance law and how they can fight for it, how they can get income from these children or the next kin, whoever is there, and how they can lead a better life. And one of the ladies was like, yeah, I know all this, but my son is also struggling. He has a family to take care of. So it's not right for me, who is elderly, who's aged, to go and ask for the money. Let them live happily.
Actually, recently there was in the news, some parent in Gujarat had gone to court against his children for not looking after him. So there is some amount of awareness among the educated. I don't think among the
So when it comes to mediation, we have seen that half the time that the children will come forward to support, because then it becomes a legal issue, then neighbors are involved, society is involved, so that scares them into coming and saying, okay, we'll take care. Yes. Yes.
Thank you so much.
Thank you, Ms. Pavitra. And in the interest of time, we have a keynote session which is about to begin right now.
Right. Okay.
So
on my behalf, I'd like to thank all our panelists, Dr. Raj Shekhawat, Dr. Ramaya, Dr. Pavitra Reddy, Dr. Vishwanath. Thank you, Dr. Suman. Thank you so much. And
thank you, madam. Thank you so much
very
for
interesting.
This interactive session. It was very insightful. Thank you so much.
Thank you.
Thank you to all the panelists.
Hello, everyone. Good afternoon. So we are about to start now with our second keynote session for the day. And we have Dr. Jean P Loreche from the Philippines node who's joining us. Dr. Loreche is the commissioner of the National Commission of Senior Citizens in Philippines. She brings a wealth of healthcare experience and dedication to her role. Her commitment to public service was evident during the pivotal role in the Department of Region 7 amidst the COVID-19 pandemic, and with titles in both medical technology and medicine. Dr. Loreche's extensive experience include hospital administration and a fellowship status in anatomic and clinical pathology and oncology. During the pandemic, she spearheaded the COVID-19 testing, and she served as a medical consultant and a spokesperson for the Department of Health Region 7, significantly impacting the region's crisis response. Now, as a commissioner, she champions senior citizens' rights and well-being, leveraging her comprehensive understanding of healthcare and compassionate approach. Dr. Loreche's dedication, leadership, and advocacy for senior citizen welfare makes her a valuable asset in shaping policies and initiatives positively impacting the lives of older adults in Philippines. Over to you, Dr. Loreche.
Good afternoon. Yes, and thank you so much, esteemed guests, including participants in this Asia Pacific Aged Care Hub. I would like to share our practices here in the country, from policy to practice, transforming aged care in the Philippines. If you know that we have an aging population, just like our neighboring countries and members of this Asia Pacific Aged Care Hub. To date, as of 2024 data coming from the Philippines Statistics Authority, we have around 10.5 million older adult population, starting at the age of 60 up to and beyond. That is accounting for 9.4%. And if you notice, there is a population projection already that was given to us that in 2100, it would be at 6%. And then in 2010, 6.8%, 9.9% by 2025. So basically, we are just a few months away from 2025, but we are already hitting the target. It would have been good if we hit the target not on the older adult population, but rather on something else. But sad to say, the aging population problem or concern is a reality on the ground. So if you look at it, when we talk about policies, the government has certainly implemented a lot of policies that would impact the lives of the older adult population. Of course, for health and welfare, way back in 1987, the Philippine Constitution already provided for the health and welfare of its elderly population. And then there was an expanded Senior Citizens Act of 2010 that will actually provide further services, discounts, and benefits to the elderly population. I believe that the Philippines is one of the many, I do not know if there are other countries, by the way, who has such a wide array of services and discounts, including benefits. We have the Centenarian Act, of course, wherein if you reach 100, you receive 100,000 Philippine peso. And we have expanded it further most recently with the Octogenarian Act, which means that when you reach the age of 80, 85, 90, 95, you again get a cash gift from the national government, notwithstanding what the local government units are giving to their constituents as well. There are wealthier or richer municipalities or cities that would give a similar counterpart or even a bigger amount to what the national government is giving as a benefit, as a reward, as a recognition of their aging population. Of course, the 20% discount plus 12% discount on top of the 20% via the VAT is also given to older adults, particularly when it comes to the medicines and drugs, their maintenance medications. There are also discounts even with the transportation, land, sea, air, all of that, even hotel accommodation, restaurants, and food chains. You can get all those discounts. Republic Act number 7876 is the Senior Citizens Act, Senior Citizens Center Act of the Philippines that provides that for every municipality and city, there has to be a senior citizen center or a community center. However, as we go around Cluster 4, which is Region 6 and 7, extending to Region 8, we have seen that this provision of the law is not fully implemented. And so what is the task of the National Commission of Senior Citizens, which was created by law, Republic Act number 11350, creating an agency directly under the Office of the President way back in 2019 to address the problems, the issues, and concerns of its aging population. And so the commission is actually tasked, the tasks of the commission is actually on policies, making sure that we lobby, we have the revisions or visit, or maybe an enhancement of specific laws, providing benefits and welfare for the older adult population. On top of the policy-making activity, the Commission is further tasked of making sure that these policies and guidelines are implemented on the ground. And so, from policy, knowing that we have the laws necessary for us to move forwards in the care of older adult persons, our team conceptualized the fact that there is such a thing as a loop of service flow in terms and in relation to addressing the needs of the older adult population in the country. We are also of the fact and mindful that for the Philippines and the culture of the Filipinos is that the home is where they should be taken care of. And that is also provided for in the Constitution, where everyone, every family member should take good care of their aging members of their households. However, because of the challenges that we are faced with, there is migration already of family members seeking livelihood opportunities outside of where they are, particularly those who are placed in the most rural areas. Remember that we are an archipelagic country with more than 7,100 islands. So you hop from one place to the next. Sometimes it's quite a distance, and you are separated either by mountain or by sea. So it makes it very difficult, especially for those geographically isolated areas. So we need to strengthen the families and the homes where the older adults are. But basically, we also understand the need to look into the totality of their needs when it comes to health and well-being. It can be done by looking at it in the preventive aspect versus the curative aspect. Being a medical doctor, I know that we do not really want to dwell on curative because it is going to eat up a lot of our economic burden to the Philippines or to the government. So we want to strengthen our community-based care centers. So when you talk about community-based care centers, the law provides that there has to be a senior citizen center in every locality, which is not being fully implemented, but which we are trying to follow through. And for those centers that are already available, we see that there are certain programs related to the community needs in terms of preventive aspect of an older person. We have to empower, capacitate these local government units. Remember that the success based on our experience here in the country at the grassroots level, it is not going to be a top to bottom approach. It has to be a bottoms up. Every local chief executive must embrace the idea for it to become successful. They have to have that ownership. So when they have that ownership, they know that the idea may not be coming from them, but they can lay claim to it, which, by the way, is the way to go, reading the political landscape of our country. So in the community-based care setting, what do we need? We put in the wellness. We put in all the checkup, the follow-throughs. We put in the diagnostics for basics that will be needed by the older person. Lifestyle changes, nutritional, dietary, including, of course, social interactions, the exercises on the physical aspect, psychosocial, because we know that cognitive mental impairment is also on the rise among the older adult population. Remember that elderly people are more prone to depression, anxiety, stress, for whatever reason. And so by providing them a place where they can move, work together, maybe interact to socialize would be a good way of delaying the progression of whatever cognitive impairment they may have or even physical problems that they may have. This is also a way of encouraging livelihood training programs because we believe that the older adult population, when they're able, when they are capable, when they are empowered, and they are willing, they can actually find meaning into their lives by providing them the necessary skills for livelihood programs. A classic example of that would be here in the province of Cebu. You know that it's a tourism-rich destination area. So we train them to become tour guides. Of course, we train them to become guides and to be the ones who will be sharing histories in cultural heritage areas. Maybe also encourage them to do other livelihood projects whereby they can sell, provide to tourists, both local and international. Disaster preparedness has to be placed in that particular setting, including research. Data can be gathered on the ground, thrown higher up for possibilities of a research tie-up. Or maybe the center can become a recipient of whatever data, whatever research, evidence-based activities that has been conducted in order for us to enhance whatever programs we have in our area. We need to encourage help desks to be placed in the centers where the older adult person can actually seek help, guidance, and even legal assistance, and a referral to where they can go should they report violence against the older person. So when they have completed that in the preventive aspect, they can go back to their homes safely because we believe that they are now empowered on a daily basis, on a weekly basis. Various programs are being managed and supervised at that level. Again, it doesn't end there. We know that the older adults will also need facility-based for what? For their admissions. But admissions should be categorized further. Acute care, for curative, immediate, emergent. And then we have to put them to the next step, which is the transition, the step down, or even what we call the convalescent care center. In the convalescent care center, that is where rehabilitation can happen. That is where preparations and training of the family members will happen, so that when they're brought up to their homes, then they are able to take care of their older adult person. When they are back to the homes, the cycles goes again back to our community-based care centers for the continuance of their preventive care. Of course, we cannot do away with the long-term care facility. There are individuals, older adults, who have nowhere to go. The abandoned, the neglected, either coming from the community, coming from the streets, coming from the hospitals with nowhere to go. We need to start thinking of developing our long-term care. Currently, under the Department of Social Welfare and Development, there are only 4 residential care facilities in the entire country, 2 of which are here in Metro Manila, and 2 are in Mindanao. There is none that is developed in Visayas. But we want to see a better, bigger long-term care facility. Maybe the future is for every region, every province should have it. But then it takes a lot of funding, a lot of manpower and upkeep. So we need to look into that, study it very well, and maybe part of it would be to propose to our policymakers. So when we talk about community-based care centers, we are going to launch 3. As you know, I just started October of last year. We're going to launch it in Moalboal, which is a 4th-class municipality in the south portion of Cebu province this coming May 24. Another one in Ormoc, Leyte, that's in Region 8 on July, and in Cabatuan, Iloilo province in Region 6 in August. We are hoping that by putting in a template, a pilot area or pilot areas, we will be able to cascade it to every local government units by which they would learn to embrace this and would want to have it done. So when we talk about facility-based, which I already mentioned, we would like to give a classic example of one hospital somewhere in Camarines Sur, Bicol. That is where your beautiful Mayon volcano, the perfectly coned volcano, is located. We went to Bicol Regional and Geriatric Medical Center. This is a classic example of a hospital that caters to and takes care of the geriatric population when they are admitted. But what is beautiful and impressive here is that they have activity centers, not just for the admitted patients, but in their outpatient center, they have a wellness area there wherein they have hearing, vision, they have functionality, and all of this together with the daily interactions, giving mini lectures on how to detect dementia, how to take care of them, and even doing low-impact exercises for the elderly who comes into the hospital. We are trying to connect this hospital, this facility now, with what we call an LGU, a local government unit in that particular area, region. That's what we call the Sipukot. There is already a trained they have undergone training for their barangay healthcare workers on the detection for geriatric syndromes. But this is not functioning in its maximum capacity. Why? Because it lacks the embracement of the local government unit. So our next visit will really to talk and sit down with the stakeholders there. So now we will be able to connect the first action, which is from the home, going to the community of Sipukot, going to the hospital, and back again to the community. And we are also developing via this hospital a step-down facility within its compound, not necessarily within the hospital premises. And so these are just photos, images of our collaboration with the local chief executives in Region 6 and 7. We really wanted them to feel that this program is for their service to their constituents. We collaborate with our policymakers, so we will be able to see if the laws that are in existence needs to be revisited, maybe to be enhanced in order to cope up with the changing times. We collaborate with the various government agencies like the Department of Information and Communication Technology, the TESDA, which is the training arm for skills development, Department of Labor and Employment, including that of our Department of Social Welfare and Development. We need to be able to work together as a team. So, ways forward for us. For us to move forwards, taking care of our older adults, making sure that we are prepared to when the time comes 10, 20, 30 years, when our older adult population increases further in number. First is a robust research for evidence-based planning and programming. Without research, without data, it will be very difficult to craft the program, to plan this, and to be able to submit this to our policymakers for them to see the need for support. Second, ways forward for us is to be able to set the standards, secure accreditation and licensing currently for the step-down facility that we are envisioning to put up in before the year should end, utilizing whatever infrastructure is already currently available. There are no set standards. We do not know which government agency will give the accreditation and license. And so our team will have to work in a collaborative manner with the Department of Health, together with the Department of Social Welfare and Development, and the other, maybe the DILG or the Department of Interior and Local Government, because they are the implementing arm. Institutionalization of Senior Citizens Community Care Center, which we have started, and this is going to be tackled in Congress next week. We need to empower the stakeholders through community-driven development. Empowering them means having them in the loop, making them understand what it is that they are into. Of course, we need to catalyze a strong collaboration across NGOs, and this Asian Pacific aged hub that we have is a very good catalyst already to help us, make us and help us in our trainings, capacity building, learn from your best practices. We want to implement cost-efficient and impactful initiatives because at the end of the day, it has to be felt on the ground and to propel advocacy efforts on geriatric care, rights, benefits, and privileges of the older adults. And so if you look at it, what we are doing, we want to have it a holistic, whole-of-nation approach. Thank you.
Thank you very much for the insightful keynote, Dr. Loreche. In the interest of time, we have asked to collate all the audience questions, and we'll get back to you later on that, Dr. Loreche. Next keynote speaker for the day is Ms. Sarah Raffay. Sarah Raffay is the Chief Executive Officer at Calvary Health Joint Venture, where she has overseen the full accreditation of their virtual hospital against quality standards as one of the first in Australia. She is known executive in health and the executive of strategy at the Southern Adelaide Local Health Network and Chief Operating Officer at Women's and the Chief Operating Officer at Women's and Children's Health Network prior to moving to the private sector. She has demonstrated strong leadership and management skills in healthcare setting. Sarah is known as the change champion and has successfully led large-scale strategic, operational, and financial improvements to deliver new and innovative initiatives. Her experience working in both public and private healthcare sectors enables her to successfully navigate the current ecosystem of healthcare. We have asked Sarah to record her keynote to us, so we'll be playing the recording here, and Sarah will be there a bit later to actually give some final comments. Over to the recording.
Hi, to the Asia Pacific region. I'd like to acknowledge that the land I stand on today is the traditional lands of the Kaurna people, and that we pay our respects to their spiritual relationship with their country. We also acknowledge that the Kaurna people, as the custodians of the Greater Adelaide region here in Australia, and that their cultural and heritage beliefs are still as important to the living Kaurna people today. My name is Sarah McRae, and I'm the CEO of a virtual hospital in Australia. My journey in healthcare has been driven by a passion and vision for the future, a future where virtual hospitals stand as the cornerstone of our healthcare system. Today, we find ourselves in a critical juncture in healthcare. Traditional models are being stretched to their limits. Ambulances were ramped outside emergency departments for hours. Access to hospital beds is creating havoc in our emergency departments. These facts represent moments of crisis for patients. My mother was one of these statistics. It impacts patients, their families, and extreme pressure on clinicians. It is time for immediate and innovative solutions. Global healthcare faces unprecedented challenges that threaten the very sustainability of our systems. These challenges include lack of resources. Healthcare services are grappling with limited financial resources and shortages in skilled workforce. This results in an inability to provide timely and effective care to all who need it. In the wake of the pandemic, clinicians are becoming burnt out and leaving their professions we are struggling to replace them. There's an increase in burden of chronic disease. Chronic disease is on the rise. People are living longer and people are sicker and more complex. This exerts more pressure on their healthcare systems. Managing these conditions takes time, resources, and ongoing care. This equals additional pressure on traditional hospitals that are already stretched. Inequitable outcomes and access. Despite advances in healthcare, inequitable access to healthcare persists. Whether it's due to location, social or economic situation, we fail to provide equitable access to healthcare for all. Digital future. I'm an advocate for evolution in healthcare. I firmly believe that digital health, virtual care, and hospital in the home are essential components to respond to the current challenges in our exhausted health system. They are a reset. They can redefine access to care, improve our patient outcomes, and reduce the strain on our physical healthcare services. Imagine a world where the hospital comes to you, not in the hurried lights of an ambulance, but through the gentle hum of a wearable device on your wrist, the soft glow of your smartphone, or even the immersive environment of a virtual reality headset. Telemedicine connects us to doctors with a tap of a screen. Tiny sensors embedded in our clothing and homes discreetly monitor our vital signs. At the same time, the power of artificial intelligence analyses this data, helping us to detect the earliest whispers of potential health issues. An era of proactive health management. We no longer wait for illness to strike, but we intercept it in its infancy. This results in reducing invasive treatments, fewer hospital visits, and importantly, healthier, longer lives. Treatments are tailored to a disease and to the individual patient's unique genetic makeup, maximising effectiveness and minimising side effects. As healthcare becomes more personalised, it also becomes more equitable. Remote monitoring and virtual consultations bring optimal care to those in rural areas and underserved communities, breaking down geographic barriers. Language translation tools integrated into health platforms ensure that care is accessible without language being an obstacle. Empowerment will be the hallmark of this new era. Gone are the days when health data was locked away in inaccessible records. Imagine a world where individuals have complete control over their health information, using it to make informed decisions alongside trusted medical professionals. Patients move from passive recipients to active collaborators in their own well-being. The human element remains paramount even in this technology-driven future. Doctors, nurses, allied health will all be empowered, not replaced. With the help of digital tools, including AI-assisted analysis, clinicians can dedicate more time and focus to the things that truly matter. Time with patients, building relationships, and applying expertise where it makes the most difference. Virtual hospitals also provide the opportunity to provide diverse care. Take, for example, the experience of a mother who benefited from our virtual hospital service. She shared, "I think the service was fantastic, a great way to keep people in their homes whilst receiving treatment. The model is so appreciated as I have a breastfeeding infant." For this mother, the ability to receive care while continuing to breastfeed her infant at home was not just a matter of convenience. It was a matter of providing care that respects her role as a parent and supports her family's needs. Imagine a world where hospitals are reserved for the most acute cases, where prevention is the primary medicine, and where a healthy, fulfilling life is not merely a goal, but an achievable reality for all. The future I envisage is within our grasp. The technology exists. It's up to us, healthcare providers, innovators, policymakers, and patients themselves to unite behind this vision. The Calvary-Ampler joint venture is a virtual hospital run here in Australia. Calvary, who's delivered healthcare in the hospital settings for greater than 160 years. Ampler is a wellbeing innovation out-of-hospital service. The two came together 3 years ago and are now delivering 24/7 care 365 days a year. We are 100% accredited against the national standards of the hospitals, and we've treated over 200,000 patients across Australia. In South Australia, we deliver acute hospital care, hospital bed substitution. Our length of stay is 4.2 days. Our NPS is 89, and this is considered world-class. 96% of our consumers report positive patient care satisfaction. We treat greater than 150 diagnostic-related groups. Our representation rate to emergency departments is less than 1.3%, and our readmission rate is the same. And our our average hospital-acquired complication rate is 0.6%. And through this model of virtual hospital, we treated greater than 12,000 patients. Today, in this virtual hospital, we have 100 patients. We have delivered more than 55,000 bed days in the last 3 years. This impact equals reduction on health system pressure, cost savings of $220 million based on hospital construction costs for extra beds. Australia's health system is under pressure to reduce its effect on climate change. Healthcare accounts for 7% of Australia's greenhouse gas emissions. Research shows that virtual care leaves half the carbon footprint of hospital care by minimising the need for physical infrastructure and reducing patient and staff travel. A virtual teleconference uses only 1% of the emissions of a hospital visit. Hospitals also create a substantial amount of waste with equipment and utilising large amounts of wastewater with its linen and sterilising. Virtual care is showcasing a sustainable and responsible environmental model for the future healthcare. Currently, the Calvary-Ampler joint venture is 4% of the public beds in South Australia. 4% in Australia equals 1,400 beds. In the UK, the push towards virtual healthcare is gaining momentum, intending to double the current capacity from 20 virtual beds per 100,000 population to 40. These achievements exemplify virtual hospitals' practical benefits and scalability in today's healthcare landscape. The success of virtual hospital is underpinned by 3 key pillars, each addressing the critical challenges of facing global healthcare. Operational efficiency and enhanced capacity. Virtual hospitals are not merely about replicating hospital-level care in the patient's home, but are a testament to a system designed to expedite recovery while maximising healthcare resources. This model directly addresses the challenges of resource limitations, offering a solution that enhances the capacity of healthcare systems without the need for significant capital investment in physical infrastructure. Elevating patient experience and outcomes. Integrating remote monitoring and telemedicine transforms patient care, fostering a new era of empowerment and engagement. When combined with longer-term monitoring, 80% of patients reported increased confidence in managing their long-term conditions, underscoring the empowering impact of virtual care. Lack of access to healthcare can also be improved by virtual care, which provides equal access and treatment to diagnosis and care of disadvantaged and vulnerable groups who can be cared for in their homes and their local community. However, governments need to make sure further efforts to bridge the digital divide so that rural and disadvantaged communities have the means necessary to access technology to participate in virtual healthcare. The cost effectiveness of virtual hospitals presents a compelling argument for their broader adoption. Virtual hospitals' cost per episode of care are approximately $1,000 lower than comparable inpatient unit costs, primarily due to hotel and labour cost reductions. By significantly reducing the expenses associated with traditional inpatient care, virtual hospitals offer a sustainable model that promises substantial savings and a more efficient allocation of healthcare resources. Becoming barriers to embrace innovation. One of the most significant barriers to the adoption of virtual hospitals is the inherent cultural and organisational resistance within the healthcare sector. This resistance often stems from a reluctance to depart from traditional models of care, coupled with concerns about the efficacy and safety of virtual healthcare delivery. Proposed solution. To further overcome cultural and organisational resistance, an actionable solution is to implement comprehensive training programs that educate healthcare providers about the benefits and operations of virtual hospitals. These programs should demonstrate the efficacy, safety and patient satisfaction associated with virtual care, thereby addressing concerns and fostering a culture of openness to innovation. While we've discussed the broader barriers to adopting virtual hospitals, it's crucial to delve deeper into the specific funding-related challenges. Despite the proven cost-effectiveness and public support for virtual care, traditional in-hospital care continues to receive priority funding. This discrepancy not only hampers the growth and scalability of virtual hospital, but also overlooks the potential of significant savings and improved patient outcomes. Additionally, implementing virtual hospitals requires substantial investment in technology, an investment critical for ensuring high-quality, accessible care. There needs to be a concerted effort to rebalance healthcare funding models. This entails advocating for policies recognising the long-term cost savings and patient benefits virtual hospitals offer. Investment in virtual care is a must. The technology underpinning virtual hospitals, from remote monitoring devices to telemedicine platforms, is fundamental to their success. Virtual hospitals are also at the forefront of embracing cutting-edge technology, including AI, virtual reality, and activity monitoring. Securing more funding for this technology is essential. Governments and healthcare organisations should prioritise investments in digital health infrastructure, ensuring that virtual hospitals have the tools they need to deliver care effectively. This may involve targeted grants, public-private partnerships, and incentives for technology providers to develop solutions tailored to virtual care. Finally, the transition towards value-based care represents a critical shift in how we approach healthcare funding and delivery. Value-based care focuses on outcomes rather than services rendered, aligning healthcare providers' incentive with patients' health and well-being. By embracing this model, we can ensure that funding is directed towards interventions like virtual hospitals that provide the greatest value to patients and the healthcare system. This shift requires a systemic change in healthcare policy and reimbursement models, emphasising efficiency, effectiveness and patient satisfaction. To overcome these funding challenges, a multifaceted approach is required. This includes lobbying for changes and collaboration among stakeholders, healthcare providers, government agencies and technology companies and patient advocacy groups is crucial to drive these changes. How has the Calvary-Ampler joint venture succeeded? The journey of the Calvary-Ampler joint venture hospital serves as a compelling case study in the transformative potential of virtual healthcare delivery. Through innovative strategies and a commitment to excellence, the JV has navigated the complexities of integrating virtual care into the healthcare landscape, offering valuable insights into how such initiatives can succeed. At the heart of the JV's success is its medical oversight model that champions shared care. This model is a testament to the power of public-private partnerships, bringing together the best of both worlds to create a healthcare delivery system that is both efficient and patient-centred. The private sector, known for its agility and operational efficiency, takes the lead in managing logistics and the day-to-day running of the virtual hospital. This includes everything from technology, infrastructure, to patient scheduling and communication. Conversely, the public sector plays a crucial role in providing regulatory oversight. This ensures that care is delivered through the virtual hospital meets the stringent standards expected in the traditional healthcare settings. The collaboration between public and private entities guarantees that patients receive care that is innovative, it's safe, it's reliable, and it's of the highest quality. The development and implementation of the JV model have not been without its challenges. Overcoming cultural and organisational resistance required a concerted effort to demonstrate the efficacy and benefits of virtual care. This process involved extensive stakeholder engagement, from healthcare professionals to patients, ensuring that all parties were aligned with the vision and potential of virtual hospitals. Moreover, navigating the regulatory landscape and establishing a sustainable funding model were challenging. This was achieved through strategic advocacy, showcasing virtual care's cost effectiveness and patient benefits, and securing the support necessary for long-term success. The joint ventures model's transition to its current state of excellence took 3 years, a period marked by continuous learning, adaptation and refinement. This journey underscores the importance of perseverance and flexibility in the face of challenges. With the Calvary-Ampler joint venture team dedicated to creating a virtual hospital system that not only addresses current healthcare needs but is also poised to adapt to future demands. Today, our model stands strong and exemplifies how virtual hospitals can address cultural and organisational concerns, regulatory challenges and funding issues. It has established a blueprint for success that other healthcare providers can follow, demonstrating that virtual hospitals can play a pivotal role in shaping the future of healthcare delivery with the right model, collaboration and commitment. As we look towards the future, it's clear that virtual hospitals must become an established part of all state health systems in Australia and around the world. Our journey thus far has demonstrated not only the feasibility, but the imperative need for virtual healthcare delivery models. They are essential in addressing the challenges of resource limitations, managing chronic diseases, and ensuring equitable healthcare access. To achieve this vision, we must advocate for and establish collaborative frameworks that involve government bodies, healthcare providers, technology partners, and the community. These frameworks will facilitate the sharing of best practices, innovations, and resources to standardise and support virtual care models across different jurisdictions. We need to engage in target advocacy to ensure that virtual hospitals are recognised and supported within our healthcare systems. This includes advocating for regulatory frameworks that facilitate virtual care delivery and equitable funding models that reflect the cost effectiveness and high quality care virtual hospitals provide. A cornerstone of our expansion strategy is significant investment in technology infrastructure. This includes advanced remote monitoring tools, telemedicine platforms, and secure data management systems. By prioritising these investments, we can ensure that virtual hospitals have the robust technology foundation they need to deliver effective and efficient care. Ensuring that healthcare professionals are well prepared to operate in virtual hospital settings is paramount. While they receive the same foundational training as traditional healthcare settings, additional focus will be placed on managing remote monitoring technologies and enhancing digital communication skills. This dual approach will ensure that the quality of care is maintained while adapting to the unique demands of the virtual healthcare delivery. The success of virtual hospital
Thank you so much, Sarah. Just on the interest of the time, can I actually ask you to come online if you're there and maybe provide a few final comments for us, Sarah?
Thank you. I hope that was helpful. In relation to what we've been delivering here in Australia is that 80% of our patients are greater than 65 years of age, and we're providing care for those patients or those residents within their homes, or we're providing it within the aged care facilities. So I truly do believe that there is absolutely a place for virtual hospital level care to be provided for the aged within both their homes or within the aged care facilities. So in South Australia, of the 12,000 that I presented today, over 2,000 were in residential aged care facilities. And so we really do feel that there's a place where we can safely care for acutely unwell patients that do not then require to have to go into a hospital setting where they quite often will deteriorate further, where they're separated from their family, they're separated from their familiar environment, and they come back, poorer than what they did when they were admitted. So we have seen the success of this model here in Australia, and I hope that by sharing it today, it's, given you some insight and some thought, provoked some thoughts for you to think about what can be delivered across your countries.
Thank you so much, Sarah. We all enjoyed the presentation, and we are collating the questions for you, and we will send them to you soon after this. Thank you so much for joining today.
Thank you.
So moving on, our final keynote speaker for today is Professor Nooran N Haini, joining us from the Malaysia node. Professor Nooran is the former Dean of Health and Wellbeing Research Cluster at the University of Malaya. He's currently a professor of epidemiology at the Department of Social and Preventive Medicine. Having completed a PhD studies at the University of Sydney on physical disability and functional limitations in Malaysian and Australian older adults, Nooran went to lead many large-scale studies in Malaysia, including a highly impactful program on elder abuse, which has led to drafting a legislation in Malaysia. Over to you, Professor Nooran.
Thank you very much, Chair. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning, good afternoon, good evening to everyone wherever you are. So thank you for the Asia Pacific Aged Care Hub International Policy Forum for this wonderful event. And I'll be talking about elder abuse, research and policy in Malaysia. So I'll be talking about three things, just to look at the state of elder abuse and neglect in the country, how Malaysia have been responding to issues on aging, as well as, I guess, a little bit about what can we do to prevent or to help us from the elder abuse and neglect issues. So just to put everyone at the same page, this is a definition of elder abuse and neglect by the WHO, World Health Organization, as well as the INPEA. Elder abuse is actually a single or repeated act or lack of appropriate action occurring within any relationship where there is an expectation of trust, and this causes harm or distress to an older person. And basically, elder abuse and neglect can be divided into 5 categories: financial abuse, emotional abuse, neglect, physical abuse, and sexual abuse. But what is more common is this, the multiple types of abuse that coexist within one another. So it is also common to see in all the violence, trauma cases or trauma incidents in any part, I mean, from child abuse right up to domestic violence to even elder abuse and neglect, polyvictimization is also a common occurrence, right? So looking at the distribution of elder abuse and neglect, this is a systematic review way back in 2017, but I think it's still relevant today. This is one of the 3 systematic reviews and meta-analysis that looks at all the best available evidence from multiple studies. And the estimated prevalence of elder abuse and neglect in the world is about 15%. And this is for older people aged 60 years and above. But what is more alarming is that not just the prevalence, but in the terms of cases that we see, one case that you see, there are at least 24 cases which is underreported. So that is one of the things in terms of elder abuse and neglect. And in terms of the types of elder abuse and neglect, what is commonly seen is actually psychological abuse, followed by financial abuse or financial exploitation and neglect. One of these 3 would be the top 3, depending on how you measure elder abuse and neglect. Right? So in Malaysia, what is happening? So our overall prevalence that we've seen, this is the figure, and I guess this is the most available document that we have. We did a study in 2014, the Prevention of Elder Abuse and Neglect Initiative, as well as the Ministry of Health. They did the National Health Mobility Survey 2018, which is going to be repeated again this year. But the prevalence, what is found is that 1 in 10 of our older adults have had some form of experience in terms of elder abuse and neglect within their lives, within their lifespan from the age of 60 years and above. And what is also worrying is that you see polyvictimization, which means that 5% of this is more than one type. So, and the types that we see is almost the same as what I presented in the systematic review: neglect, emotional abuse, financial exploitation, or financial abuse kind of tops the list. And if you look at the definition by WHO and IMPE, there is this sentence that says there must be a relationship of trust within the person, the older person, as well as the abuser. But we also measured, because financial scams is quite rampant, and we know that sometimes it happens amongst strangers. And what we see is that prevalence actually double when you include issues, or when you include those who are victimized by strangers. And among some of the risk factors that we see is the same as what is there in the literature, or what happens in other parts of the world. Living alone, social isolation, loneliness, some of the common risk factors that we see. Those with depressive symptoms, and those who have had history of previous abuse, which means that either they were abused when they were a child. So those with acute, adverse childhood experience, or ACE, those who have had domestic violence before, they are more prone or more likely to also experience elder abuse and neglect. And another findings that we saw was that another risk factor that's quite prominent is those who have chronic diseases. This include things like diabetes, hypertension, poor physical function, stroke, and things like that. And similarly with what is seen in other parts of the world, majority were actually never reported. And NHMS and our findings actually found that almost 30% of those who experience elder abuse and neglect do not report this case. The other part of elder abuse and neglect is in terms of the consequences, and we see that there are adverse health outcomes, including mortality. And when you talk about mortality, in terms of the victims, the mortality increases by threefold. And this is something that we also try to create awareness among issues, among those in terms of the stakeholders who are in charge of financial abuse, for example, financial scams. So we worked with Bank Negara Malaysia, we worked with AKPK to alert them that financial exploitation does not just mean that you don't have money. It leads to a lot of other adverse health outcomes, in fact, even mortality. We could show that within 2 years of you having financial exploitation, your mortality increases more than those who have not had any experience of elder abuse and neglect. So it shows to say that financial exploitation or financial abuse is not just about losing your money. It's more than that. So I'm glad that we linked on to KPK and to tell them that financial literacy is also something important. Another thing that we also note is that elder abuse and neglect happens in all forms of setting. It's not just in the community, it also happens in the institution as well. The issue about COVID, yeah, we have had COVID. And one of the things about COVID, we didn't have any numbers per se, but we had anecdotal evidence, or we had reported cases that financial abuse is one of the things that happens during COVID in the country. And there are also, I think, evidence from UK and US that says the elder abuse and neglect actually increases 8% during the time of COVID. And if you look at the global burden of disease, the one on the left, I think, yeah, it actually puts up COVID as the second leading cause of death in 2021. So this is us post-COVID. One of the things that we did not do is this. Among people who have cognitive issues or dementia, what is the prevalence of elder abuse and neglect? So in our study, we looked at general population, and this is because of the tools that is needed to capture or to measure elder abuse and neglect among dementia patients. And it's not the same tools that we use in general population. So in the literature, it said that among people living with dementia, the occurrence of elder abuse and neglect is actually 50%, but it's 1 in 2. So it is really high. And there are not many literature on this, but I guess this is something that we might need to have a look in our country, how would we fare in this. Like I said, one of the things that we have issues about is actually the tools. So some of the tools are really, really tools that have been used in the past. We adapt it, we adopt it, and we validate it. So we've looked at the psychometric properties to make sure the tools is robust. That means you're measuring the things that you're supposed to measure. But as time moves on, issues like financial abuse, what we measure in the existing tools are talking about things that people see yourself. So it doesn't include what's happening right now. So there is a move by the World Health Organization right now is to look at the tools, and we've done that together with them. And we've realized that there is a need to actually develop newer tools that looks into the issues of elder abuse and neglect in current setting. So this is some work that is actually moving right now, and we hope that we'll get enough funding for this. One of the things for research is it's difficult to get funding. So moving on from just the numbers, looking at the epidemiology, looking at the occurrence, the risk factors, and the consequences, we also try to understand why financial abuse or financial exploitation happens. And we did this using a mixed method approach or qualitative approach. And these are some of the things that we found out. How it happened is mainly because there is this issue about establishment of trust over time with the perpetrator, right? Sometimes some of them actually have some psychological persuasion, therefore then this happens. Power and control, of course. Reasons why older adults actually give in. Some of them were forced to, and some perceive there is benefit to self. And with regards to coping, some just keep it to themselves and try to forget about it. Some actually manage as best as possible. And also, there are some who actually get support from others. But what is the interesting thing is that in terms of preventive strategies, I think a lot of the older adults that we talked to actually said that education, information sharing, empowerment, these are important things, getting them to know or aware of their rights and the risks of elder abuse and neglect, and a lot of support from social support is some of the preventive strategies that can be done to avoid financial exploitation or financial abuse. But one of the things that I remembered when we did this, so we did a pilot study first to look at among those who have had financial exploitation, and one elderly gentleman who was quite careful with his finances actually. He's a retired person and he used to work with a bank, so he's quite literate in terms of this. But he was approached by a good friend to invest in this in an investment scheme. So he thought, since he is well versed with financial issues, so he said he will just take out a little bit and use that bit, and this is the amount that he is willing to lose. Right, so he went in the investment scheme, and And he did gain some money, but after 3 or 4 times, the whole thing collapsed. And he felt really bad because he thought, I mean, to him, he is supposed to be somebody who knows about this stuff, and yet he also falls into it. So when we talked to him, he said that, remember whenever we talk about health or well-being, we talk about these 3 or 4 groups of things, the biopsychosocial model, we call it, or biopsychosocial spiritual model. And we tend to think that the one in the middle is where we are, right? But he said, as you grow older, the needs are different. And the biopsychosocial model actually looks like the one in the other side. So it kind of overlap even more. And he gives an example. He remembers when his son actually played football and fell and fractured his foot. So what happened was after the surgery, he went back to home, and he actually brought all his friends to his house on the pretext of sharing homework. But they were actually playing video games. And he compared that to his wife, who actually fell and broke her hip, and then had to go for surgery and then came back home. And during the recuperating stage, she felt very, very lonely. So in the biopsychosocial model, when it comes to older adults, it's not like what we imagine, the big holes and then we're just right in the middle. It kinds of, the overlap is much, much, much bigger. And another interesting thing that he also shared is this. In my teachings of epidemiology, when I talk to my students about epidemiology, lever is like the seesaw. Everything has to be in a balanced position, right? In balanced form. And we tend to ask older people whether they are independent. So ideal. So things about being dependent is something that we always ask about. But to him, he says that humans are social animals. So one thing or another, we need friends, we need people, we need this interdependence, we need appropriate interdependence. So I think this is something that we fail to measure in research or in things. So to me, it's actually this balance between, when the balance tilts over the other side, then the risk of being abused and neglect is actually high. So trying to get the balance is actually something that, kind of need to think about. And again, he also felt very bad that he actually had this experience of financial mistreatment. He went into depression. He actually sought help, and he went to see a psychiatrist and a geriatrician as well. And they actually did cognitive assessment on him, and he said that he was not demented. I mean, there was no form of dementia. So he said, maybe there is other thing that was not measured. And I actually looked into some of the literature. This is not what we did, but this is a group of people in the US. But I think it's by a group of researchers or people who actually does this work, Duke Khan and his friends. So he actually looked at the brain, and there seems to be some form of specific regions in the brain that is associated with higher susceptibility to scams in groups of people. And this depends on where the changes in the brains are. So the frontal and temporal lobes, where is very important for decision making and cognitive control, is different as you grow older. So there are changes. So it just suggests, or it just means that maybe whenever the cognitive assessments are being done, it measures dementia, yes, I guess, or early part of dementia, or cognitive decline, things like that. But it doesn't actually measure decision making, and especially so in financial decision making. I mean, he always wonders, why is it that he, being financially literate but still fall into this trap? I wish I could tell him this, but unfortunately he passed away during COVID. But this would have been the answer to why even he himself, who does not have dementia and still very good in financial issues, still fall into financial exploitation. So I thought that was quite sad. Right, so a lot of studies have been done by Duke Khan and their friends, looking at gray matter and looking whether they are susceptible to scams among older adults. So this is some of the reasons why we will postulate why older adults are susceptible to financial abuse as we age. Having assets, right? They have lived long enough to accumulate health. among older adults in Malaysia, they might be assets rich. Most of them are assets rich. They might not have, so they do have, they have lived long enough to accumulate wealth, and they own house, they have visible assets, and this might lead them to be more likely to be exploited. People might find it hard to believe because of ageism, but I think along the ways, a lot of us have been talking about this financial scams or financial exploitation. I hope this is no longer true. And the issue of unlikely to report is actually quite high. Our study actually shows about 30% won't report, mainly because they feel that this is a family matter and it would have a lot of repercussion when they report, right? So they're more unlikely to ask for help, right? So this is basically the whole field of elder abuse and neglect, looking at the occurrence, the risk factors, the consequences of elder abuse and neglect, and how we can actually intervene, right? So if you look at the factors that we can intervene, you see legislative policies up there, remedies, laws, and a lot of preventive initiatives, as well as changing in terms of the social and cultural norms. With regards to talking about elder abuse and neglect, maybe 10 years ago, this was a taboo thing, right? You can't talk about elder abuse and neglect because you don't, obviously we don't agree. But now it's slightly a bit more easier to talk about it. And I think this is a change, so that's good. But I think we also need to do a bit more on in terms of the preventive initiatives. So we looked at the National Health Mobility Survey report, and we saw that with regards to reporting of elder abuse and neglect, among those who report, no one actually reports to the healthcare providers. So there was actually 0% there. And we felt that we were wondering why this is happening. And of course, the reasons why people don't report, because they don't want to implicate the family, that's about 60%. But the issue about healthcare providers, not because to me, healthcare providers were one of the first screening people that they could see, right? So this could have been an easier red flags that you can pick up. And so some of the things that we did was to actually come up with manuals among the healthcare providers. And a group of us actually taught the healthcare providers on how to pick up elder abuse and neglect cases and how to manage them. And we also looked at the evidence to see whether it works, and through the randomized control trial that we did, as well as through the quasi-experimental trials, it does help to improve in terms of the knowledge and the awareness of the healthcare providers to pick up elder abuse and neglect. We also tried to bring this up to the Ministry of Health. That was early 2020. Unfortunately, COVID came. So I guess this is a venue that we still have to work on. With regards to caregivers, we also understand that one of the things about caregivers is the caregiver burden, right? And it's not an excuse to abuse your older adults, no, but a caregiver burden is an actual thing. And one of the things that we also realized when we talked to the respondents is the issue about expectations among the caregivers, as well as what they expect that the older person can do. Because I guess if you don't manage the expectation well, then the likelihood of abuse might be there, right? And of course, understanding the older people themselves, the changes that happens among the older people. I think one of the things that we heard just now was about hearing impairment. And it reminds me of what happened with my grandmother. My grandma had hearing impairment, so she doesn't really like to use the hearing aids. So we tend to talk a bit louder whenever we see her. And I just reflect back that when she doesn't understand, does it mean that she can't hear or she doesn't understand what we're trying to say? So we tend to speak loud. I mean, it sounded as though we're shouting, and I guess in a way you kind of have to step back and just think about things that happen. So we've converted our books into e-platform. So this is actually Future Learn, and it's free for anyone to access this. It's just a 2-hour course per week for a period of 3 weeks, talking about caring for the caregivers. So this is not for the older person, but it's among those who are caring for the caregivers and trying to empower them, giving them some tips to help them in their journey of taking care of older persons. So we're moving. We're also moving towards getting things into e-form, which is much better. So in terms of how we have been responding to the issue of elder abuse and neglect or aging issues, I think these are some of the policies that we already have. We have our National Policy for Elderly in 1995. We have the National Health Policy for Older Persons in 2008, and then the National Policy for Older Person that was reviewed and looked at in 2011. Lots of Malaysia Plan, the 11-12 Malaysia Plan that talks about older person. And we also were told that we're going to have the first reading of the Elder Law in 2024. But we are now in May, so I'm not sure whether the month of or the years of 2024 is going to be enough for the first reading to come. But basically, when we talk about policies in Malaysia, the Ministry of Health and Ministry of Women, Family and Community Development are the major providers for health and social services. So a lot of policies general policies for adults as well as policies for older adults are in the two ministries, right? So this was what we were told. This was before COVID. Yeah, I'm wrapping up. Thank you very much. And as it is, we do not have any specific law, so I think it's quite urgent that we talked about the laws. And I hope that with 2024 coming, there will be some readings in terms of the elder law in the country. So these are also other things that we can do. This is last year by WHO that talked about what are the things that we can do to tackle abuse in older people. And one of the things that I think the first thing is combating ageism, which I really think is something that we do. This is just to say that this was what, when I talked to the older person just now, the older gentleman, he said how he went through or how he got over his experience of depression or depressive symptom by listening to Queen. And these are the songs that helped him through. I'm sure those who are in my era would know Queen. And this is the songs or the lyrics that he listens to get him out of his depression. So with that, I think some key takeaways. Elder abuse and neglect is common, can happen to anyone, anywhere, but it can be prevented. And longer life actually does bring opportunities. And one of the things that the opportunities depends heavily on is a person's health. So with that, I thank you.
Thank you very much, Professor Nooran, for this very insightful and detailed presentation. Just in the interest of time, we're actually going to collate questions and come back to you soon after. So thank you, everyone at the Malaysia Hub and to Professor Nooran for the session today and for the keynote. So our paper presentations are still going on in the boardroom. And at 1:30, please join us for lunch. And after that, at 2:30, we will be having a fellows and an invite-only session, a roundtable session on the outcomes of the program as such. And after that, at 4:15, we have the valedictory function, so we actually invite all of you to join. And for our colleagues at the Malaysia node, the Philippines node, and at the Nepal node, we are very grateful for your presence for the last 2 days. So please stay with us until the end of the valedictory section. And we really look forward towards seeing you towards later in the day as well. So thank you for joining us all, and look forward to seeing you after the lunch.
Delegates, slide. People in online mode, we will be starting very, very soon. So just bear with us. Give us a couple of minutes time. We just want to make sure the fellows who are in person, they are in this room.
Recording in progress.
Everybody is here. Just in a couple of minutes time, we will be starting the session. So thank you so much for your patience. Appreciate it. Do we have all the fellows with us? Can we start? Okay, all right. Can you please close the door? Thank you. All right, good afternoon, everyone. We are going to formally start this session. Before I start the session, can I just say that there's this wonderful saying which says that we don't learn from experience. So when I heard that for the very first time, I thought that's very strange. Often people talk about experience. I've got 5 years, 10 years, 15, 20 years experience, and experience is everything. However, the quote goes like, we don't learn from experience. We learn by reflecting on experience. And reflection is extremely, extremely important. So today, in the next hour or so, collectively, we'll be learning from each other. We will be reflecting on this journey. This whole session is divided into 3 segments, where we will have 15 fellows across 6 countries plus Australia reflecting on their journey, and collectively we'll try and learn and unpack a few very, very important things. So the first segment is going to be about their introductions and reflection, where each fellow will very briefly talk about who they are, what their background is, and then quickly reflect on their journey. Their fellowship is almost 12 months long and it's about to finish in June. So what you have learned, what is the most important learning for you as a fellow, as part of this fellowship is what you'll be sharing. So 2 minutes each. Then we'll move on to segment number 2, which is focused on the academic outcome. So Madan will be chairing that part, and we will reflect more on the academic outcomes in the paper, potentially from this. And then the third segment will be about a policy report outcome as well. So we'll formally get started, and we'll start with the fellows who are in the room first, and then we'll join by the fellows who are online. So briefly, in 2 minutes time, introduce yourself and talk about the key reflections for you on this fellowship. We'll start from here.
Yeah, my name is Geriatrics-Gobal, Associate President. It's been a fabulous experience being part of this fellowship. I think, the things that I learned is the investment business initially. For some speakers, it was what are working, not working, and also how
I'm here.
Also, I'm really how to get this. That's a very key.
Hi, apologies. We're from the Malaysian hub. Just want to say that we can't hear anything at all.
IT people, can you make sure that they, the delegates who are online, can you hear me? If you can hear me, can you give a thumbs up in the comment section? Right now I'm talking. If you can hear me, can you please give a thumbs up in the comment section so you all can hear me? Okay, fantastic. So what we'll make sure is you want to start speaking and see if you can hear from the next person now.
Yeah, my name is Mayalsia, and I'm a professor in public health dentistry at the Sharamti Dental College, which is affiliated to the Rajiv Gandhi University of Health Sciences, Bengaluru. And I have an academic background, public health, as well as dental public health. And the capacity building initiative, which was jointly conducted by DFAT and the Flinders University and ARIA, had a profoundly enriching experience on me. So through active participation, it has provided me an exploration of various themes. So the themes were aged care provision, encompassing diverse topics such as housing, healthcare models, and insurance-related policies, safety considerations, effective strategies for mitigating career burnout, and it has presented invaluable networking opportunities also for me. So I got to network with various people from spectrum of disciplines, including business, management, or healthcare. And it also helped me give a heightened understanding regarding spiritual and holistic health. And this has sparked a personal commitment for me to explore innovation as a strategy and leveraging technology in aged care. So specifically, I'm motivated to develop an app which is tailored to unique healthcare needs for sort of create platform that empowers caregivers to deliver more promotive efforts. So that's it can help in enhancing the quality of life. So in summary, the APACH initiative has not only expanded my knowledge of best practices in aged care, but has also instilled a deep sense of learning in me. So with that, I'm profoundly grateful for the invaluable experience and collaborative opportunities that this program has afforded. Thank you.
Thank you. So what we'll do is, as the fellows are speaking, please make sure the mic is really close to your mouth, because we want to make sure that all the online participants can hear us. So we'll pass it on to the next fellow. And while you reflect on your journey, can you please speak loudly and keep the mic very close to your mouth? Thank you.
Hi, I'm Dr. Lakshmi. I head the research at Indian Dental Association. So, Indian Dental Association is one of the very important advocacy stakeholders in India. Again, belonging to the background of oral health, something that starkly reflects me is it belongs to the larger umbrella of NCDs. And NCDs ultimately is something that's very coherently associated with aged care. When I had been during my fellowship stint in Australia, what I could really observe is NCDs is something that's always taken a back seat, be it in developed country like India or a developed country like India. So what I would like to take forward from here is to draw parallels and understand as to why NCDs are taking a backseat in both these countries, irrespective of the differences that we have in the economic and the socio-cultural backgrounds. And I would also like to further take this up at different levels of education, wherein we try to look into more kind of integrated multidisciplinary approach with a workforce skill mix. Enhance the research opportunities, be it through the collaborative efforts, so that more and more evidence is being generated to inform the policies, and then further go down all the way to the services delivery of the services level, wherein both the countries, I think, need to invest more funds, allocate more funds for research as well as for the addressing of the NCD burden, which is globally increased. So I'm really thankful for the APACH Fellowship for giving me this opportunity. Thank you.
Thank you. Thanks, ma'am.
So good afternoon, everyone. I'm Dr. Trivedi, medical doctor trained in public health. I wear multiple hats. One is I'm a public health researcher and a project manager. The other side, I'm also running an institute where we provide healthcare for free for the low poverty line people, dialysis and outpatient services, mainly focused on NCDs. So even my research mainly has been focused on NCDs. Apart from that, I'm running to residential aged care homes in Bangalore. So I am putting my feet in two sides. One, I'm looking at the policy for the aged care, and the other one, I am the service provider as well. So these two aspects makes me sometimes wonder that when I talk about the policy, I am already thinking, is this implementable? What are the challenges I'm going to face? So I feel, I don't know whether it's a strength or, what I'm bringing with this fellowship. I just want to highlight what this fellowship meant to me was that the one very striking thing which I noticed was how very well Australia is regulated, or rather say over-regulated, and how under-regulated Indian system is. We are nowhere there, even at the starting point. We don't even have a registry of the number of centers, what's happening. So that was very striking for me. And the second thing which was very a great learning for me was that aging and aged care is completely different from dementia care. As a service provider, the dementia care is a much more challenging thing than just an aged care service which we are providing. And the third thing which was very interesting and which was very useful for me was the visit to all the centers, different centers we did it in Australia. And that gave me a wider perspective of the services, how they're incorporating and multidisciplinary teams they have and how they're working together. And also the challenges of workforce which they face. And it's nothing new here as well. Here, I'm also facing the same challenge here also. So though there is a drain of people from Nepal or from here to other countries, but even India is having a huge shortage of people. So there are many more learnings. Without taking a much time, I will come back and talk, and I want to thank for this fellowship and networking. Yes, I should say networking was one of the greatest thing which happened. We definitely in Australia, and here this 2-day session was wonderful.
Thank you, Trivedi. We'll move on to the next fellow, which is, yes, Dr. Acharya.
I'm Dr. G.P. Acharya, Professor of Operations and Supply Chain here in hospital, University of School of Management. So the Master in Awards program has given me its knowledge, also motivated me to continue my research in this healthcare population. This research is really impressed me and exploring all kinds of models. And there's given us opportunity for me to have networking and healthcare facilities in Australia, and a lot of gap between Australian models and the scope for a lot of improvement in many areas in terms of technology. So now I started working on that and I made a proposal to the Indian Council of Medical Research. The topic of enhancing aged care services in India, bridging the demand and supply gap through recharge and technology interventions. And as a part of that, I started visiting some aged care facilities. Senior citizen facilities have visited so far and start understanding how the population, people are going to respond. Physically, I want to see the facilities. Then I come to what kind of research I can continue. And then also one more paper I'm presenting on sustainable solutions for sustainable healthcare systems. That is nurturing resilient communities, sustainable solutions for aging societies. That's a paper I'm going to present in the College of Professional Continuing Education, CPC, in Hong Kong Polytechnic University. They have a Center for Aging and Healthcare Management Resource that is supported by SHAPE, that is Society for Health Administration Programs and Education. So this is an opportunity again. This platform has given me to continue and explore further avenues. So really the program is really interesting and also it gave me a lot of energy.
Thank you so much, Dr. Acharya. Move on to you now.
Thanks, Raj, for that. Are we audible? Because we are getting some feedback that the voice is not audible. Can the online participants just confirm that we are able to hear us? HONG018. Can you hear us, sir? Okay. Can someone from... Okay. So probably we'll pass this mic, which I'm speaking, to the rest of them so that they can hear loud and clear. And also, as Raj told, probably we need to have the mic closer. Anyway, I am Dr. Nandakumar. I am a professor in community medicine at Ramaiah Medical College, Ramaiah University of Applied Sciences. And I've been a fellow of Australian Awards Fellowship for this Aged Care Asia Pacific Hub. For me, the journey has been more exciting than the destination. And I've made friends, which I'm sure is going to last for a lifelong. And what is the best learning is that because we have had these collaborations which are coming in, because when we say networking, it refers to something which we can leverage for level A, but this is comprehensive, which has changed my perspectives about certain things. And looking at aged care from a global context, I had a project with Sweden universities. I have worked with American universities, and Australia, this is my first exposure away from the Indian context. So when we contextualize, the problem is aging and care of the aged. But when we look at the solutions, we can learn from each other is what I felt. Especially when we look, the first output of the association has been a paper with Madan and team, where we have published the UN Healthy Aging Agenda and its contextual relevance in India. This was part of a series of aged care papers with Angie and Madan were the editorial thing. So that's the first outcome where we are seeing that it's not, be the regulations or something which might be good in one context, need not necessarily be adapted or needed in another country or this things, where family is the core in an Indian context, where we consider even the nuclear families have an elderly parent, some who lives close by and other things. So in that situation, the social constructs, the economic constructs, and the technology constructs that we are talking about, I'm sure that there will be a convergence of these things adopted for the local settings. So that is where my journey is beginning now, where we are trying to put together especially my interest has been in informatics and using technology for primary healthcare. So I'm very sure that like with the group that we are having and the kind of discussions, both training, capacity building, curriculum, and also using the technology to reach to the elderly in a positive manner so as to making aging not as a condition, because we are saying burden of elderly. It's not a burden. So we are going to see how we can leverage that and also work with the policymakers, and I'm sure we will be the change what we want to see. So it's been a very fabulous journey. And the all other things that have emerged are certainly the institutional collaborations and with people and other collateral benefits is what I would like to call. And having this conference at Ramaya itself is a testimony where we have brought together all the fellows from different countries onto this virtual and real platform. So I'm thankful to Flinders University, DFAT, Australia Awards Fellowship Program, and all the fellows from all the countries who have participated in it. Thanks a lot, Raj. Thank you.
Thank you, Nandu. Now we'll be moving on to our online participants. So we have got nodes in Malaysia, Nepal, and Indonesia. So can I request our fellows in Malaysia to kindly unmute yourself and take turns to very briefly introduce yourself and share your reflection on your fellowship so far. So over to you, the fellows in Malaysia.
I'm a professor of geriatric medicine at the University of Malaya, and I'm a UK-trained geriatrician. So my prior exposure to aged care has been very biased because UK is an island, and very insular at that. But I had been in Malaysia for about a decade, so I had also been exposed to some of the practices primarily in the Far East. So this has been a real eye-opener because all of a sudden, we all seem to have the same problems. And so it, compared to all the other countries that I've been to, and we really can work out common solutions. And jointly, we already have solutions for each other. So I think there is a huge possibility of long-term collaboration, and I'm looking forward to starting anytime soon.
Hi everyone, good afternoon. Kajal here, geriatrician from University Malaya Medical Center, also working with Prof. Tan Maupin. So I think the last year in being part of this APACH fellowship has been really an eye-opener. Number one, I think I got a bigger picture of what an ideal aged care service would look like after my visit to Australia. But of course, with a lot of twists and local adaptations and modification to what I can bring back to the local context here, given the diverse culture and the values that we hold on to. And I think the strong benefits and the values that we have is the fact that we tend to hold on very strongly to our family values and, wanting to care for our aged or our parents back home. So if we can get some of the expertise from there and adapt it to what we can do here locally, then that combo would be like a perfect solution to what we lower middle income country can actually do given our limited resources. Secondly, I think at least for the last 2 days, the exchange of information and skills has been really, really good, which we can actually bring home. And like Prof. Dan said, we probably have got problems and we would be able to find simple solutions without the need of really hi-fi investments needed. That's about it. Looking forward for better and more future collaborations. Thank you.
Thank you so much to our two fellows in Malaysia. Very kind of you. Now we'll be moving on to Nepal. So can I request the node in Nepal to unmute yourself, and both the fellows in Nepal, if you can take turns to briefly introduce yourself and share your reflection on your fellowship, please.
Am I audible?
Yes.
Okay. Am I audible?
Yes, you are.
Okay, we're extremely sorry because the two fellows luckily have a meeting in Australian Embassy now, and they're discussing about these things at the moment. So I think we could express what we've learned just in a brief, because I'm not the right person to tell because I was not there. But what, as a team member under Kalbin Maliku and Dr. Prabhat Adhikari, me, Anjana, and the team have been looking closely on these programs under ARIA. And what we found out attending all the sessions together, even on the last meetings, we learned that it's about collaboration. It's about working together. It's about aligning our objectives together so that we can work together. And like our former participants had already mentioned, it's not always implementing the exact things in one scenario to the current scenario. Likewise, example, our society, the society in Nepal or India, the core concept is about families. Likewise, what we've learned after the fellowship thing, we've understood now at the moment what the team members here, we have been collaborating to in policy advocacy, as the speaker yesterday was a parliament member, also a doctor. Beside that, we have visited some private, unfortunately, some private, because we only have one aged care center in Nepal that is run by government. We have visited some aged care center and we walked for what went well and what didn't go good. And we have maintained a sustainability plan. We have prepared a sustainability plan. We have worked on the research articles on aged care, especially focusing on geriatric care in Nepal, which unfortunately has not been worked out a lot in Nepal. And we have found out that there has been almost negligible number of geriatric nurses or palliative care nurses in Nepal. In these areas, as a youngster emerging in this arena, learning from everyone, the expert, eminent personalities there, it has been such a great pleasure for us to learn from all of you, from simple things to the things were very complicated. I have to accept it because the things had gone wonderfully well, and the participants had allowed us to understand the details of the topics they were explaining. So we, from Nepal, a small hub country with its own beauties, we appreciate the opportunity that is provided to all of us to learn. And what I want to request all the team here, at least, is to conduct these kind of programs wherever possible and have hub center. It's well and good, have hub centers and make more participants aware so that this is taken into grassroots level of every countries, be it Nepal, be it Malaysia, be it India, any countries, Australia. So we really appreciate your support, and I hope if our participants join, they might add further later. And thank you for the opportunity provided. Thank you so much.
Thank you so much. Please convey our best wishes to the two fellows from Nepal. And I think you have done an excellent job of representing both of them, and you've done a wonderful reflection. Now we'll move on to our fellows in Indonesia. So can I request the fellows in Indonesia to please unmute yourself and very briefly introduce yourself and share your reflection, please.
Okay, thank you. I'm Faradila Mirsanti. Hi everyone, I'm Faradila Mirsanti. I'm a medical doctor and a government employee from Surakarta City, Indonesia. I would like to thank you again for all this opportunity supported by Australia Awards, DFAT, Flinders, ARIA, and Ramaya. And for me, the almost 3 weeks fellowship and these 2 days of conference has gave me very insightful things about the aged care, and what I learned is that there is so much to do in Indonesia about the aged care. So I think I would like to. What I have done is that I think I would like to start from the community-based aged care in Indonesia. My proposal with other colleagues here for grant from 11 Maret University is being approved. This is about the aged care, about the frailty and ageism, and we are doing it for this 1 year ahead. And also I make AIDS care issue as the topic for my project in leadership training program here. This leadership training program is a mandatory for a government employee to go for higher position. So with all this, I hope it will give more insight for government here about the AIDS care. Thank you.
Thank you. Over to the next fellow in Indonesia, please. You're muted.
I think he lost connection. He will join soon.
So in the meanwhile, while we're waiting for them, can I request our two fellows in Philippines to please unmute yourself and share your reflection?
Hi, hello, good afternoon. Mabuhay from the Philippines. I'm Ivan. I'm an occupational therapist. I work as an associate professor and researcher at the University of Santo Tomas in Manila, Philippines. I was trying to look back on the experience of staying in Australia in this past 2 days, and I have to admit, it's easy to get blindsided with bright, shiny new innovations, research, and practices. But what area and what the APAC has always been teaching us, it's always think as to how this can be contextualized in their country. So there's always that challenge of bringing what you've learned into your country and making sure that it actually works. And the second thing, probably it's the inspiration as to what ARIA is doing and how it's networking, how it has networked in Australia, how it has networked in the Asia Pacific region. And it's that challenge again of trying to replicate that network locally here in the Philippines. That's it for me.
Thank you, Ivan. That was wonderful. Can we have the next fellow from Philippines, please?
Hello, good afternoon. I'm Dr. Trisha Bautista. I'm a geriatrician practicing in public hospitals, but I'm also into academe, teaching medical students and residents. Well, for me, I think just like for everyone, it has been very enlightening. Much has been said, but in terms of what it really taught me is that we need to really act now or else it can be too late. And there is so much to really fill in the gaps. But then sometimes I feel like it's too overwhelming, especially with all the information that we received for the past 2 days. But if we want to really make things happen, it's all about coming together with like-minded people. And so I think for me, I gained confidence in searching for people who are also championing aged care. And with that kind of collaboration, we can make more impact. And as what others have also said, context is very important. There's so much to learn, but we need to put it really into practical terms. And we need to start somewhere else. And so what I have initiated here after Australia are the community-based activities for seniors. And that has been running since October of last year in 3 different community sites. And our team will actually be visiting Kuala Lumpur in University of Malaya next month. And that is, I think, a product of this networking and collaboration. And I hope that this kind of linkage will continue and be sustained until we all reach our goals or targets for our senior citizens. And thank you to APAC for the wonderful experience.
Thank you, Trisha. Do we have the fellow from Indonesia back here? Are they online? If they are online, can you please join us now? If not, we will continue the conversation and you are welcome to join us as and when you come there. So do we have the fellow from Indonesia here yet?
Sorry, I think not yet.
That's fine. So once they are here, just let us know. Write a text in the message box.
Sure.
We'll alert it and we'll involve them.
Sure, I have.
Thank you so much, all of you. I think it was really nice to hear your reflections in terms of whether it was networking, collaboration, the cross-pollination across different countries. Very, very heartfelt reflection. So thank you. With that, we will move on to segment number 2, which is about academic outcomes. So I'll hand it over to Madan to facilitate that further. Over to you, Madan.
Thanks, Raj. So in terms of academic outcomes, I think we had this discussion earlier that we are going to be working on a thematic series of 2 papers, one focused on models of care in health workforce, and the other focused on policy and regulation. So we have had some discussions earlier, when you were in Australia, and we had some discussions over the last 3 or 4 months. And what we want to do now is that very quickly pass on to you, maybe just 2 minutes each fellow, have a minute to reflect on models of care and health workforce, have a minute to reflect on the policy and regulation, and start thinking on that note as to where you are and what do you see is important in your country and region. And try to see in terms of data, in terms of issues and challenges. So I think this discussion would sort of segue into what we are planning later on. We would have more detailed discussions later. So I think I would first start with Teddy here.
Yeah, thank you, Madan. I think with regard to the care models, I think, because we listen to various, range of care models, that has been practiced, tested in Australia, in other countries, as well as in India. But I think, one of the common things that I notice across the Asia Pacific region is this community-based and social care model, where actually taking the care to the doorsteps of elders and their households. Even though things are changing, the living arrangements are changing, but still in the Asia Pacific region, we have more of community-based care models being existing and also being delivered. So I think, one thing that I probably would recommend to be added to the paper would be to focus on the community-based care models, and also when it comes to the policies, there are a lot of issues that, of course, that comes to my mind. One was, of course, having a proper regulatory frameworks, and also to what extent the problem that is addressed to the policy are really captured, the real problems, whether those are real problems or probably to what extent it is driven by the evidences. Because unfortunately, for example, one of the scoping reviews that we did in India, we don't have adequate evidences to actually, back up the policy provisions in India. So we have around 15 different policy interventions. But however, what's happening is there is not adequate evidences to substantiate, okay, this policy provision is critical. This policy provision would, address these concerns of elders. So that backup is something that is missing. And also, of course, in one of the discussions with Andreas earlier, so we were thinking, how these monitoring and evaluation frameworks are kind of integrated into the policy documents, and also subsequently into the program, frameworks. So I think, these are some of the things that are crucial, and also particularly when it comes to the, wage care work, I think we've been discussing about workforce. To what extent resources are allocated to build the workforce in terms of training, in terms of, of course, training people at different professional disciplines, start from geriatric medicine into social work, into psychology or dental dentistry. So I think, these sort of things we need to keep in mind. And also, I think the other factor that also we've been discussing about to what extent we can leverage technology in aged care. And again, unfortunately, in policies in India, we don't have that much of emphasis being given to optimize the technology in aged care services.
Quickly, I just want to add about the thematic papers we are going to do. We might not be able to involve everybody as an author in those papers. So probably when you are actually talking about that, would you just indicate which of the paper you want to get involved with, and then we'll take note on that, and we'll probably have a communication later when you're actually developing those papers. Thank you.
Just to address that, I think, of course, I've been assigned to work on the policy paper. So I'll be there.
Thank you, Madan. So just give me a moment. I would be happy to work on the thematic series and like to mainly concentrate on workforce oral care models in rural India. And these are preventative oral care models where we would look at, sort of oral health promotion, delivering primordial care, primordial levels of prevention, focusing on that, and looking at how this could later help in us writing some policy briefs, which probably would be put forth at the state and later the national level. So mainly, I would like to focus on the preventative aspects of oral health care, how it could reflect it further. Thank you.
Just to very quickly add, in terms of the papers that we write, we have about 3,500 to 4,000 words, and we're doing a comparative analysis across 6 or 7 countries, including Australia. So, and each of the fellows is going to be input, is going to contribute something from his country, and also the region as well. So, it might be a good idea to take a big picture perspective, because these two are going to be commentaries. So we're not primarily looking for scientific research articles for these 2 papers. So that is one thing which I want to add with the sort of discussions goes. Okay. So let's just move on.
I think I would be happy to contribute towards the policy paper. Again, drawing the parallels between both India and Australia, looking at different policy dimensions, be it the windows of the policies, who have been the actors and the institutions who have been involved in the policy making as far as geriatric care is concerned in both the countries, and what have been the barriers and facilitators for policy formulation and implementation in both these countries. So would be very happy to contribute my part on the policy.
I would be more interested in models of care and also look at the out-of-pocket expenditure for that, because in the Indian context, number one, the culture plays a major role. Still 70 to 80% of them elderly are taken care at the home. And those who are sent to the aged care homes are for various reasons, maybe because of the migration or for various reasons in the houses. So, and the government is not supporting in any way. It's not subsidized, or it is completely coming as an out-of-pocket expenditure. Either the very few elderly could pay themselves, or they're dependent on the other children. So I'd be interested in looking at models of care, because as of now, in the Indian context, because of there's no regulation, everybody has their own model. When I say I'm running 2 centers, I am running it the way I feel is the right thing to do. Somebody else is doing the way they think is the right thing to do. Now with all these learnings, now I've decided that we need to have one separate dementia unit, otherwise it doesn't work. So I want to look at how in the Indian context, people are coming with these models and how is it functioning. That's where I would be interested. And I already have collected some information about by calling few centers, how they're functioning. I have a data of almost around 25 to 30 centers. What is their mode of operation and what is the fee structure? All that information I already have collected. Maybe we can talk more about that.
So I would be interested in models developing. My area of specialization is operations and supply chain. So I have already done some framework, developing a framework on supply chain model for aged care industry.
So how these different from source to destination, who are the stakeholders involved in that, and what are the different flows involved, workflows involved, from like financial flow and material flow and information flow. All these things I'm going to study from various stages. Ultimately, how do we improve the quality of our service to the basic care society? So that's my area of interest.
Thank you. I would be specifically focusing on within the model, contextualizing the available model for the Indian context. Because when we look at the various, from the literature point of view, we have that evidence. So to map it from the various levels, whether it is residential model or those things from the Indian context, that component. And when it comes to the health workforce, the training and capacity of the formal providers, because we were discussing about the medical allied health sciences and the nursing curriculum. Today, there is a gap where the assessment and interventions are not very well defined as a competency. So in fact, we are looking at developing those and building evidence to include it so that at least the formal healthcare providers are competent enough to do what they are supposed to, while we look at the larger component. So that would be a very critical component, especially from the APAC forum, to say that like across while you're training, it's not just the pediatrics and the adolescent health, it's the geriatric which needs to get that as a desired and essential component of training as well. So into that. And with regards to policy part of it, like I'm still not very clear about what we would want to do in terms of, because like analysis of policies, the strengths, weaknesses, do we have a policy or not? That thing is happening. So once you have something which has a public health impact, and from the work, if I feel and the group feels, I would like to contribute there as well.
So I would now move on to the Philippines Hub, probably with Professor Trisha.
All right. I think I'm quite torn, but I think I'll be more interested in the models of care, particularly in the determinants of quality of life for the older adults. And so that will include determinants of active aging. But particularly more for aging in place and community-based models of care. Now for policy, why I am also into this one is because I wanted really to strengthen the intergenerational engagement. And so I think workforce should also come or should be developed as early as possible, meaning even during primary school and high school. So I feel like engaging with different generations should be part of social studies subject in those settings, so that it will not be difficult to recruit them when they're already adults to help take care also of older adults. Not necessarily just taking care, but at least in how to communicate and collaborate with other generations. So, okay, I'll just sign up with models of care. Thank you.
Ivan, if you're there with us.
Yeah, sorry. Yes, I am. It just got a little bit choppy there. Yeah. So one of the things I did when I came back is I worked with some students and we did review policies, laws, regulations at the national level that has influence on aged care. And some of those laws and regulations were actually presented by Dr. Loreche a while ago. We specifically looked at rehabilitation policies and regulations, and we found out there's none. That means I think I'm leaning towards that particular stream because we do have that initial scoping of the laws and legislations here in the Philippines.
What about Farah next?
Farah, can you hear me? Farah, can you?
Hi. Yes. Yes. Well, for the policy in Indonesia, there are some policy. I think support the welfare and the health provision, but I think most of the policies that work well. So because most of elderly lives with their family, so I think as the ADP presented before, it is today that community-based aged care is one maybe is the opportunity to improve the aged care in Indonesia. So I think in spite of all the policy which has made by our government, I think it is important to focus on the community base and support it with the new policy, with the policy here.
Thank you for that, Farah. So I'll move on to the Malaysian hub now with Professor Mausman and Kejal. Can you keep it brief, please, just in the interest of time?
Hi. I'm probably more interested or more inclined towards the policy, only because I think we have got quite a number of acts and regulations here, but probably not well implemented. Also, I was just imagining the paper where if we can draw some parallels, similarities, differences between the different countries in our region, try to address the gaps that we have locally, and eventually give or propose some solutions, some easy, short-term, mid-term solutions would be really great. And this will be probably tying quite nicely because our country is also working towards the aging blueprint. So hoping to try to contribute to that.
Hi, I don't mind doing policy. Models of care will be extremely complex for us because we have so many different models of care. But with regards to policies in our country, we apparently have good policies. The problem is with implementation. So I think we can look at policies, but I think we are not the only country in Southeast Asia with excellent policies but poor implementation. So if we were going to look at policies, we will have to look at mechanisms by which you would implement the policy, because our government gets away with a lot by making really nice policies and then not implementing them. And we have got acts of parliaments that have been passed now for aged care. In 2019, 5 years later, the policies to and implementation attached to this act is still being heavily debated. And then we also have this elder care. It's not elder care. The law for older persons, whatever it's going to be called, and whatever it's going to be included. It was drafted in 2019, so it's still not come into force. Not even being read out in Parliament yet. So implementation is probably also quite important to look at.
Thank you for that, Margaret. So in terms of the Nepal hub, Jyoti is traveling to Nepal and also communicating to Prapath to actually keep them updated. So thanks for that. So before I actually give it to Raj for the next segment, very quickly, I was talking to Raj yesterday about the levels of integrated care. And whenever we talk about integrated care, there are usually 3 levels. We have facilities, we have integration at the levels of facilities, integration at the level of services, and we have integration at the levels of services. So technology is still the so I was actually talking to Raj about it. And when you are talking about models of care, you're also including technology in it. So for those who are actually working on technology, it gives us an ability for also to reflect on technology in the viewpoint of policy care. So that's a direction that we could potentially take. And also I noticed Akram is there. Very quickly, Akram. Akram from, sorry, Ahmed from Indonesia. Very quickly, you can just introduce you to us and just on your things, fellowship. Will be very quickly.
Thank you. Thank you, madam. I'm sorry for the I lost the connection due to the lost connection.
We can't hear you, Akram. Can you actually raise the volume?
Louder, please, Ahmad.
Yeah, I'm sorry, madam, for the I lost the connection with the internet and the lack of electricity in here. But I want to add in some comment about Paradila from Indonesia. We're also interested in research about models about the successful aging in Indonesia. For example, like health-related behavior to the successful aging in Indonesia, and also we also interested in adding some what is the policy that have been done and what is the bottleneck for the how successful aging in Indonesia is lack of success in our elderly in Indonesia. So I think this is our interest in research about Indonesia, elderly aged care in Indonesia. Thank you.
Thank you so much for that, Ahmed. I'm just very quickly going to pass it to Amrita, our invited guest from the church. Amrita and I was actually, we're actually talking about data, we're actually talking about policy regulation. Can you share your views about this?
Yeah, I heard all the fellows. First of all, I can congratulate everyone, and I think it has been a pool of wonderful resources now we have for the region who can contribute for the aged care. So I'm really happy to be there with all of you at this forum, and I'm really delighted to see your work and your contribution. So I heard your ideas, and I realized that all the topics which you mentioned are relevant. However, we should, yes, focus on policies, but we know all the policies, listing the policies is not enough. We have to see whether they are being implemented or not. So listing the policies, just giving numbers, I think this work has been done by many organizations. Even if you ask countries, they can give you a record of it. So maybe that is not going to be at any kind of further value. Maybe analyzing those policies in terms of allocation of budget, allocation of resources, human resources, and other things, commitment, political commitment. That is going to be very extensive work. And if fellows are willing to do something like that, that would be useful. Then coming to the models of care, I would like to emphasize that fellows should focus on, yes, definitely seeing the models of care by the lens of continuum of care. So by the lens of continuum of care, so if you are going to an aged care center, definitely you should ask like how it is connected with the referral linkages, how they are connected with other kind of services. So maybe continuum of care lens should be the ideal thing to do, rather than just going and monitoring one care system. So that is another thing. And then people were also mentioning about oral health, dental care, and other things. And here I would like to mention that maybe grouping it with maybe 2 or 3 more interventions, and we can say life course interventions. So maybe life course intervention, the interventions which were done maybe at a very at the childhood stage, means or maybe dental oral hygiene, or maybe teachings how to brush your teeth, how to all those things, how they impact the oral health in later life. This is the intervention. And if we make a case that these kind of interventions can improve, can impact the trajectory, basically how the people move from
losing their intrinsic capacity and their functional ability. So if you relate that intervention with that lens again, that would be more interesting and useful in terms of giving any policy advice or Then another thing I want to say that at the end of the day, whenever we are writing papers, it should be comprehensive, it should be linked. Another time I'm emphasizing, don't take it in a silo. Every time you connect it with the continuum. And yes, definitely evidence-based recommendations in this area especially are lacking. However, every country context is different, but we need to know what works, what doesn't work, what is scalable, what is sustainable. So maybe one aged care which is able to serve maybe 100 people might be good for a country which has some few million people, but might not be scalable in a country like India or Bangladesh or Indonesia with bigger population. So maybe keeping those things into consideration. However, that model also is useful for smaller countries. But whenever we are giving advice, keep that under consideration that everything will not be applicable for every country. It is a kind of a one size doesn't fit all. So those 3-4 things maybe overarching would be helpful, I think. And I'm always willing to support the fellows without any my personal, I would say, no interest, but just as a person, as a professional, as a previous academician, my interest in this area, I would love to support you with all kind of data we have or all kind of knowledge I have, I may contribute. Please feel free to connect with me anytime, and I would love to respond to you as quickly as possible. Thank you very much, and I have a flight to catch it, so I will be leaving in 5 minutes. But I'm really thankful to organizers, to Dr. Nanda, all the fellows, Flinders University. You have been such a good company, first of all. In the last 2 days, I cannot tell you like how much I had kind of fun. It was a fun learning and, networking. It was nothing like I had to make an effort to network. It happened automatically. Everybody was, so it was such a pleasant experience. I really loved it and thoroughly kind of joyful as well as thorough learning. I learned a lot. And now I am connected with these 15 fellows, Flinders Universities, Ramaya University, Madam, everyone. So I am feeling very much empowered. And thank you very much. Wish you all the best. And all the fellows, congratulations. All the best in your further research. Thank you.
Thank you so much, ma'am. We are very grateful for your support, and we look forward towards working and collaborating with you. So now we move on to the next segment. I'll pass on to Raj.
Thank you, Madhav. I think in the past 2 days, we had 4 panel meetings, and we had 4 panel conveners who were convening those 4 meetings. And they were Shyam, Kajal, Triveni, and Teddy. So what we'll do is these 4 panel conveners will be taking initiative in terms of drafting the first draft on policy report outcomes. So I would encourage all these 4 fellows to very quickly share their insights so far. So we'll start with Shyam.
I get your question once again.
All I want you to do is I want you to reflect on the policy report outcomes based on the panels you chaired. Okay.
So I chaired this session on addressing the healthcare challenges today. So I found that we had people from diverse disciplines, and general physicians and people who are in the area of community medicine and public health, and also people working for non-governmental organizations also. So apart from including the geriatric medical education also into the framework, we had people who had innovative ideas to tell us more about how the elderly could have a productive lifestyle and also develop a good social support system. So that was one of the things which I came across. So probably we could focus on that, and also about how elderly physical and social well-being would contribute to spiritual well-being. So that's another thing. And also we could integrate the technological aspects into the elderly care. So we had a lot of insight from Dr. Ramaya and yourself, Raj. So I would summarize this in this particular.
Thank you so much. Now I'll move on to Triveni. Triveni, if you can put on the lens of policy report outcomes based on the panel meeting you convened and talk about it briefly.
I will talk about innovative models of care and health outcomes. Yeah, I think the one thing which was highlighted by all the panel members who were in India in person were the lack of information and awareness of aged care management, and also it's in India it is still evolving, and within the lack of information out there or the awareness how to manage was one of the things which was highlighted by everyone in the panel who were present on the dais. And also the second thing which was the very prominently which came out was the stigma of cares sending the parents or their loved ones to the aged care center, the stigma which was attached to that, and the burnout of the caregivers. How can that be addressed? That was one part of it which was very prominently came out from many of them. And the second thing which was discussed was the important point was healthcare need. How can the care be integrated? Not necessarily it has to be medical care. It can be allied. It can be more than medical care. How can that be integrated? Which is even now the care for aged is looked as a medical management, not as a natural aging process. That was another thing which came out. And also I think from Darren and Lee, who were more talking about the technology, and also when I looked at the panelists who were from India and two joined from Australia, there was a lot of talk about the technology, which is much, much advanced in Australia, the care for the aged with innovation and technology, which nobody addressed in the Indian context. And also another challenge, which was another issue which was looked at was, though there are the models, different models, how do we look at the acute, the chronic and the palliative? How do we differentiate this, and how can this be addressed at the centers, and how can they be empowered to do it? And there again, the technology part came in for the discussion at that point. And the last thing which was which I felt was important, the discussion which came was how can the technology be used to reduce the cost of care? As I earlier said, in Indian context, it's 100% out of pocket. There is no subsidized thing other than the below poverty line. People, everybody, it's 100% out of pocket care. So how can this technology can be used to reduce the cost of care? And for the final point I want to make was it's an unorganized sector and it is not standardized. How do we standardize, and how can this be made as more with the guidelines and more training. So there's a lot of things which came in, which is wide and not really fitting in. And I think what we missed in that in the discussion due to the shortage of time was we really didn't get in detail about the model of care, though there was a lot of discussion which went around the workforce. So I think I should just make it more comprehensive presentation of what I have written it down and share it later.
You have shared it very beautifully. Well done. Thank you so much for that. Now over to you, Teddy, if you can reflect on this, on the panel you convened, please.
Yeah, thank you, Raj. Yeah, of course, we had these 8 different questions related to that. And of course, we could not cover all just 3 questions. And again, within the 3, there were very rich discussions. So looking at the current challenges in aged care policy and regulation, yes, one thing that comes across in countries was unregulated aged care industry. In Malaysia, it was reflected as well as in India, of course, except in Australia, which is really, really well regulated. I think there are a lot of these learnings we can take from Australian model. And also another important thing that Dr. Anupama highlighted was this, to what extent the life course approach is kind of used or probably looked at from the policy perspective. So that's something I really agree that that's a very crucial thing, because here in the policy we primarily talk about when they reach the 16th over. So what happens before that? Because they need to prepare. So I also feel that start these policy provisions or interventions from before that old age defined age. So that is I feel it's quite crucial. And also, I think from the Indian perspective, there was this social connectedness that also need to be considered. And secondly, we talked about these benchmarks and international standards, which Dr. Amrita was talking about. So I think, yeah, she also talked about this quality assurance, to what extent, we divide that into essential and non-essential, desirable ones, and also making it right-based approach. So that's the thing. And also another important highlights of this, what we are going to do, for the future, basically what policymakers can anticipate and how they respond to future challenges. The very interesting topics that came up one was climate change and how it impacts aging. So that's another important thing. And also, food security, and also we need to see probably the policies need to be informed based on what is happening at the grassroots level. So those are the things. And also with regard to workforce, there was one small discussion that happened was, basically regulating the practice of various professions.
Thank you so much, Teddy. Now over to you, Kajal. If you can unmute yourself and you can reflect a little bit more about the panel you convened from the policy report perspective.
Thank you. Thank you. So my panel was basically on clinical geriatrics, the challenges and the solutions. So I'm not very sure whether I can see it entirely from the policy lens, but I can definitely see it in terms of some form of implementation that has been actually utilized by the experts given the local challenges that they were facing. So I think the first thing that was really glaring among all the panelists is actually how they have utilized their own modification and adaptations to engage the community and to get the local people involved. So a simple example was how our Indian colleagues actually get those, school leavers, the 10, 12 school leavers, and, train them to then now go on and train and look after the older persons. So that was one thing that I think it's actually similar in all the other regions except for Australia. But at the same time, this might actually be able to answer and help to solve some of the workforce issues as well. That was number one. Number two, we also discussed on the role of multidisciplinary or integrated care. And all the panelists also agreed that, it's time to actually get the care to the people in the community. And it's no longer the tone that, when multidisciplinary teams means different specialities. It doesn't need to be that. It's actually just allied health professional, advocates, people who can actually go out to the community and reach out to the people to tell them what works best. And actually really speaking, a peer-to-peer advocate will probably do the best compared to us doctors, just telling them in a very didactic manner what needs to be done and what is not to be done. Thirdly, the other issue or theme that emerged was also the need for training and education And I think in this policy can change because we seem to be talking about healthy aging only when people start aging, but not realizing that this is a life course thing and needs to start from early on, right from school, telling them how to look after age well, and then slowly goes on. So that was the third theme. And finally, we also briefly discussed about costs. But I think there's really no one size fits all for this. And even the panelists also just mentioned that we will slowly need to work together. There needs to be private-public partnership. There needs to be partnership with our NGOs to try to make things work. And yeah, mainly that's that. Thank you.
I think all the four panel conveners did an absolutely brilliant job of synthesizing some of these points. Now we have moved to the very, very final element. In the next couple of minutes' time, we have 6 fellows who are here in person, and then 9 of you are probably online and away. So what's going to happen is I will be handing it back over to Madan so we can award the certificates to the fellows who are here in person. Those of you who are online or remotely, these certificates will be shipped to you as well very soon. So over to you, Madan, for awarding the certificates.
Thank you, Raj. I think it's the most important component. Even though the fellowship is not officially over, we would still require the paper outputs, still require the policy outcomes, and probably another couple of grants as well, another $1 million. So that'll be really good. So can I actually ask? So these are from the DFAT, Department of Foreign Affairs and Trade. These are the official Australia Awards fellowship certificates. So can I call upon Associate Professor Teddy Andrews, Jai Hind Jyoti Karan? I call upon Professor G.B.R.K. Acharya, please. Dr. Lakshmi Balraj. Professor Megha Shambat. You have to change your prefix here to a Professor Nandakumar. Call upon Dr. Silveni, please. Chris, and for our Nepal fellows, Dr. Prabhat Adhikari and Mr. Kavin Varikar, going to be handling it to Jyoti. Jyoti is traveling to Nepal after this. He'll be able to hand it to Kavin and Prabhat. And for all the other fellows who are online, the fellows will be directly shipped. Jihan has been contacting you to get your addresses, so it'll be shipped to you soon after. Thank you so much.
Recording stopped.
I think it's only us.
I think we didn't hear the announcement. Did you hear what I said?
I think it's only us that's online.
Yeah.
Maybe we can say bye-bye to our online friends.
Bye-bye.
Bye. Bye.
Bye, everyone. Thank you for the
Bye.
effort.
Thank you.
Bye-bye.
Thank you.
Bye, everyone. Thank you.
Okay, for everyone. Thank you.
And bye one है ना? अब एम लिभ गर्ने होला नि के भन्छ कि भन्नु अनम्युट छ लिभ गर्दैन
Ladies and gentlemen, distinguished guests and esteemed participants, a very good evening to one and all. Welcome to the valedictory ceremony of the Asia Pacific Aged Care Hub International Forum 2024. Now, I invite our respected dignitaries on the stage. Dr. Shalini C. Nui, Principal and Dean, Ramaya Medical College. Associate Professor Anchi A. Shafi, Dean, College of Business, Government and Medical Law, Flinders University. Professor Raj Shekhawat, Dean, Research, College of Education, Psychology and Social Work, Flinders University. Associate Professor Jyoti K., Flinders University. Associate Professor Andrea Cebula from the Australian Industrial Transformations Institute. Dr. Nandakumar B.S., Associate Dean Research, Ramaya University of Applied Sciences. Now I request everyone to rise for the Ramaya anthem.
Sakalaantaryami Harini Chala Bhajantum Jnanam Vijnanam Cha Bhakti Sahitam ज्ञान विद्या विनय भूषण
ईरामय्य समूह संस्थान
ज्ञान विद्या विनय भूषण ईरामय्य समूह संस्थान तारे निहार के आगने ईमान के जय वेन्नुव ई संस्थान के ದ್ರಷ್ಟಾರರು ಕಟ್ಟಿದ ಕನಸಿನ ಸಾಮ್ರಾಜ್ಯವಿದು
ದೀಪದೊಳು ಪ್ರದೀಪಗಳ ಬೆಳಗುವ ಶ್ರದ್ಧಾ ಸ್ಥಾನವಿದು
ಅರಿವಿನ ದಿಗಂತರಾಚೆಗೆ ಜಿಗಿಯುವ ಸಂಪನ್ಮೂಲವಿದು ಗೃಹ ಗೃಹದಲ್ಲಿ ಗೃಹ ನಿರ್ಮಾಣಕ್ಕೆ ತಂತ್ರಜ್ಞಾನದ ಸೋಪಾನವಿದು ಅಮಿತ ಜ್ಞಾನಕ್ಕೆ ಸಾಧನ ಕ್ಷೇತ್ರವಿದು ಪ್ರತಿಭೆಯ ಸಾಧನೆ ಮಾಡಲು ಸ್ಫೂರ್ತಿಯ ಕೇಂದ್ರವಿದು ಅಜ್ಞಾನದ ಕತ್ತಲೆ ನೀಗುವ ಸುಜ್ಞಾನದ ಸೂರ್ಯನ ರಶ್ಮಿದು
ಜಗದೋತ್ಥಾನದ ಅಂಗರಸನು ಹೊತ್ತಿದ ಅರಿವಿನ ತಾಣವಿದು
ಅರಿವಿನ ಹಣತೆಯು ಬೆಳಕನ್ನು ಚೆಲ್ಲಿದೆ ಅಸಂಖ್ಯಾತ ಕಿರಣಗಳು ಎಲ್ಲೆಡೆ ಹೊರಹೊಮ್ಮಿವೆ ಜಯವೆನ್ನುವ ಈ ಸಂಸ್ಥಾನಕ್ಕೆ
Thank you, everyone. Now I request Dr. Nandakumar B.S. to give the welcome note.
Thanks, Dr. Monica. As the saying goes, all good things must come to an end. But we are feeling that this is just a beginning of a new chapter
new friendship, new bonds that are being built, and new networking that is happening. So I deem it an honor to welcome the delegates on the dais, Dr. Andreas, Dr. Shalini, Dr. Angie, Dr. Raj Shikhawat, Dr. Jyoti, Dr. Madan, all my fellows from APAC, Dr. Shalini Pradeep, seniors from other institute, and postgraduate students, Dr. Suman, Dr. Dinesh, and all the online, if we have the participants, all of them. So this 2 days has been a very good memories that we have built, and the science that has come out of it is extremely knowledgeable. And I'm sure that the learnings that have started now will continue and will certainly make a difference to the aged and aged care sector at large. So without much ado, I would want the proceedings to continue. We again welcome for this valedictory function. Thank you.
Rightly said. We have witnessed the convergence of ideas, the sharing of knowledge, and the fostering of meaningful connections throughout the forum. Together, we gathered not only to celebrate the conclusion of this remarkable forum event, but also to reflect on the insights gained and the paths that lie ahead. Now I request Dr. Shalini C. Nui to say a few words about the event.
Again, wishing you all a very pleasant afternoon. And I'm sure you all, I hope you all have had a wonderful 2 days over here. And I definitely enjoyed, whatever part I could be part of. It was really a very eye-opening experience. And as you may have heard, many of you would have heard of Swami Vivekananda. He was a social reformer, and he was an Indian. And he even was invited to the United Nations to address them. And according to him, he said, "Arise, awake, and stop not until you reach your goal." So that is one thing. And another thing that he said, which I think will apply to this hub, is he said, if on a day you do not come across any problems, if on a day you do not come across any problems, that means you're walking on the wrong path. So don't worry, even if you have problems, you may have difficulties in, implementing all the policies that you discussed, but definitely arise, awake, and stop not until you reach your goal. Thank you, and wishing you all the best.
Now I request Associate Professor Angie A. Shafi to talk about her experience.
Thank you. I just have a few words to say. Flinders University, which is one of the universities involved in this amazing collaboration, has a Making a Difference agenda with the vision to change lives and change the world. The outcome of this forum and the DFAT grant absolutely embodies this vision and has exceeded all our expectations. Coming together as a group of amazing thought leaders with a shared sense of purpose and vision and a set of values will absolutely have an impact on changing lives and changing the world. The research we have discussed will contribute to addressing aged care challenges, not just locally in the 6 communities, but through this amazing collaborations of multidisciplinary scholars, we'll be producing world-class research with international significance for elderly care. Furthermore, we have successfully engaged business, industry, government, thought leaders, and the community, and have built bridges for collaborations that will make a difference both in the short and the long term. This international partnership will not only have significant societal impacts, but through these outcomes, learnings, and collaborations, national and international significance that will truly make a difference. Our founder, Matthew Flinders, has told us to experiment and experiment bravely. So thank you, everyone, for the time, dedication, passion, innovation, and spirit that brought a group of strangers together who have now met and are experimenting bravely and created friendships that will last a lifetime. Thank you to our wonderful hosts for your hospitality and welcome, and may this just be the start of many amazing collaborations ahead.
Thank you, ma'am. Now we have a video clipping from Mr. Reuben Jacob, who is from ARIA and also a member of the APAC Hub.
Thank you everyone for participating in this APAC International Policy Forum at Ramaya Medical College in Bengaluru. Thank you also to everyone joining in on this program virtually from across the globe. I hope you found the last couple of days inspiring, challenging, and as a wonderful learning opportunity. I'd like to thank the Department for Foreign Affairs and Program and this forum. I'd also like to thank Flinders University for their support of this program. I'd like to convey my heartfelt thanks to Dr. Nandakumar and his team at Ramaya for making this International Policy Forum possible in a very short period of time. A lot of hard work and effort has gone into making this forum the success it has been. I'd also like to thank Madan and the entire APAC team for their hard work in delivering this APAC program. I'd also like to thank the APAC leaders and their organizations for participating in this program, making it a rich learning experience for us all. Finally, I'd like to invite you all to the ARIA conference on the 4th and 5th of July at the Adelaide Oval in Australia. It is themed Facing the Future, Living Well, Aging Well, and Dying Well. We're bringing together global experts in the aged care ecosystem for 2 fabulous days of wonderful conversations about the future of aging and aged care. For more information, visit the ARIA website. Thank you.
Thank you, sir, and we look forward to attend the conference. Now I request Dr. Madan Balsubramanian to provide his feedback. I request Professor Raj Shekhawat to give his feedback. Sorry, sir.
Thank you so much. Can I just say that the past 2 days has been absolutely brilliant. Apart from you guys being such fantastic hosts, especially the leadership team, one thing which I absolutely loved was interacting with the students and all the volunteers. I think you all did such a wonderful job. So let's give a huge round of applause for everybody. Well done. The namesake of Flinders University is called Matthew Flinders, and Matthew Flinders was an explorer, and he once said that I have too much ambition to rest in the unnoticed middle order of mankind, and since neither birth nor fortune favored me, my action shall speak to the world. And I almost felt like every single interaction I had with every single person here, be it students, be it volunteers, be it people from leadership, be it fellows, I could see that spark of ambition and the desire to make a difference in each one of you. So please keep that desire burning, and let's just continue to make a meaningful difference in the community. Thank you so much for having us here. Thank you.
Thank you, sir. Now I request Associate Professor Jyoti Khadka from Flinders University.
Thank you very much. Dignitaries on the dais, APAC fellows, and delegates who are actually present here, students, and those who are present on the online. I just want to reflect back on when we actually envisioned this program. We never thought that this will grow like this will be this big, this is going to be this impactful. And a lot of hard work has gone into that. So I'd like to thank especially the Ramaya University for hosting us, hosting just amazing 2 days, and making all of us so comfortable, honestly. And then the knowledge share, the collaboration we made during the 2 days, I think it's just the beginning into making a lot of big difference in Asia Pacific region. And I would also like to thank, honestly, Ramaya University, along with Nandu and his team, who has done the amazing job. I was talking to Nandu yesterday, saying that the program has got so seamless, given that, like, when you look at the format itself, it's actually a program here and virtual program on other 4 countries. And doing that, which is looking at a kind of impossible task, has gone so seamlessly because of him and the team that has actually put this program together. And I was really impressed. We are so impressed, and thank you for that. And I would also like to thank our leader, Madan. Without him, this APAC would have not been possible. Please put our hand together to thanking Madan for doing an amazing job. And we actually really flourished within his leadership. And we look forward doing more collaborative work under his leadership. And we feel like probably APAC will grow much further under his leadership. And we are always there to help and support your initiative on this APAC. Thank you very much.
Thank you, sir. I now request Associate Professor Andrea Sibila to give his views.
Thank you. I can only echo everything that has been said. So thank you very much for excellent organization, for excellent discussions, and for having us here. I do want to end perhaps on a very personal note and tell you really what I learned here. This is my first sort of direct involvement with APAC, and when you spend your working life in Australia, you have a certain perspective, and you come somewhere else and you're reminded there is a difference, that we all are different, we all do things differently, and we have different experiences. So the 3 takeaway experiences for me here. One is, I was absolutely amazed by the multi-jobbing that I learned about. Many of those people who talked in the last 2 days were teaching, researching, actively engaging in service delivery. You name it, the list is long. I wondered, do they need any sleep? No, probably not. How do they cram it all in? How can we mix our minds, adapt our minds, be so flexible to do all these things and apply what we learn and what we teach in real life? Absolutely amazing. And then there are the challenges, the constant reminder that culture matters. The conversations we had about, the word wasn't mentioned here, I think, but stigma, the getting out, reaching out to people, providing aged care, the conversation about elder abuse, how is this communicated? How do we actually know about the challenges? Who opens up to us and the service providers to tell us about their experiences and that they may be in need when there are social barriers to communicate that? And there is the other aspect, and that's the role and possibly the lack of a role of state provision. Many of you told about the out-of-pocket expenses that people have when they require aged care, but also other services, and the lack of a solid infrastructure that we in Australia almost take for granted. And it's an imperfect infrastructure in itself. We have lots of problem with aged care. It's not perfect, but at least we have a foundation and we have a system around that. And here, many stories were about the absolute lack of a coordinated approach, and lots of good souls trying their best to deliver services and make life better in their communities and beyond. And it may be, my impression was it's an uphill struggle, but everyone does it with dedication and good spirit. And these are sort of my personal experience from the last 2 days. It is a helpful reminder for someone who spends his time in an office in Australia that we have joint challenges, but they're all kind of different, but we can work together to overcome those. Thank you very much.
Thank you, sir. Now I request Dr. Madan Balsubramanian to give his feedback.
Thanks, Monica. I'm just going to be standing here because I have some mementos on behalf of Flinders to actually give to everyone. And before that, I would like to share mainly two things. A few months ago, or maybe when we finished the program in Australia, we had an intention to actually run a small policy forum at one location. And we thought Nandu was a standout. And we actually thought, let's do it in India. And let's actually, since we had the largest number of fellows here, we actually thought, let's actually bring it here, the first APAC International Policy Forum. And our vision was very small, just 50 people. And we thought very small budget, and we were actually discussing with Nandu. What has happened, transpired over the next 3 months, I think it's totally unbelievable. We had 3 other nodes participating. From Nepal was interested in joining. Malaysia was also interested in joining, as a node, as well as Philippines. And they're all physical nodes for themselves. And it's not easy to actually organize a physical node in their countries. So, and coordinating that, and we had about 50 to 60 in each of these physical nodes participating. So that was a major job. And they were actually coordinating with Nandu, they were coordinating with Monica, with Aditya, with Naveen, and all his team over here, and lots of things going on. And there was a hub manager across, these 3 hubs, and there was Hurjihan, my research assistant over there, coordinating and trying to bring all the team over there who are actually working on diverse things. So it's been a lot happening, and as Nandu rightly pointed out, something like 6,000 or 7,000 messages or email exchanges together. So it's been a lot of effort. As I said earlier, the first International Policy Forum undoubtedly has been a great success, and I would like to thank the Ramaya leadership for this. Very grateful to Shalini ma'am, to the Vice Chancellor, to the Pro Vice Chancellor, to the hospital chairman, to the registrar, to all the leadership at Ramaya University for hosting us and for making this such a massive a success. For the in-kind support that we got from Ramaya University was absolutely outstanding. And we are very grateful to everyone over here. And we see this as an opportunity. It's just the first step for us to actually build bridges and start looking at higher goals, bigger goals, and bigger achievements from now on. So if I start naming people, it's going to be a very big list. So Anandu and I have actually, saw the list going on to 100 or 200 people perhaps being involved in providing support. So I'll do the best I can over here. And if there are any others whom I've missed, so please do apologize. And we'll get back to you soon after that. And Nandu is here to identify that. So I would like to first actually thank Shalini ma'am, and I would ask Angie to actually give a signed, personalized greeting to Shalini ma'am. Thank you, ma'am. Angie, if you could just stand over there.
Oh, okay.
This one. Just. Can I now ask Angie to actually give a small token of appreciation? This is probably just an extent of our love to Professor Nandakumar. In no measure. So, thank you so much. I would now like to actually invite Dr. Shalini Pradeep. Thank you so much, ma'am, for all the help and for actually putting this together with Nandu. We are very appreciative and very grateful. I do understand Dr. Lalita is actually not here today, but on behalf of Dr. Lalita, if Dr. Suman is here.
Thank you so much, Dr. Suman, for your help. I would like to give Dr. Suman both for Dr. Lalita as well as for Dr. Suman as well. So, this is for Dr. Lalita. Thank you so much, Angie. Can I now invite Professor Raj, please? So we had a number of volunteers, especially, I think, the most standout and really helping us around. I would like to, this is by no measure, a token of what, this is just a token of love. And I think you have done a lot for us. So can I actually ask Dr. Raj to actually first, give a small token of love to Monica, please. Can I now actually ask Aditya? Naveen, if he's here?
Praveen.
Praveen.
Praveen and Naveen.
Yeah, Praveen and Naveen, sorry. And Naveen, Praveen. Got you right? Naveen, okay, sorry. And also to Dinesh, Dr. Dinesh, please. Sorry, I missed your name, Dr. Dinesh. Yeah, I have a lot of names here. And also to the postgraduates from Community Medicine Department, we're very grateful for all the help and the efforts that you have put here. Dr. Vishnu. Dr. Neha Ankit Choi. Dr. Rakshit. Dr. Anusha. Okay. Dr. Shireshwani. Dr. Sopimat Anusha, sorry. And I would also like to thank Mr. Rajaram for providing all the IT support. Ravi. And also to Mr. Om, the secretary to Dr. Dean, who's been very helpful in trying to be so responsive to all the emails. Thank you so much, and coordinating everything.
Yeah, that's okay. We can take it. Yeah, on just
And I'm not sure if I've missed any other names.
We are able. If there are anyone, probably I have to sort of like think of it.
So, thank you so much, Raj. So I would like to wind up by telling that thank you so much, everyone, here at Ramaya and at all our three physical hubs and everyone joining online. I think it has been really great. When I said earlier, I actually stressed on the word first, APAC International Policy Forum, and we are looking forward for the second APAC International Policy Forum sometime soon. So thank you, everyone.
Thank you, Madan. And on behalf of Ramaya Medical College, we have, and the university, small token of love. I would request Dr. Shalini Nui ma'am to hand it over to Andreas. I think I can actually open it and give.
Okay.
To Angie. Yeah, to Raj Shikawat. To Dr. Jyoti. And one to Madan. And for Madan. So both Dr. Shalini ma'am and I will do that. We're very happy. What about the certificates from the institute? Ma'am, we do have the certificates for the fellows. If you can quickly, the fellows who are here for participating in this APAC forum, Dr. Megh Shambat. No, this is for the participation at this thing. So both Angie and you can give the... Dr. GVK Acharyalu. Dr. Lakshmi. Who else is there? Triveni. Yeah. It's in the. It's in the other this thing. Okay. Because they are printed certificates to all of us, including Angie, Nanda, and this thing. Now this is standard format for participating in the thing, so that both to our resume and to the participation certificates. So probably we will share with you after the event. And Dr. Shalini Pradeep had prepared a very elaborate vote of thanks. Yes. Yeah. No, and also we had the paper presentations which were done on both day 1 and day 2. So they have been scored and the prizes are being announced. So Dr. Suman would announce the prizes. Yeah.
Good evening, everybody. For the 2 days of presentation, the papers that were presented, we had scored on conceptual and understanding of the study, knowledge of how the study was conducted, understanding the results and its implication, presentation skills, response to questions, slide aesthetics and slide construction. These were the areas where each of the papers were scored. And on the first day, we had two very close contenders. One was an online presentation and the other one was an offline presentation. So this was for yesterday, where the theme was basically models of care. Today was policy and regulations. We did have a mix of certain things today because the number of papers in that area was little less. Actually, with today's presentation, we have 3 people who have tied at the same score. Dr. Varalakshmi, Dr. Teddy, and Naveen. Sir, I would definitely appreciate your paper on your policy, and also I would like to mention Anu Mohan's press paper. Both your papers were really good. But when it comes to scoring, the judges for the papers were, for the first day was Dr. Shalini and Dr. Sanjay, who's a community medicine specialist. And for today, it was myself and Dr. GVK Acharyalu. So to conclude, I would say that the paper on psychological, let me check where I've written. Okay, the psychological morbidities among older adults and elderly with regard to COVID-19 survivors in rural Karnataka, Dr. Rakshit. This is for yesterday's presentation. I would request Dr. Raj to give away this certificate of appreciation to Dr. Rakshit. One more, sir. And in today's presentation, we had, this is something different which most of us have not generally looked at, whether the environment is age-friendly or not. So we had one of our own postgraduates, Dr. Naveen, looking at it with this presentation. So today's, it says, and okay, there were 2 more online presenters who have also scored. That is, one is Dr. Varalakshmi. She looked at false prevalence and further preventive action. Their certificates would be posted to their thing. And another one from Nepal, Dr. Rubisha Adhikari. Both of them, these were the online presenters who have won this prizes for the paper presentation. And thank you very much for the opportunity you provided. I had opportunity to listen to very good papers and a lot of things I have learned also. Thank you.
Yeah, the curtains have come to a close, and as an extended family, with Madan and Nanda being the focal points, we hope to continue with more collaborations and more discussions. I would like to thank the management, the chairman, sir, for having made his presence felt yesterday. Sir Srinivas Murthy, Madam Dr. Shalini, Principal and Dean, then management of RUAS and Dr. O.P. Karbanda, administrators of Ramaya Hospital and Ramaya Memorial Hospital, the Department of Physiotherapy, fellows and the delegates on the dais, off the dais, the chair and co-chair and the panelists, online and offline delegates also. And the scientific committee was well looked after by Dr. Suman to see that all of us finish on time, though we had to extend it. Yeah. Online sessions, we had very good online sessions without any glitches, thanks to you all, I don't know. And Dr. Dinesh Rajaram for your catering. You have taken personalized care. Thank you. the departments of community medicine, medicine also, and geriatric medicine, the DRP team, which has already been applauded, EDP team also has been applauded, Ms. Ravi is here, photographer Ravi, and the support staff. Without
transport from external
yeah,
has been very helpful.
the transportation was also very well organized, thanks to Aditya. Okay, and overall, we thank each one of you for staying back for the valedictory and being with us. Thank you, one and all.
Thanks to Shalini ma'am for being very
Yeah.
supportive. Thank you. So we have finished 5 minutes early, which is a very good thing. Chef, yeah, have a good food. You can give it to them.
Only one, no?
We have the tea and coffee served outside, so please join us for the high tea.